Hi, hello friends, good morning. Welcome to the Core 6 revision series. I'm Dr. Sumna. Today you'll be learning PSM with me, okay? So first, we'll revise the epidemiology and biostatistics part. So moving on to the first question on screen. So the epidemiological study with population as a unit of study. So which is the epidemiological study with population as a unit of study? The options are ecological study, cohort study, case control study and experimental study. Okay, so the answer for this question is yes, it is ecological study. See, in ecological study, the unit of first study is population, whereas in the other studies, your cohort study, your case control or your RCTs, that is experimental studies, the unit of study is always a individual or subjects. So what is this ecological study? See, for any study design, basically what they do is we have an exposure, we have an outcome, right? So we try to find a relation between this exposure and the outcome. But in ecological studies, you try to find out the relation between the exposure in population and what is the relation of that to outcome in population. It's not in single individuals. For example, here's an example of an ecological study. What they did is they compared the chocolate consumption with the number of Nobel Prize winners within countries. Okay, so it was found that among all the countries, Switzerland had the highest number of chocolate consumption as well as they had the highest number of Nobel Prize winners. So that was the inference they made. But there is an issue with this study design. Okay, suppose this guy who's a Nobel Prize winner from Switzerland, if you ask him, maybe he might not be eating chocolate, right? So that is whatever you have inferred may not be correct in case of individuals, but it might be correct in case of population. This difference or this issue is called ecological fallacy. Remember this term, ecological fallacy. That is an issue in ecological studies. And one more point is ecological studies cannot be used to establish causality. Why we just discussed the reason, right? So now we'll just revise what are the study designs. How do you classify study designs? You have observational, you have experimental, right? Under observational, again, you have descriptive, analytical. Under experimental, you have randomized control trials and non-randomized. We'll just write it down. So your study designs, you classify them as observational and experimental. What is the basic difference? In experimental, the investigator, or if I am investigating, I intervene and I give an intervention there. Okay, I'm doing an experiment there. Whereas in observational studies, I'm not doing anything. It's the nature that is doing. Whatever is happening, you're just observing and then you come at inferences. Okay, so you have observational, experimental. Under observational, you have descriptive studies and analytical studies. Under experimental, you have two types, that is randomized trials and non-randomized. Now, under descriptive, again, what are the studies which are descriptive? You have your case report, case series, then ecological study, and cross-sectional studies. These are all descriptive studies, okay? And under analytical, you have your case control study, cohort study, again, cross-sectional studies. See friends, cross-sectional study can be either descriptive or analytical. For example, if I'm finding out just the burden of a disease, okay, I'm finding out the burden of hypertension alone. If that is my study, it's a descriptive cross-sectional study. But suppose I want to find out the burden as well as the factors associated with it. Or I'm trying to find out whether this hypertension prevalence is more in females or males. So if something like that comes in, then it becomes an analytical study, okay? So under analytical, mainly you have case control and cohort studies. Now another question is, among the study design, which one is used in hypothesis formation, which one is used in hypothesis testing, and which one is used in hypothesis confirmation? So for hypothesis formation, you use descriptive studies. to test your hypothesis, whether whatever your hypothesis is true or not. For that, you make use of your analytical studies or the case control and the cohort studies. For hypothesis confirmation, you have to go for experimental studies or RCTs mainly. So I hope that is clear. Now we'll move on to the next question. So you'll be given a scenario and you'll be asked to find out which is the best study design used for this, or identify the study design. Okay. So the question is, 20 pregnant women were asked about the history of smoking when they came for regular antenatal visit, and then followed up to see how many of them had low birth weight babies. So what is the type of study design used? The options are case control, cohort, cross-sectional and ecological study. Okay. So if such a question comes, first you define what is the exposure, what is the outcome, and what is the direction. Okay. So in this example, what is the exposure? It is the smoking, right? Smoking history in mothers or ANC mothers is the exposure. And what is the outcome? You're seeing for low birth weight babies, whether smoking in the pregnancy time led to birth of a baby with low birth weight. That is what you're going to find out. And they have said that you are following them up. So this term, this is actually a keyword. If there is a followed up, that means it's a cohort study, right? So the answer here is prospective cohort. So we'll see in detail. So when there is an exposure, you start with risk factors and those without risk factors, and then you follow up the group for a long time, and then you find out the outcome. Such a study is a cohort study. Suppose this was a case control study. How would have they asked the question? Suppose if I'm taking babies with low birth weight, and I have who are the cases, and I have a control group with normal birth weight, and then I go backward and I take the history from the mothers, whether they were having smoking while they were pregnant. So if I start from a cases and control, that is diseased and non-diseased, and if I go back and then I search for the exposure, then it becomes a case control study. Here it is from the smoking, that is a risk factor, and without risk factor you have, then you follow them up, and then you find out for the outcome, which is low birth weight and normal birth weight. So this kind of a study is a cohort study. And when you get questions like this, you see the word here, followed up. Follow up is saying in which one? Cohort study. And ecological study doesn't come in play at all, right? Because ecological study is for population. You cannot take this. So the answer here is the prospective cohort study. So again, just the same thing. So mainly, this is where you go wrong. You have cohort studies and case control studies. So in cohort studies, you start with exposed and non-exposed, okay? And then this is how the investigator goes, okay? And then you follow them up and you see how many of them developed disease in the exposed group and how many of them developed the disease or the outcome in the non-exposed group. And in such a study, you get the incidence, okay? You get all the risk incidence, then you get the relative risk, then you have attributable risk, you have population attributable risk. All these risks you get in a cohort study. For a case control study, you start with cases. What do you mean by cases? Whom do you call a case? Case is always a deceased person, right? So in case control studies, always the study should start with the deceased and controls who do not have the disease. So you have disease and non-disease. Then you go back in time and then you compare their exposures, whether this particular risk factor was present in the control and in the cases. So that is how we do a case control study. So now, cohort studies, we have three different types of cohort studies, which are the retrospective cohort, prospective cohort, and ambispective cohort. So always remember, in cohort studies, you always go from the risk factor to outcome. There should be no confusion in this. In prospective studies, just see this part. You have retrospective and prospective studies explained in this diagram. So in retrospective studies, see the risk factor and the outcome has already occurred. You are starting a study here. But then you go back and you see for the risk factor, it is two groups with the risk factor, one group, and the other group without the risk factor. And then you see for the disease outcome. The direction is always from risk factor to outcome, but both the risk factor and outcome has already occurred. This type of a cohort study is called retrospective cohort, also known as non-concurrent cohort. Okay. Next type is prospective cohort. That is a simple one. You're starting here, both the risk factor and your outcome has not occurred. So you're going to, first you'll follow up people with risk factor, no risk factor, and then you follow up them up and you find out for the outcome. So here both have not occurred. So this is a prospective cohort. Now there is a prospective cohort is also known as what? Concurrent cohort. There is one more type of cohort, that is the mixed cohort or the ambispective cohort. Here you are somewhere here, okay? You have risk factor present minus and you go for outcome, and the investigator is somewhere here. Okay, suppose this is 2008, this is 2010 and 2009. So I'm doing my study in 2009, but the risk factors already occurred in 2008. Outcome has not occurred. Outcome is going to occur. So I'm in between the risk factor and the outcome. This kind of a study is called a mixed cohort or a ambispective cohort. Okay. So now you know the study designs and type of cohort studies. Now moving on to the next question. Okay, 30,000 large cohort is followed up for 10 years. Then 50 cases developed and rest controls have been taken. What kind of study design is it? So what do you have here? You have a big cohort going on, right? You have a big cohort of 30,000 people which you are following up for 10 years. That study is going on. So in between that study, that is within that cohort, you're doing a second study or a case control study within that cohort. This kind of study is called a nested case control. Okay. So we'll just see what it is. So you have a big cohort study going on. Okay, this is being happening. Okay, so in between this cohort, if you take some cases and some controls and you try to embed a case control study within the cohort study, that makes up another study. Okay, so there are studies which are embedded within the cohort study. You have two types of studies which you should remember. One is your nested case control, and another one is case cohort studies. So we'll see each one. So here the answer is nested case control study. So in nested case control, you have a defined cohort. So in cohort, you're following up certain people, right? So they have the risk factor and you're seeing whether they are developing a disease or an outcome. So in between while you are following up, some people will develop the disease, some people will not develop the disease, some will take more time. So in a nested case control study, what you're doing is, suppose this is my cohort and one person developed a disease, I take him as case 1 and then I take a control similar to him but without the disease. So I take a control 1 here. Then another person developed the disease, that is case 2. Simultaneously, I take a control group. And then you get cases 3 and 4. For them also, I take controls, that is control 3 and 4. Then case 5, control 5. Okay. So like this, within the ongoing cohort, I get cases and controls and I do a case control study within that cohort. This type of study design is called nested case control study. So there is something else called a case cohort study. This is also very similar to a nested case control study, but there are few differences, okay? In a case cohort study, again, this is also embedded within the cohort. So you have a defined cohort and you get some cases, okay? Case 1, case 2, case 3, case 4, case 5. Those who develop the disease, these are the cases. But instead of taking, control group simultaneously, that is when I develop case 1, I'm not taking control then and there. But I wait, and after all the cases have developed, then I select 5 controls. Okay, here I have 5 cases. So once my sample size have attained, suppose it's 5. So if I got 5 cases and then at a time I just select 5 controls for these cases and then I do a case control study, then that becomes a case cohort study. Okay, so 2 types of case control studies which are embedded within a cohort are nested case control and the case cohort study. So now going on to the next question. So this question involves some calculations, okay? Basically, they are going to ask you the calculate the association. That is, in case control study, you have to calculate the odds ratio. In cohort studies, you have to calculate the risk. Can be relative risk, attributable risk, population attributable risk. So this is a similar question to that. Okay, what is the question? So a study was carried out to find out safety of OCPs. A relative risk or odds ratio of thromboembolism among OCP users to non-users in the given case control studies. So they've given a case control study. So what was done? You have OCP users and risk of thromboembolism. Okay, so your cases are those having thromboembolism and your controls will be those without thromboembolism. Okay, and you're saying for the OCP use in them. Okay, so you're asked to calculate the odds ratio in this question. So when you're asked to calculate odds ratio or relative risk or whatever, the first step is you have to make a 2 by 2 table, and you should not go wrong in the table, because once the table is made, then your calculation is quite easy. Okay, so you see there's a table here. Okay, they've already given a 2 by 2 table, but this is not the 2 by 2 table that you want. Okay, you have to convert the data given here into your 2 by 2 table. We'll see that. So in any 2 by 2 table, this is how you make it. So the disease should come here. Okay, this is the people with the disease should come here. These are the people without the disease, and this side you get your exposure and your those without the exposure. This is the basic format of the 2 by 2 table. Now your work is to fill in this. So what they have given, you have cases of thromboembolism, that is 84 cases of thromboembolism. That is, you have total 84 persons who are deceased. So 84 is the coming here. Okay, and then you have 168 people who are not deceased or who are controls. So that is here. The question is, out of the 84 cases of thromboembolism, 50% have used OCPs. Okay, so what is the number of people who were exposed to the OCP? That is 50% of 84, which is 42. So here obviously it is those who are not exposed but they got the disease. Here it is 84 minus 42, again 42. So in the other group, that is in the control group, you had total of 168 individuals. Out of them, 14% have used OCPs. So here you should come 24, that is 14% of 168, and the rest it is 144. Okay, so your main job is done. You have filled the 2 by 2 table. This should be this column is always disease, those without the disease here, exposure present, exposure absent. Fill up the table. And how do you calculate the odds ratio? Odds ratio is also known as cross product ratio, right? Or AD by BC. Okay, you just do the cross product. So in this case, your odds ratio becomes 42 into 144 divided by 42 into 24, which comes to 6. Okay, so in this question, your answer is 6. 6 is the odds ratio in this question. Okay, so I hope that is clear. So when you're asked to find out the odds ratio, make the 2 by 2 table first and then do the cross product ratio. Okay, so the next question, it is, in a population of 9,000, 2,100 were alcoholic, then 70 alcoholics among this developed cirrhosis and 23 non-alcoholic people developed cirrhosis. What is the attributable risk? So they've asked for attributable risk, and what is the basically what is the study design they're asking about? It's a cohort study, right? You had a big population, out of them a major chunk, that is 2,500 were alcoholic, and the rest of them were non-alcoholic, and then you're following up them, and then you see who developed cirrhosis, whether it is more in the those who had the risk factor or those who did not have, whether it's in the cohort group or the other group. Okay, so here they have asked you to find out the attributable risk. So again, just like the odds ratio, here also when you are asked to find out the any risk, can be relative risk, attributable risk, population attributable risk, best thing is first make the 2 by 2 table so that you don't go wrong. Okay, so here the outcome in this 2 by 2 table, in case control study you had diseased and non-diseased. Here you have the outcome present and outcome absent, right? So this is the outcome present, here you write, those without the outcome you write here. This side you have the exposure present and this side you have the exposure absent. Okay, this is just A, B, C, D. I'm just writing it down for the convenience of the formula. And what is relative risk? The question is attributable risk, I know, but we'll see what is relative risk and how do you calculate attributable risk and what is population attributable risk also in this single question. Okay, so relative risk is incidence in the exposed by incidence in the non-exposed, right? So what is the incidence in the exposed and what is the incidence in the non-exposed? Incidence in the exposed you get by A plus B, right? This is A. This is the out of the exposure you have this much people who had the outcome, okay? Outcome incidence of the disease in A, and then A plus B is the total exposed. And incidence in the non-exposed is how much? C by C plus D. The C by C plus D is the incidence in the non-exposed. So when you ask to find out the relative risk, it is incidence in the exposed by incidence in the non-exposed. So you get it like A by A plus B divided by C by C plus D is the relative risk, okay? So if I get that, suppose the relative risk is 3, then I can say that, how do you interpret it? There is a 3 times more risk of developing cirrhosis in alcoholics than compared to those who don't take alcohol, okay? Now the question here is, they've asked for the attributable risk. So attributable risk you get by, that is actually the subtraction. You get incidence in exposed minus incidence in non-exposed, give you the attributable risk. When they ask you the attributable risk proportion, it becomes incidence in exposed minus incidence in non-exposed divided by incidence in exposed. So basically what attributable risk is telling you is, see, if I get an attributable risk of 30%, that means among the exposed people, the 30% of this disease is due to their exposure, that is due to the alcoholism. Suppose that in that case you are comparing in the exposed only. But if it's a population attributable risk, then you take incidence in the whole population minus incidence in the non-exposed divided by incidence in the population. So in attributable risk, you say this much of the risk can be avoided in the exposed people if this particular this is avoided. But in population attributable risk, you're considering not just the exposed, but also the non-exposed person. So if I get a population attributable risk of 70% in smoking causing lung cancer, that means if I remove the smoking factor, then I can prevent almost 70% of the incidence of lung cancer in this whole population, okay? So population attributable risk is more important for your policy makers rather than the your relative risk or attributable risk. So coming to the calculation here, what is the calculation? We have been asked to find out the attributable risk, right? So we have incidence in exposed minus incidence in non-exposed by incidence in exposed, and the incidence in exposed becomes here when you give the values, this is coming to 70, this is 23. The total here they have told exposure is seen in 2,100 people, that those are alcoholic. The total population was 9,000. So those without the exposure is 6,900, okay? So this is your A, this is your A plus B, this is your C, this is your C plus D, okay? So when you give the formula, you get the answer to 90%, okay? This is the attributable risk in this given question. Now, another concept, you should know what is number needed to treat and number needed to harm, and what is attributable risk as well as what is absolute risk reduction. So, first we'll see what is attributable risk and absolute risk reduction, okay? See, attributable risk, you know, that is the risk that is attributed to this particular exposure, right? That is usually you say attributable risk in terms of harmful exposure, okay? Risk in terms of harmful exposure is the attributable risk. Whereas absolute risk reduction, calculation, everything is almost same as your attributable risk, but absolute risk reduction, you're reducing, right? So absolute risk reduction is said in terms of beneficial exposure. And you have 1 by attributable risk gives you the number needed to harm, and 1 by absolute risk reduction gives you the number needed to treat. Sometimes you might be given questions and instead of asking the attributable risk, they might ask you to calculate the number needed to harm, or if it's a beneficial exposure, you might be asked to calculate the number needed to treat, okay? So the formula is number needed to harm is 1 by attributable risk, whereas number needed to treat is 1 by absolute risk reduction. So how do you remember this? So I have a mnemonic for you. Who is this? ARR, right? A.R. Rahman. So you agree that his music is always beneficial, and you know music is used as a treatment or therapy, right? So remember it like this. So ARR's music is beneficial as a therapy. So ARR for absolute risk reduction, ARR is always beneficial. So comes the beneficial one, and it is needed for treatment, or you can say it is related to number needed to treat. AR Rahman cannot do harm, he can only do good or treatment side. So number needed to treat is related to ARR, and again it is for beneficial exposure. Okay. So what is this number needed to treat? So now you know it is 1 by ARR, right? So in simple words, you do it in case of, for example, in an RCT, where you're trying whether you're trying a better drug or a beneficial drug than what is existing. So if I get a number needed to treat is 4 for a particular drug, how do you interpret it? That means it is the number of patients you have to treat to prevent the additional bad outcome. Suppose if I'm saying to prevent stroke in hypertensive patients, I've developed a new drug and the number needed to treat is 4. That means at least 4 persons I have to treat so that I can prevent a stroke outcome in one person. Okay, that is the simple concept of number needed to treat. So remember, absolute risk reduction or ARR is related to number needed to treat. 1 by ARR is number needed to treat. Whereas the other one is AR or attributable risk is related to number needed to harm. This 1 by AR is the number needed to harm. Remember, ARR, beneficial, music therapy or treatment. Okay. Now coming to the next question. So here you have a cohort study undertaken to study the association between green tea intake and diabetes mellitus. The relative risk they have already given, you don't have to calculate. It is 0.85. What is correct regarding association between green tea and diabetes mellitus? So basically, they've given the study design, they've given the relative risk. You are asked to interpret. This is a NEET-PG last year question. Okay, so the options are green tea consumption increases the risk of diabetes, green tea consumption decreases the risk, green tea consumption has no effect and cannot be determined. So how do you interpret the risk? Either relative risk or odds ratio. Okay. See, when the risk is less than 1, that means there is a negative association and your exposure is protective. This you get in case of, for example, in vaccines. Vaccines is an exposure, right? You're giving it so that you can prevent the disease or you can prevent the outcome. So most in vaccines and all, you get relative risk less than 1, which is beneficial or protective. And if the relative risk is more than 1, that means there is a positive association and it is harmful. You have a higher risk. And if it is equal to 1, that means there is no relation. Okay, there is no risk. So in this question, you have less than 1, right? 0.85 is the relative risk given with regard to green tea consumption and diabetes mellitus. So in this case, you can say green tea consumption decreases the risk of diabetes mellitus. Option B is the correct answer. Fine. Now we are going to the next question. So we have discussed about case control studies, cohort studies, ecological studies, and basic classification of study designs. Now the next question is about RCT or randomized control trial. The question is, all the following are true in RCT except. The options are baseline characteristics of intervention are similar in both arms. Option B, investigators' bias is minimized by double blinding. Option C, sample size required depends on the hypothesis. And option D, dropouts from the trial should be excluded from the analysis. You have to tell me which one is not true, that is true except. So which is not true from these statements regarding an RCT. So what is an RCT? Basically, just like a cohort study, you have a study population. From them you have two groups, like in one group you give the intervention, in other group is your control group. But something you do here is you are giving an intervention, okay? You are giving an experiment or you are introducing an intervention, and there is something called randomization. That is the main thing, or you can call the heart of RCT, or which step is known as the heart of RCT is randomization. This is an MCQ point, okay? So we'll see the options once again. So in an RCT, baseline characteristics of intervention are similar in both arms. Yes, you have a control arm and an intervention arm. You take so that they are similar. The baseline characteristics will be similar. They have to be similar. Then the investigator's bias is minimized by double blinding. Yes, you have three types of blinding in an RCT: single blinding, double blinding, and triple blinding. In single blinding, who's blinded? The subjects. That is the patients whom I'm going to, or my study subjects, they don't know which intervention they are going to get. Okay, somebody I'm giving a new drug, the other group I'm giving an old drug, but they don't know which drug they are going to get. That is single blinding. In double blinding, even the investigator also doesn't know which drug, who is going to get which drug. Okay, that is double blinding. In double blinding, you are preventing the investigator's bias also. Then there is something called triple blinding. In triple blinding, the investigator, the subject, as well as the person who's analyzing the results, all three of them don't know which group has got the intervention, which group has got the placebo or the control drug. Okay, so blinding minimizes investigators' bias. Yes. The sample size required depends on the hypothesis. Yes. In sample size calculation depends on the hypothesis of your RCT. The fourth option is dropouts from the trial should be excluded from the analysis. No, that is the wrong option regarding RCT. Okay. So we'll see what it means. Okay. So suppose there are different ways in which you can analyze the results of an RCT. They are, you can do analysis by, you have intention to treat analysis, then you have as treated, and then you can analyze as per your protocol, that is per protocol analysis. Okay, we'll see what each one is. Okay, suppose I have I have two groups here. Okay, and my intervention is for some disease. I'm trying a new surgery as an intervention, and in control arm, these people are following a medical treatment. So one arm is your intervention arm is surgical treatment, and your control arm is medical treatment. Okay, for example, and here I'm doing my RCT. Fine. And then I'm going to see who has a better outcome, whether it is my surgical group or the medical group. Suppose one person, after beginning of the study, he got afraid and he's saying, no, I don't want surgery, I'll go for the medical treatment. Then you have to allow that, right? You cannot deny that. So this person from here, he shifts here. He goes to the medical treatment, okay? Similarly, suppose one guy from here, maybe he got severe, he got sick or something, and maybe he wanted surgery. Change his mind, so you're putting him here. Okay, so that is, people can drop out or people can actually change their groups. That is one issue with the RCT, okay? So how do you analyze this? So some people have changed their group, some have dropouts. So in intention to treat analysis, you don't mind all this. You analyze the subjects according to the group they were randomized. You have initially randomized people, right? Randomization is the main step of RCT. So you have randomized them into intervention group and your control arm. So you follow whatever has been randomized. You don't mind all these changes that has happened. So when you analyze the subjects according to the group they were randomized, that is called intention to treat analysis. But when you analyze the subjects as per what has actually happened or as per the treatment they actually received, that is called as treated analysis. And then you have a third one, which is per protocol analysis. Okay, in per protocol analysis, you take those subjects who have followed the protocol. That is, those who have changed the groups, those who have dropped out, you just delete all of them, and you do your analysis in the remaining subjects who have completed the study as per the protocol. So you have intention to treat, as treated, and per protocol analysis. And usually we prefer the intention to treat analysis. So the option, because the RCT, the randomization is the heart of RCT, right? So if you don't follow that, then the main purpose of the randomization is gone. So intention to treat analysis is, it preserves your randomization. So the option D is wrong in this. That is, dropouts from the trial should be excluded from the analysis. No, it's an intention to treat analysis. They are not excluded from your analysis. Now we are moving on to the next question. So efficacy of a new drug A is compared with an existing drug B in which of the trial phases? So you have clinical trial phase 1, 2, 3 and 4. So here this question is regarding the phases of a clinical trial. So you know the phases of a clinical trial, right? You have a preclinical phase as well as clinical phase, right? In preclinical, suppose if I want to test a new drug or a new vaccine or anything, I have to do trial, okay? Before you administer your product to the population, to people, you have to complete your whole trial, and then only you can get the approval, and then only you can give your product to the market. So before you start the clinical trial, that is, you start trial on humans, you complete your preclinical trial, usually on animal subjects. And then once that is over, then you go for clinical trial. You have phase 0, phase 1, phase 2, phase 3, phase 4. Okay, you have 5 phases from 0 to 4 in a clinical trial. We'll see each one, okay? So phase 0 and phase 1, both these are done in healthy human volunteers. Phase 0 is nothing but you do a microdosing. You just see the dose and all that, so you just do a microdosing, that is phase 0. So in phase 1, in healthy human volunteers, you try to establish the safety and the non-toxicity of your drug or your product. That is the first thing you do, okay? First, you have to ensure that this thing is safe to be given to other people. So your safety is the most important thing, do no harm. So in phase 1, you establish the safety. So if they ask you which is the phase which establishes safety, it is phase 1. It is done in healthy human volunteers. Usually you have less than 100, 20 to 100 is the normal number of people involved in a phase 1 of clinical trial. Then once the safety is established, okay, this drug is safe. Now you go for establishing the efficacy or the effectiveness. Okay, that is done in phase 2. In patients, here you do it in patients. The phase 0 and phase 1 was for healthy volunteers. Now from phase 2 onwards, you take patients who give consent to participate in your study. So phase 2, it is patients. Here you try to establish the efficacy. It is not actually effectiveness, it is efficacy. Because when you try to see the result in an ideal condition, like in a trial, you call it efficacy. Effectiveness is another term which comes in real life, okay? So here it should be efficacy. And in phase 3, so once the safety is established by phase 1, then you have established the efficacy in phase 2. Now phase 3, what you have to do, you have to compare your drug with the already existing drug, right? So that is done in phase 3. So what is the number of people involved? In phase 1, it was 20 to 100. For phase 2, you need 100 to 500 people usually. In phase 3, usually done between thousands, okay? Thousands to 5,000 people are involved in phase 3. So your question was what? Efficacy of new drug is compared to existing drug is in clinical trial phase 3. It was just, if the question was just to find out the efficacy of the drug alone without this comparison part, then your answer would have been phase 2. If they have asked for the safety, the answer would have been phase 1. So here it is phase 3. So once your phase 3 is over, that is your 0, 1, 2, 3 over, then you can give your drug for FDA or any approval. So once the concerned authority or the body, they approve your drug, then you can give the drug in the market. Then you have one more phase, that is phase 4, which is done in patients after your drug has been given in public, okay? After your drug has been introduced to the public, then you do a phase 4, which is mainly to find out the long-term side effects of the drug. This phase 4 is also called as post-marketing phase, because in phase 4 is done once you have marketed your drug, okay? This is after this marketing phase. So that are the those are the 4 phases, not 4, 5 phases, 0, 1, 2, 3, 4 of a clinical trial. You should not go wrong in this, okay? So your next question is regarding another study, that is meta-analysis. Full name, if you say, it is actually systematic review and meta-analysis, okay? So the question is, all are true regarding meta-analysis except your options are statistical technique for combining the finding from several independent studies on a special topic. Then its purpose is not to identify risk factors. Then the option C is its purpose is to increase the statistical power by increasing the sample size. And option D is the validity does not depend on the quality of your systematic review. So which is false regarding meta-analysis? So what is the meta-analysis? See, when you say the evidence pyramid, right? The studies which give you the higher evidence, that is the meta-analysis. So what is meta-analysis? See, for example, I want to find out the prevalence of hypertension among adolescents in India. That is my aim. Okay, I want to find out the prevalence of hypertension among adolescents in India. So to find out this, what I do is I collect all the studies which are dealing with the prevalence of hypertension among adolescents in India. Many studies might be done regarding this topic, that is hypertension adolescent in India. Maybe I collected 4 studies from Kerala, okay, done by 4 different people where they have assessed the hypertension prevalence in their particular study. Then I get 3 studies from Tamil Nadu. Then I select 5 studies from Assam. Then I get a study done in Delhi. So what I do is I collect all the studies, those who have studied this hypertension prevalence in adolescents. Then I try to find a combined or a pooled value, that is which says average hypertension among adolescents is this much from all these studies. This is what you do in a meta-analysis. Okay. So for that, yes, so meta-analysis is a statistical technique for combining findings from several independent studies on a special topic. Yes, this is what meta-analysis is. Then its purpose is not to identify risk factors. Again, true. Which is a study that identifies risk factors? It is a cohort study, right? Cohort study is the one you do to identify risk factors. You have risk factors and you follow them up. So that is cohort. It is not meta-analysis. Then its purpose is to increase statistical power by increasing the sample size. Yes, your study is highly powered in terms of sample size because in a meta-analysis, I'm combining different studies. So altogether, my sample size is actually very huge, right? So I'm actually trying to increase my sample size. Thereby, I'm increasing the power of the study. But the option 4, the validity does not depend on the quality of the systematic review. That is false. So the option D is the answer for this question. See, the quality of the meta-analysis or the quality of the systematic review you do depends on what all studies I've taken to find out this answer, right? If I want to find out the prevalence of adolescent hypertension, I want to find out the effect. In that case, each study which I take is important. If I'm taking very poorly done studies with a very low sample size or not properly done, then it will affect my result. My final result is also affected by each of these studies. Okay, so your validity or the quality of your meta-analysis depends. Yes, it 100% depends on the quality of each of the studies you're taking. Okay, now we'll talk about some of the limitations of meta-analysis. Okay, first one we just discussed with this question, that is also called garbage in, garbage out. Okay, that is what is GIGO. This garbage in, garbage out. What does it mean? So if I'm doing a systematic review and meta-analysis, if I'm incorporating all poorly done studies or garbage kind of studies, then of course my result would be very bad, right? So if I'm inputting garbage, then I give out garbage only. That is what is meant by garbage in, garbage out. Basically, the quality of the studies, it is reflecting on the final answer in your meta-analysis. That is the first limitation. Second one is called, what is this? Apple and orange effect. So in meta-analysis, you are combining different studies, right? Most of the studies will be different, but we'll have to combine them. That is another thing. Sometimes some studies will be done in, some studies are done in South India, some are done in North India. The characteristics of people, their lifestyle, everything changes, right? From North to South. So you're actually trying to combine apples with oranges, which are not the same, right? So that is another limitation of meta-analysis. The third one is called File-Royer effect. And this one is actually related to your publication bias. So what is this? So, positive results, that is those studies which gave a positive value or a significant value, which your associations became significant, your p value was significant. So you found out there's a significant association between this thing and the outcome. So those studies which have such kind of results, they have a better chance of getting published, right? But there might be studies, there are studies which may not get this significance or which provide negative results. So they, the publishers usually, they have a reluctancy towards these negative studies which don't have a significant values in their results. So what happens is these negative studies are neglected and you get more and more of studies with positive findings. This is called a file drawer effect. That is, the negative studies go into your file draw and your positive studies are getting published. So what happens? This affects your overall output, right? You're getting more of positive studies, then your overall effect will be towards the positive side. So this is called publication bias. So what are the limitations of a meta-analysis? You have garbage in, garbage out, apple and orange effect, and a no file drawer effect or a publication bias. So, okay. Another question is, what is the hierarchy of evidence pyramid? So at the bottom, you have editorials and expert opinions. Then above that, you have case series and case reports. Then you have your case control studies. Then cohort studies are superior to that. Yes. Then above that, you have RCT, and on top, you have your systematic review and meta-analysis. So based on the hierarchy of the evidence pyramid, the topmost one is by the systematic review and meta-analysis, followed by the RCTs, then cohort, and then it comes in that order, okay? And who is this? You should know his name. This was a previous year question. David Sachet is known by father of evidence-based medicine, okay? That is David Sachet. Now you can see another graph on screen, a diagram on screen. You have to identify what this is and you have to interpret this, okay? See, this is what you see on screen. This is called a forest plot, okay? So this is how the results in a meta-analysis are published, or the results in a meta-analysis looks like this. In this graph, they have actually shown the result of a meta-analysis. So this is called as a forest plot. So we'll see this. So there are, suppose the study was to find out, risk between smoking and maybe lung cancer. And they have collected different studies. You have some Smith et al. Then Jones et al. You have different studies here. Okay, each of these things, each of this shows that single study. Okay, suppose in the first one, here you see the odds ratio is given 1.3 and they've given the range. So this, this square here, it represents the result or the association, or the odds ratio of this first study is given here. And this line, it represents the range. Okay, so here it is 1.3 is shown by this square, and the line shows the range, that is 1.5 to 2.6. Similarly, you have for each studies. If I take this last one, Chu et al., then you have the odds ratio of 2.1 given here, and the range is from 1.8 to 2.5. So this is a forest plot, and how do you interpret this? You will be given each studies, and the square in each study is the, the odds ratio or the finding in that particular study. And this line, it represents your range or the 95% CA there. Then this diamond you see here, this is the combined effect from all these studies. What is the, what is the pooled effect of smoking on cancer lung? That is, you're combining all these odds ratios, and then I get a combined effect. This one is your pooled effect, okay? It is shown by this diagram. So this is how you interpret a forest plot. So I hope you'll be able to identify if this diagram is given and you're asked to interpret, okay? Identify. So what is this diagram? Again, this is also another diagram related to meta-analysis. This one, see, it looks like a funnel, right? This is called a funnel plot. You should know that funnel plot is used to find out publication bias. That is the use of a funnel plot. So funnel plot is related to which type of study? Meta-analysis. The use is publication bias. You see in this plot, you see different dots here. All these dots, they represent individual studies. Okay, that is your finding in individual studies are shown by these dots. And here you have your observed outcome. So you have positive outcome here, you have negative outcome here. Okay, see, if there is no publication bias, that is the person who has done the analysis has taken all the studies properly, all studies have been published. So in that case, you get a symmetrical funnel plot. Okay, if the funnel plot is symmetrical, that is, you get almost equal number of dots on both the sides, then there is no publication bias. If your funnel plot is asymmetrical, that is, you see, some studies scattered here. More of the studies are pull towards one side and you get lesser studies here. That is, you see an asymmetry in the funnel plot, then that means there is a risk of publication bias. That is, publication bias is present. So that was forest plot and funnel plot. Now with that, we come to an end of all these study designs. So this is a final table for your revision. You have to answer these questions along with me, okay? So these are some of the keywords or the catchwords which you get in the question. So if you see those words, it is easier for you, to pick up the answer in the NEET-PG or any competitive exam. Okay, so what is the study dealing with the prevalence, burden, snapshot? This is a what? Cross-sectional study, right? Cross-sectional study is also known as what? Prevalence study. So if you see the word prevalence, or a study was done to find out the burden of anemia among this group, whatever. So burden or to find out the prevalence, that is a cross-sectional study. It is nothing but a snapshot. It's like you are taking a photo. At this point of time, you take your subjects and you see how many of them have hypertension, how many of them have anemia, or what is the burden of refractive errors in this group. So that snapshot study is called a cross-sectional study, right? Now the second one, the study which is used to find out the incidence, or the study which involves follow-up, or you're doing to find out the risk factors, or the study which can give the natural history of the disease, which is helpful in explaining the natural history of the disease, or where you can find out where you can study multiple outcomes, and where you get incidence, all kind of risk, relative risk, attributable risk, population attributable risk, which is a study we are talking about. It is a cohort study. Fine, no confusions, I hope. Now the next one is when you want to study multiple exposures, or when there is a rare outcome, or where you do matching, that is, you match between the cases and controls, or where the association measure is odds ratio. It is your case control study. Now you tell me, which is the best study to evaluate intervention and outcome? The best study to evaluate intervention. When it comes to intervention, it is always experimental, right? So the best study to evaluate intervention and outcome is your RCT. When I ask you the best study to evaluate exposure and outcome, instead of intervention, I'm changing the word, it is exposure, you're not doing an experiment, then the answer becomes what? Cohort. Okay. Now, which study is known as the population study? That is a study which has unit of study as a population. That is remember your first question we discussed, ecological study. Then, which is the study which gives the maximum evidence to establish causality, or which is a study where you get forest plot or funnel plot? You get all these in meta-analysis, right? Maximum evidence to establish causality, again meta-analysis, forest plot, meta-analysis. Here I am adding funnel plot also, okay? Funnel plot to find out publication bias and meta-analysis. Then, which are the studies embedded within the cohort? So within the cohort, we studied two different studies which are embedded within the cohort. What are the names? Nested case control and case cohort study. And now the last question is cases, name the study design where cases act as their own controls. Or this one is used in acute events. I have not discussed it here, but you should know, okay? This study where the cases act as their own controls is known as a case crossover design. Okay, remember there is something called a case crossover design, that is for acute events. The same cases act as a control. That is, you got an acute event, so I see the exposure and the outcome, and in the same person I take maybe a few days back. I take him only as the control and I compare. That is the same person act as cases and control. That is a case crossover design, and it is used for acute events. Just remember this. Okay. Now we'll move on to the next question. Now we are going to do some calculations, okay? So the question is, in a population of 5,000 number of new cases of TB is 500. Old cases is 150. What is the prevalence? Okay, so you'll be asked to calculate the prevalence incidence. It's a common question you get in NEET-PG. So what do you mean by incidence? What do you mean by prevalence? Both these are what you call morbidity indicators, right? They help you to define the burden of a disease in a community, in a population. So either you have incidence or you have the prevalence. In incidence, you are trying to find out the new cases. That is, incidence is the number of new cases in a population who is at risk. Whereas in prevalence, it's the new as well as the old cases. That is, what is the current prevalence of the disease. So in prevalence, you have new plus old cases divided by what? Population at risk. That is your prevalence. It's simple, but here what is asked? Here you have been asked the prevalence, okay? So what is the prevalence here? You have, what is the number of new cases? You have 500 plus what is the number of old cases? It is 150 divided by what is the total population is? 5,000, okay? If you do this, you'll get the answer as 13%. So the answer here is option C, 13% is the prevalence. So if the question was to find out the incidence, then you will do only the new cases by total population. That is 500 by 5,000 will be the incidence. So here it is prevalence, they've asked. So again, how do you remember this? See, prevalence, AL. I've changed the color, right? Prevalence is for all cases by population at risk. Incidence, IN, N for new. N is for new cases. So in incidence, you are only calculating new cases by population at risk. Now, and what is the relationship between incidence and prevalence? Remember PID, pelvic inflammatory disease, or PID. P equal to I into T. That is, prevalence is equal to the product of your incidence and duration. So how can you increase? What are the things that increases the prevalence of a disease? So when the incidence of the disease increases, obviously the prevalence increases. When the duration of the disease increases, that is, patients are still there. The duration is more, then also your prevalence will increase. So P equal to I into T is the relationship between the prevalence, incidence and the duration. Okay, now the next question. If a new effective treatment is initiated, that is, you're starting a new treatment, and other factors are remaining the same, which of the following is most likely to happen? When you initiate a new treatment, what will happen? The options are incidence will not change. Option B, prevalence will not change. Option C, neither incidence nor prevalence will change. Option D, incidence and prevalence both will change. So what is the answer here? See, I'm introducing a new treatment here, right? So when I'm introducing a new treatment here, incidence is not going to change. That is the correct answer, right? Incidence will be the same, but the prevalence will change, right? Because I'm introducing a new treatment, so more people can get cured of the disease if my treatment is good. So prevalence will change, but incidence is not going to change. So in this question, your incidence will not change if a new effective treatment is introduced. But if I am trying to introduce a new preventive method or a new vaccine, then I can stop the new cases, right? If there is something which can, stop the new cases, then I can change the incidence. So if it's a new preventive methodology or new preventive modality, then I change the incidence. But here the question is treatment. So that is, your prevalence will change, but incidence will remain the same. You know this, we have already discussed. So if this, this bottle is the total prevalence, your new cases are the incidence. And if there is a death occurring, or if if the disease is cured, then it goes out. So your prevalence decreases there. But when the incidence increases, the prevalence increases. Now you tell me what will happen in these scenarios. When a new treatment cures the disease, there is a treatment which completely cures the disease, what will change? Your prevalence will decrease, right? Patients are cured, they are moving out of this pool. So your prevalence will decrease. When a new treatment prevents death but does not cure the disease. See, there is a new treatment, but it prevents the death. Okay, so patients are not going out, but it does not cure the disease also. It just controls it. In this case, your prevalence will increase. Because the patients their level is controlled, but they are not cured. They are still there. So but their longevity is increasing. Their life expectancy is increasing. So in this case, your prevalence is increasing. This is what is happening in case of diabetes, hypertension, etc. now, right? Because initially people used to die because of diabetes. Now we have good treatments. So death has come down, but those people, they have a more longer life, and the caseload is still there. It is keeping on increasing. So when there is a new preventive modality, that is, you are preventing the occurrence of new cases, you're preventing it there, then your incidence will decrease. New vaccine, this is how you can decrease the incidence. When the incidence decreases, obviously your prevalence will also decrease. Okay, now your next question is, all are indicators of mortality except. So, there are mortality indicators, we have morbidity indicators, and we have quality of life indicators. There are different indicators. So, mortality means death, right? So, which is not an indicator of mortality. Case fatality rates, yes, it is an indicator of mortality. Standardized death rate, again death rate, it is an indicator of mortality. Life expectancy is also an indicator of mortality, even though it doesn't have the term death in it or anything like fatality, mortality, or anything. But life expectancy is a positive mortality indicator, okay? The duration of sickness here, you see, this is a morbidity indicator. This is not a mortality indicator. So your duration of sickness here is the answer here. It is not a mortality indicator, okay? Now, these are some of the indicators of health. See, you should know the formulas for all the indicators. They can ask you to calculate any one of these indicators. Maybe they'll give some values and they'll ask you to calculate the crude birth rate, calculate the case fatality rate, calculate the mortality rate. Anything can be asked. So all these formulas should be by heart, okay? You should know it very clearly. So we know we have the mortality indicators are crude death rate, life expectancy, infant mortality rate, neonatal mortality rate, under 5 mortality rate, maternal mortality, disease specific mortality rate, and proportional mortality rate. These are all your mortality indicators. Out of them, question which one is the positive mortality indicator? It is your life expectancy. Now, which is the best indicator which shows socio-economic development of a country? See, the best indicator which shows the socio-economic development of a country is under 5 mortality rate. Okay. The second best indicator is infant mortality rate. So, in countries with higher socio-economic development, you get a very less under 5 mortality rate and an infant mortality rate. So, it is like a proxy which shows the socio-economic development of a country. So, these are questions which we previously asked. You should know them. Now, what is MMR? This is a very simple thing, very common thing, but students go wrong and it is kind of confusing when it comes for the exam. So there are two things. One is the maternal mortality rate and the other one is the maternal mortality ratio. When somebody asks you to calculate the MMR, it is always the ratio, okay? Otherwise, if it's the maternal mortality rate, that will be specified, maternal mortality rate. If it's just MMR, it is the ratio. So what is the difference? So in both, your numerator is the same. So it is the maternal mortality. That is the number of women who die due to pregnancy related causes. That is your numerator. But the denominator differs in the ratio and the rate. See, when the denominator is women of reproductive age group, then this one, it is the maternal mortality rate. That is the number of maternal deaths in a year divided by women of reproductive age group into 100 or 1000. That is the maternal mortality rate. Whereas in ratio, you get maternal deaths divided by total number of live births in the population. This is the maternal mortality ratio. Okay, your MMR or maternity mortality ratio is denominator is live birth, whereas in the maternal mortality rate, the denominator is women in the reproductive age group. Okay, you shouldn't go wrong there, and you multiply it with, it can be either 1000 or it can be 1 lakh. So if I say the maternal mortality ratio, it can be 97 per, this is how you say, 97 per 1000 live births or 97 per 1 lakh live births. That is how you say the maternal mortality ratio. Okay, don't go wrong in rate and ratio regarding this maternal mortality. Now you have a question. This is how you get questions to calculate your MMR. Okay, so you get, moving on to the question here. So in a town, there are 2,500 live births within 6 months. So during the same period, 5 women died due to peripartum infection, 5 died due to electrocution, 2 died due to obstructed labor, and 3 died due to PPH. What is the MMR? MMR is what? Your maternal mortality, number of women who died due to pregnancy related causes divided by your number of live births into 1000. They have told per 1000 live births, right? So it is into 1000 here. So live births, how much is the live births? You have 2,500 live births. No confusion in that. Denominator is clear. Now what is the number of maternal deaths that has happened, right? See, 5 women died due to peripartum infection. So yes, 5. 5 died, 2 died due to obstructed labor. Yes. 3 died due to PPH. Yes. But you see it here. 5 died due to electrocution. You don't take them. See, this is not a maternal mortality, right? Maternal mortality is defined as a death in a pregnant lady or anyone who's with regard to pregnancy, okay? It can be during the pregnancy period or after, within 42 days post delivery, but the cause should be related to pregnancy. Electrocution or accident, things like that don't come in your numerator of the maternal mortality ratio or rate, whatever. So your MMR here is 5 plus 2 plus 2 divided by 2500. It comes to 10 by 2500 and the answer is 4. 4 per 1000 live births is the answer for this question. So MMR is total maternal death divided by total live births into 1 lakh or 1000. Maternal deaths include which all? Deaths during pregnancy, labor, delivery, even abortion also is considered, okay? Or less than 42 days of birth, provided it is related to pregnancy or complications, not accidents, not electrocutions, nothing like that. It should be related to pregnancy or any complication regarding pregnancy. Okay. Now, there are certain mortality indicators in and around infancy. Infant mortality is there, neonatal mortality is there, perinatal mortality is there. We'll just see it in a nutshell, okay? Infant mortality, what is the term? What is the time period? Infant is less than 1 year, right? So, from birth to 1 year, the rate you get is infant mortality rate. For neonatal mortality, it is first 28 days. That is when you call a baby neonate. So, neonatal mortality is for the first 28 days. Early neonatal death is first 7 days, that is first 1 week. Then after 1 week, that is 7th day to your 28th day, this is the late neonatal death. Then there's something called a perinatal mortality rate. Perinatal mortality rate begins from 28th week of your gestation to first 7 days. That is the early neonatal period plus your 28 weeks to birth, that time. This is the perinatal mortality rate. I'm not going to the formulas of each one. You should know all the formulas and you can get a question where you're asked to calculate these rates. Okay. Now, what is the current infant mortality rate of India, or what is the current maternal mortality rate of India, ratio of India? So you should know these. I've put 5 values in the slide. You should know these by heart. They can ask you this. Okay. This is from the SRS 2020 values. So what is the current neonatal mortality rate of India? It is 20. Neonatal is 20. Okay. Then you have infant mortality rate, that is death less than 1 year of age, 28. Under 5 mortality rate is 32. Your maternal mortality ratio is 97. Maternal mortality rate is 6. Okay, 20, 28, 32. These are the neonatal mortality, infant mortality, and under 5 mortality. 97 is your maternal mortality ratio, and 6 is your maternal mortality rate. You should know all these 6 values by heart. Okay. Now we'll see some of the, we have seen mortality indicators till now. Now we'll see some of the indicators for quality of life. So here you have to learn 2 indicators for quality of life. One is your PQLI, the other one is your HDI. So PQLI is the physical quality of life index and HDI is the human development index. See, all these indicators have certain components, right? So you should know both these are quality of life indicators. They help you to compare the quality of life between countries. So suppose I want to find out the quality of life in India and Bangladesh. Then I take this as an index and then I see, okay, India is having a better HDI. So the quality of life is better in India. Suppose I take India with US. US has a better HDI, better PQLI. So their quality of life is higher than that of ours. So that is the use of these quality of life indicators. You have PQLI and HDI. PQLI is not used now. Okay. At present, you use only HDI, but you can get questions from both. So you should know the components. Okay, PQLI, the components are life expectancy at 1 year of age, infant mortality rate and literacy rate. These are the components of your PQLI. And what about the human development index? It has one more thing, that is the income. Okay, for HDI you have life expectancy at birth. It is not at 1 year of age, it is at birth. Then you measure the knowledge. That is just like in PQLI you have literacy rate. Here you have your knowledge. It is combined, it is calculated by the mean years of schooling as well as the expected years of schooling. This gives you the knowledge part of HDI. Then you have the gross national income. See, how do you remember this? See, human developmental index, right? See, for human to development, first thing, we have to be born, right? So at birth, life expectancy, one thing. Then you should, for development, you have to have education. You should have knowledge. So that is the second thing, knowledge. That is your mean years of schooling and the expected schooling years. Third one is you should have money, or you should have a good job which gives you good money. That's income should be there, right? For development, you should be born, you should have education, you should have good income. This is how you develop, right? So HDI has life expectancy at birth, knowledge, and you have your gross national income. Okay, I hope that is clear. And what is the range? Forgot to tell you that. PQLI, the range is 0 to 100, whereas for HDI, it is 0 to 1. At present, we don't have PQLI, we have HDI. You know, for India, the value is 0.64 for HDI, and the rank, rank is 132 among the HDI, Human Developmental Index, among different countries. Okay, one question that was previously asked is, infant mortality rate is part of which of the indicators? And the options were, one was Human Developmental Index, one was PQLI. So obviously, the IMR is part of PQLI and it is not a part of HDI. This was a previously asked question. Okay. Now we'll take a short break. So welcome back, guys. Now we'll see, we have seen some quality of life indicators. Now let's move on to two other indexes. One is your multidimensional poverty index. Second one is your global hunger index. You can get questions from both of these, okay? First, we'll see what are the components of the multidimensional poverty index. So the components of multidimensional poverty index are health, educational, living standard. Okay, it is based on these three domains, that is your health, education, and living standard, that the multidimensional poverty index is calculated. And this also helps to compare the different countries of the world. Okay, so under health you have nutrition and child mortality. Under education they basically check for the years of schooling and the years school attendance. Then under living standards you have different things. Okay, cooking fuel, sanitation, drinking water, electricity, housing, etc. You don't need to know the all the details of these things, but you should remember that the main three components are: one is health, education, and living standard. Health is assessed by nutrition and child mortality. When they say child mortality, it is always the under 5 mortality rate in almost all these indicators. Okay, so how do you remember this? The components of multidimensional poverty index. The mnemonic is SHE. S for standard, H for education, H for health, and E for education. She has good standard education and a good health. Okay, so she is a mnemonic for multidimensional poverty index. Standard of living, health, education. I hope that is clear. Now the next question. This is actually a potential question they can ask you more than the multidimensional poverty index. This is the global hunger index. Okay, GHI stands for global hunger index. So global hunger index is calculated by the combination of three different things, which are there. One is your child mortality, one is your child undernutrition, and third one is inadequate food supply. So two things related to child, that is your child mortality and child undernutrition. And one thing is about the inadequate food supply to the population. It's not just related to the child part, okay? In this, your child mortality, it carries 1/3 of the weightage while calculating GHI. Your inadequate food supply carries the other 1/3. And child undernutrition is basically assessed by two things. One is your wasting, the other one is your stunting. Okay, child undernutrition, wasting 1/6, stunting 1/6. Then only the whole child undernutrition becomes 1/3, right? So you have child mortality, child undernutrition, which is assessed by wasting and stunting, and the inadequate food supply. So these are the components of the global hunger index. And India is at a very bad rank. We have rank of 111 out of 125, which is calculated, which is inferred as serious hunger. And the index is actually 28.7. Okay. So how do you remember this global hunger index? See this image here. This image should go into your mind. Whenever you hear global hunger index, this image should come. So there is a child. Child is malnourished. Okay. So you have child malnutrition here. See, he has no food. He has a very inadequate food here with him. So one is your child malnutrition, inadequate food. So what is behind him? See, death. So child mortality. So these three are the components of your global hunger index. Child malnutrition or undernutrition, basically, inadequate food, and your child mortality. Okay. So that was about the indexes. We have discussed mortality indicators, quality of life indicators, and the poverty, that is the multidimensional poverty index, and the global hunger index. Okay. Now we'll move on to another question. This is actually calculation. This also, they've asked you to calculate the case fatality rate. This is a commonly seen question in NEET-PG exam. So the question is, in an outbreak of cholera in a village of 2000 population, 20 cases have occurred and 5 have died. Calculate the case fatality rate. So what is case fatality rate, or also known as CFR? The case fatality rate is, it is the number of deaths due to a particular disease divided by the total number of deceased people into 100. Okay, so you have 100 people, out of them 5 died. You have 100 people with cholera, out of them 5 died of cholera. Then it becomes 5 by 100 into 100. Okay, so that is the case fatality rate. So what is the value given here? What is the number of people who have the case? So out of this population of 2000, 20 cases are there. Okay, so the total cases is 20. How many have died? 5. So that is 5 above and 20 into 100. So this comes about how much? 25, okay? So your case fatality rate is 25%. And another term is survival rate, okay? They can ask you the survival rate instead of case fatality rate. See, survival rate is 1 minus case fatality rate. Survival rate is 1 minus case fatality rate. So in this question, if your question was to find out survival rate, it will be 75%. Yes, 1 minus 25 or 100 minus 25%, which is 75%, okay? So case fatality rate is, once again, I'm repeating this because it's very important. Number of deaths due to a particular disease divided by number of cases of that disease into 1000. Here they have given, total population. This 2000 is actually not needed in this question. It can actually confuse you. So the formula is number of deaths due to a particular disease divided by number of cases of that disease into 100. Sorry, it's not 1000. Into 100 is your case fatality rate. And your survival rate is 1 minus CFR. Clear? Now we'll just see the case fatality rate of some diseases. For rabies, it is 100%. That is, rabies is 100% fatal disease. For yellow fever, it is 80%. For Japanese encephalitis, it is almost 30 to 35%. That is, and for chickenpox, it is less than 1%. In simple words, case fatality rate, it describes the killing power of the disease. What is the chance that you will die if you get the disease? That is what is case fatality rate. Okay. Now, another question is, which can actually confuse you, is secondary attack rate. See, the question here is, I'm going to the question, read along with me and also try to solve it along with me, okay? A couple has 4 children, all unvaccinated for measles. A child got measles on 5th April 2015. 2 other children developed measles by 15th August 2015. What is the secondary attack rate? So what is secondary attack rate? See, secondary attack rate is the number of people, number of the secondary cases who get the disease from the primary case divided by the total number of susceptible contacts. So in a population, there are certain susceptible people. Out of that, see, I am the primary case. I come to that susceptible population. I spread this disease to some of them. So how many of the susceptible contacts get the disease? That is, they are the secondary cases. How many of them get the disease from me, who is the primary case? That is your secondary attack rate. Okay. So in this question, in this question, there's a house, a couple. This is the mother. This is the father. They have how many children? 4 children. 1, 2, 3, 4. They have 4 children. And one of them develops measles. And he gives the disease to 2 of his siblings. And now you are asked to calculate the secondary attack rate. So it is the number of people, number of secondary cases who develop the disease. How many develop the disease? 2 other children developed, right? So it is 2 divided by total number of susceptible contacts. This is where you go wrong. So in this example, they have told that all the children are unvaccinated for measles. So let's assume that the parents are vaccinated, or either they've got the disease or they are vaccinated. That is, they are not susceptible, okay? So you don't have to add them in your denominator. So here, the susceptible population contains 3 of the siblings. See, all 3 of them are susceptible. Out of them, 2 got the disease, okay? So your denominator is 3 into 100. This is the secondary attack rate. And the answer comes to 2 by 3 into 100 is how much? 66%, okay? So secondary attack rate, the formula is there on screen. Don't go wrong in this. Number of exposed person developing disease within the range of that incubation period divided by total number of exposed susceptible contacts. That is the keyword there, susceptible, into 100. That is your secondary attack rate. We'll just see the secondary attack rate of some diseases. Again, this can be asked as a question. You can either get a question where, just like the one we did now, where you're asked to calculate the secondary attack rate, or they can directly ask you the secondary attack rate of some diseases, okay? For smallpox, it is around 30 to 45%. Measles, it is more than 80. Measles has a high secondary attack rate. Again, chickenpox also have a high secondary attack rate of 90%. Mumps, it has 86, pertussis is 90%, okay? Now, last year or the year before, there was a question that which one, whether it is measles or rubella, which of the disease has a higher secondary attack rate? You can go wrong thinking that is measles. No, the answer is rubella. Okay, the secondary attack rate of measles is actually 80%, 80 to 85%. Okay, for rubella, it is like that of chickenpox, it is 90%. So the secondary attack rate is more for rubella. So you should know the secondary attack rate of some diseases by heart. You should know it because you can get questions like that. Okay, now the next question is, this is not a calculation. Okay, simple question. True regarding point source epidemic is dash. Option A, secondary waves occur. Option B, there is a rapid rise in the wave which flattens or which plateaus. Option C, all cases occur in a single incubation period of the disease. And option D, it is propagative. Yes. So first tell me what is epidemic? What is the difference between? We'll go to the answer. Before that, I want to make sure that all of you know what is epidemic, endemic and pandemic. What is endemic? Endemic is the constant presence of a disease in a region. For example, common cold. Common cold is endemic, right? In India, in Kerala, everywhere. It's endemic. That is always you have a certain number of cases present. That is endemic. Epidemic is when there is a increase in number of cases from what is expected. Okay. Normally, I get 10 cases or something of a particular disease, but this time I'm seeing an increase from what is seen normally. I get 20 cases, I get 30 cases or something like that. Then it becomes an epidemic. Okay, when this epidemic, when it crosses national boundaries or international boundaries, and it becomes what? A pandemic. Your Nipah was a epidemic, right? There was an increase in number of cases. You don't see Nipah usually in Kerala, right? But there was an increase in number of cases in Kozhikode district of Kerala. So that is an epidemic of Nipah. Whereas COVID, it was pandemic. It was crossing boundaries. It was seen internationally. So that's a pandemic, okay? Now your question is not that. Your question is regarding point source epidemic, okay? See, you can classify epidemics into different types. So one is, how do you classify epidemic? These are all the, you can see on screen, these are all the different types of epidemic. You have point source epidemic, okay? Then you have what? Your continuous common source epidemic. It can be either continuous or intermittent, okay? Point source, then you have your common source epidemic, and then you have your what? Propagated source epidemic. See, we'll see each one of this with an example, okay? Point source epidemic is, the epidemic occurs at a point, at a starting point. For example, food poisoning. All of us went to a party. We had a food there, which was, it had a salmonella in it. So all of us got food poisoning, okay? So that is from single exposure. That is in one incubation period itself, you get all the cases, okay? Whoever attended the party, within that incubation period of the salmonella, all of them will develop as cases. So that is a point source epidemic. And how does the curve look like? It looks like this, right? That is, there is a curve rises and it falls. Everything occurs in one incubation period. You don't have any secondary waves, okay? From a point source, rises, falls. That is a point source epidemic, okay? And in a continuous common source. So common source can be that source is very common and it's all continuous, it's always present. For example, people taking water from a contaminated well. All the villages are taking water from a contaminated well. That well is actually a continuous common source, okay? So what happens is some people develop the disease, some people don't develop. So what you get is, you get a graph like this. The second one you see here, you keep on getting, different, this is how it looks like, right? This is how a continuous common source epidemic graph looks like. You get different secondary cases here. And in case of continuous intermittent sources, almost similar, but there are, gaps. It is intermittent, continuous here, but like it is intermittently occurring. And then the third one is a propagated source. Propagated source is the one you get in, when there is person-to-person transmission. That is, I get the disease, I give it to other people, they give it to 4 other people. It's propagating, okay? So here you get like this, See, it keeps on increasing. And then there attains a point when almost everyone, all the susceptible people in the population already got your disease. So in that case, when it comes to a plateau, it steadily comes down. Okay. So that is a graph of a propagated source. So once again, point source, we get all the diseases in one incubation period, sharp rise, sharp fall. Example is your food poisoning or Bhopal gas tragedy. This is an example for a point source, right? Continuous common source, contaminated well. You can think of that as an example and answer the questions. And propagated source is all your, infectious diseases with person-to-person transmission. Your COVID, then hepatitis A, polio, everything comes under this propagated source of epidemic, okay? So now coming to the question, what was the answer here? True regarding point source epidemic. Secondary waves occur. No, secondary waves you don't see in point source. It's just a single wave. There is rapid rise in the wave which flattens. No, the one which rises and then flattens. The plateauing is seen in different propagated source. No, so it is not there. All cases occur in a single incubation period of the disease. Yes, that is the answer. It is propagative. No, it is not propagative. So point source epidemic is where all diseases occur in one single incubation period. So here I've given the main features of the point source epidemic. Just read it along with me. So epidemic curve rises and falls rapidly with no secondary waves. Epidemic curve tends to be explosive, and there is clustering of cases within a narrow interval. It's within that incubation period. And all cases develop within one incubation period of the disease. Clear? You can expect a question regarding this type of epidemics. Either they can give you a case scenario like we just discussed, or they can even show you that graph, that picture, and then usually you will be asked to identify which is the type of the epidemic. So you should be familiar with, see, these diagrams should be there in your mind. Now, next question is, Hawthorne effect is seen in which of these studies? The options are case control study, cohort study, cross-sectional study, and retrospective study. Retrospective cohort study. So what do you mean by Hawthorne effect? I'll just show you a simple diagram, okay? That will make you understand what is Hawthorne effect. See, this is a classroom. You see picture 1 and picture 1. Picture 1 and 2. In the first photo, you have no teacher there. There is no one to monitor them. There is no one to see them. So children are all, playing around, running around, climbing on the bench and all that. So it's all a chaos happening there. But when the teacher comes in the second picture, see, all of them are sitting properly. See, once they know that they are being observed or somebody is monitoring you, you tend to show your very good behavior. You don't show your bad behavior outside. This is exactly what is meant by Hawthorne effect or attention bias. So this usually occurs in studies where you follow up people or you monitor people, which is a study which involves following up people or monitoring people. It is cohort study, right? Cohort study, you have two groups, you follow them up. And if the person know, or if your study subjects know that they are being observed, they tend to change their behavior. They tend to change their original behavior. This is called Hawthorne effect. It is also known as attention bias. Okay. So that is Hawthorne effect or attention bias. That is the study subjects tend to change their normal behavior once they know that they are being observed by the investigator. Okay. So now the other one is one more question which is frequently asked is about the Bergsonian bias or the Bergson bias, or also known as the admission rate bias. This is a bias that occurs usually due to the difference in rate of admission in certain hospitals. Okay, see, the kind of patients coming to maybe AIMS Delhi is not similar to the kind of patients coming to some other private hospital. You cannot see each hospital has a particular set of patients coming, right? So that differences can affect your study. For example, I'm doing a case control study where my cases are patients with salpingitis, okay? I have salpingitis patients as cases and those who don't have salpingitis as my controls. And I'm finding out the relation between the exposure, that is IUD, that is whether inserting an IUD is a high risk, or whether the salpingitis is more in IUD users compared to non-IUD users. That is what I'm going to try out. Okay. So here, when I take cases of salpingitis, I usually go and check what was your IUD exposure, right? But if it's, and then similarly, those who don't have salpingitis also, I'll go and ask for their exposure, whether they had a IUD or not. Okay, this is what I'm going to do. Suppose in this hospital, see, people in the doctors are very good at IUD insertions, and usually people tend to come to the same hospital, right? There are certain, so like I have some particular hospital which I like to go, which I'm more convenient at, so I always go there. So here in such a kind of study, the cases are, you're expecting more of IUD use in the cases, right? And but here, if the patients, even if the controls or in the general patients coming to that hospital, they are like more of IUD users, then your result will be biased. No, because if IUD has an effect on salpingitis, then what do you expect? The cases with salpingitis will be having more IUD use. But in this case, if the controls are also more users of IUD, then you get a biased answer. So this is called Bergson bias or a admission rate bias. Okay, this the bias due to differential rate of hospital admission. Okay, now another question, which is a study design which usually see most of the biases. It is actually case control study. Okay, because case control study, one of the major drawback of case control study is that it has different biases in it. Okay, now one or two name biases you should be able to know. Generally, you classify biases how information bias and selection bias. And another question they can ask you is, what is differential recall bias? Okay, what is this? Differential recall biases, again seen in case control studies, is when the cases remember the exposure more than the controls. For example, if I want to study history of rubella, congenital rubella syndrome, that is my case control study. I'm seeing whether the infection, the rubella infection, had led to, or any fever has led to this congenital infection. So when I go and ask mothers who have babies with this congenital anomaly, they'll remember everything. They'll remember everything from their pregnancy, because they'll be thinking by themselves, why is that my child got this disease? So they tend to remember each exposure. If I ask them whether you had a fever thrush or if you had an X-ray exposure, they remember more, better than the controls. The controls are those with normal kids. They might not remember all the exposures, or they don't give much attention to that because they have a normal child. So that is the differential recall bias or the recall bias. Okay. Now we'll move to the next question. The question is, the most difficult criterion to establish causal association in etiology of a disease is. So there are certain criteria which are known as, Hill's criteria of causation. That is, any study, you are basically trying to find out a causality, right? Whether this exposure has caused this outcome. So for finding out the causality, there are certain criteria. So you have to know these criteria. And the question here is, which is the most difficult criterion to establish causality? Okay, the options are temporality, strength of association, specificity of association, and biological plausibility. We'll see what each one is. Okay, what do you mean by temporality? Temporality is which came first. That is whether the exposure has occurred before the outcome, because that is one thing which points towards the causality. If the risk factor has come first and then the outcome has occurred, then there is that, the temporality is maintained. So that is one thing. Strength of association is measured by your different measures of odds ratio, risk ratio, relative risk. All these give you strength of association. Biological plausibility is just whatever I'm telling, is it biologically plausible or not? Whether there is whether you have a biological or a scientific explanation to whatever I'm going to say. When I say smoking causes lung cancer, biologically I can say smoking, the content, the tobacco can damage the cells in the lung, and then it can change to nucleus, it can cause the cancer. So that's biologically plausible. Okay. And the option here, the answer here is specificity of association. Specificity of association means I should be specifically saying that this risk factor is the cause for this disease. That is, it is only smoking that is causing lung cancer. So that is actually very difficult to establish in all kind of studies. So the most difficult criteria is specificity of association. Okay. What are the other criteria? So you should know these. What are the criteria? What's it called? Here there's a Hill, right? These are the Hill's criteria of causation. You should know the criteria and you should know what each one means, okay? You have temporality, then you have strength of association, specificity of association, consistency of association. That is whether it is replicable. If I do the study in some other place in the same way, I should get the same result. Biological plausibility, coherence of association. Coherence is whether whatever you have done, whatever is your result, is matching with the already existing knowledge or existing literature. Dose response relationship. That is when you increase a dose, there is a more response. If I smoke 1 cigarette and my friend smokes 5 cigarettes, he has a higher chance of developing lung cancer than me. When there is dose increase, then there is a higher chance of the outcome. That is the dose response relationship. Then you have cessation of exposure, reversibility. That is when I stop the exposure, the change is reversible. That is not true in all cases, but again, that is also one of the Hill's criteria for causation. Okay. Now the next question, this is actually from infectious disease epidemiology. The question is, the time taken for 50% of patients to develop the disease following exposure to the disease is known as. What is the time taken for 50% of the people in the population to develop a disease? Options are incubation period, median incubation period, serial interval, and secondary attack rate. It is not secondary attack rate, right? We have already discussed in detail what is secondary attack rate. You know that. I'm not going to repeat it. Then, what do you mean by incubation period? Incubation period is a time when the agent, the organism, enters your body to the time when you develop your first sign or symptom. Okay, the time, that is the time between the entry of the organism into your body till you develop your first sign or symptom. That is the incubation period. Serial interval is when there are no different cases, primary cases, secondary case. Serial interval is the time period between one peak and the other peak. That is the serial interval. That is one wave and the other wave. And the answer to this question is your median incubation period. Okay, median incubation period is the time when 50% of the people develop the disease. The answer here is median incubation period. So here is a diagram. Okay, here you have, this is your incubation period. Okay, you see here, that is the time the infectious agent enters your body with the first sign or symptom. That's your incubation period. Then the period between this primary case and the secondary case, both these peaks, that is your serial interval. Then you have something called a latent period. Latent period usually we say in terms of, non-communicable diseases instead of incubation period. Sometimes it is used interchangeably. Okay, so you should know what is all these. Okay, that can be asked. Now, the next question is, in measles, the infective period is how much? The options are actually confusing. 3 days before and 4 days after the appearance of the rash, 4 days before and 3 days after the appearance of rash, 4 days before and 4 days after the appearance of rash, and 5 days before and 4 days after the appearance of rash. So when you come to communicable diseases, I know you have to learn a lot of communicable diseases, but questions like this can be asked. Okay, you will be asked to find out the what is the incubation period of a particular disease, what is the period of communicability of the same disease, or maybe what is the isolation period, how long should you isolate a patient of a particular disease. These are all potential questions that are usually asked. Sometimes you'll have to learn some things, but at least for the common diseases, you should be knowing these values. So for measles, it is actually option C. That is, a measles patient is communicable, or the infective period is actually 4 days before to 4 days after the onset of rash. That is the infective period of measles. Now, so this is a definition of period of communicability. It is a time during which an infectious agent may be transferred directly or indirectly from an infected person to another person, or from infected animal to man. It's not just person to person, okay? It can be either from an infected animal to you or from an infected person to animal. Anywhere around, that is the period of communicability when I can spread the disease to others. So now I've made a table of some of the diseases which you should definitely learn. The period of communicability of these diseases listed here should be by heart to you, okay? And because these are frequently asked questions. So how are you going to learn this? We'll just learn with 3 numbers, that's 2, 4, 7, okay? So we'll start with influenza. Initially, I've listed some viral diseases. So usually viral diseases, the period of communicability is, in general, it is less compared to bacterial diseases, okay? So first we'll study influenza. chickenpox, then your MMR, measles, mumps, rubella. Okay, this much we'll study first. So for influenza, the period of communicability is 2 days before to 1 to 2 days after the onset of what? Symptoms. This line, consider this line as the onset of symptoms, okay? So it is 2 days before, 1 to 2 days before to 1 to 2 days after the onset of symptoms is the period of communicability for your influenza. For chickenpox, it is 2 and 4, okay? That is 2 days before the onset of rash. Chickenpox, what do you get? It's a rash, right? So 2 days before the onset of rash and 4 to 5 days after the onset of rash is for chickenpox. For measles, it's 4, okay? We just discussed now, right? So 4 days before the onset of rash to 4 days after the onset of rash is the communicable period for measles. Now, when it comes to mumps, it is 4 and 7, okay? 4 days before the onset of rash to 7 days after the onset of rash, okay? And for rubella, it is 7 and 7. 7 days before the onset of rash and 7 days after the onset of rash. So you just repeat it along with me. Influenza, it is 2 days before the onset of symptom to 2 days after the onset of symptom, 2, 2. Chickenpox, 2, 4. 2 days before a rash and 4 days after. Mumps, 4, 4. Sorry, measles, 4, 4. Mumps is 4 and 7. And rubella is 7, 7. Okay. So I hope that part is clear. Now we'll come to polio. Polio is also similar to rubella only. That is 7 and 7. The 7 days before to 7 days after is the usually the period of 7 days before the symptoms and 7 days after symptoms is the period of communicability. But you should know that in polio, the virus can be excreted through feces for even for 2 to 3 months or 2 to 3 weeks. It can be excreted to the feces. That is also there. And for diphtheria, it is usually 4 weeks, 3 to 4 weeks after the onset of symptoms. Okay, till now we were talking about days. Okay, this is all days, 2 day, 4 day, all that. From diphtheria, now diphtheria and pertussis, it is not in terms of days, we are talking in terms of weeks. Okay, so diphtheria, it is 4 days from the onset of symptoms. For pertussis, it is 1 week before the onset of the pertussis or the particular symptom of the cough, and 3 to 4 weeks after. Okay, so that is clear. Now, what about tetanus? So this is a tricky question. Okay, there is no period of communicability for tetanus. Tetanus does not transfer from person to person, right? It is infective disease, but it is not communicable. So there is no point in asking the period of communicability for tetanus. Right. Now, next is a very simple question. Question is, which is the indirect mode of transmission? So you have modes of transmission can be direct mode when there is direct physical contact, or it can be indirect mode where there is no direct physical contact between the infectious person and the secondary case. So the options are hand contact, through placenta, vector-borne, dog bite. Vector-borne is the answer here because in vector-borne it is a indirect mode, right? The hand contact part, direct mode of transmission, through placenta, of course, even dog bite. These are all direct modes of transmission, okay? So here's a table. Just reading it, don't confuse it, you can get questions like this. So direct transmission is direct contact, droplet infection, soil contact, then inoculation of the agent through your skin, mucosa, or vertical, that is from the mother to the baby. These are all direct modes. Indirect can be vector-borne, airborne, fomite-borne, or these are all indirect modes of transmission. And so the next question is, what is a confounding factor? Again, confounding factors mostly related to the epidemiological study designs. So the question is, basically they're just asking you the definition of a confounding factor, okay? So option A, factors associated with both the exposure and the disease and is distributed unequally in study and control group. That is option A. Option B, factor associated with exposure only and is distributed unequally in study and control groups. Option C, factor associated with both the exposure and the disease and is distributed equally in study and control groups. And option D is factor associated with the disease and is distributed equally in study and control groups. See, the correct answer here is option A. That is confounding factor. This is actually the definition of confounding factor. Is a factor that is associated with both the exposure and the disease or the outcome. Confounder is associated with as a variable that is associated with both the exposure as well as the outcome and is distributed unequally. It is not equal. Okay, the distribution is unequal in the study and control groups. So this is the answer for a confounder. Okay, now the idea that the concept of confounding factor should be very clear to you, because you can get different questions on that also. So I'll just explain it simply with an example. Okay, so here my exposure is actually outcome. I have coffee as my exposure and I have cancer of pancreas, CA pancreas as my outcome. Okay, so I'm finding out whether the drinking of coffee, coffee consumption is linked to a development of pancreatic cancer, whether there's a risk for coffee drinkers that they'll develop pancreatic cancer later on. That is my study. Okay, so here the confounding factor coming to play is smoking. I told confounding factor will have association with, will be related to both your exposure as well as outcome. Smokers without coffee, they have a chance of developing CA pancreas. It's a known risk factor for pancreatic cancer. Then it's already known that smokers have a higher chance of coffee consumption also. So the confounder here is actually related to both your exposure as well as outcome. And the third point is it does not come in the causal pathway. This is the causal pathway. Okay, you see here this pathway, that is coffee causing cancer. This is the causal pathway. Your confounder will not come in this pathway. Okay, it is an alternate way, but it is related to both your exposure and your outcome. And what are the ways in which you can remove a confounder? When you have a study, you have to make sure that these factors, all the biases, all the confounding factors are taken care of. Only then we can actually rely on the result of your research. You bring out a research. If it is there are many confounding factors, many biases, then there is no, the results are not trustworthy. So all researchers have to do things which take care of all the confounding factors on the biases. So how can you remove a confounder? There are certain steps to remove a confounder. One way is stratification. So you stratify the people, that is, you group them into, you find out the same exposure in people who smoke and in people who do not smoke, and then you find out whether this relationship actually exists or not. So one is stratification, then another one is your randomization, your matching, and then there are statistical methods like regression, where you can adjust for these confounders. These are all ways to remove your confounding factor. There is another variable, another term, that is effect modifier. See, effect modifier is, here you have, suppose factor A, asbestos. In the study, I'm trying to find out the relation between asbestos and lung cancer. And here, smoking acts as an effect modifier. That is, asbestos will cause lung cancer, that is exposure to asbestos. But when there is a effect modifier, what it does is, it actually interacts with this, your factor, with your exposure. It causes an interaction, it actually amplifies, or either it increases or it decreases the expected result. So when a person exposed to asbestos, there is a chance of lung cancer. But when there is a history of smoking also, there is actually increases. There is actually 4 times more risk of cancer in a person who's a smoker as well as exposed to asbestos. So this actually just amplifies or changes your interaction. So I'll just see the comment here. So somebody has told, didn't understand confounding factor. Please explain again. Okay, I'll just explain it once again. Okay, so for a factor to be confounder, okay, when do you call a factor a confounder? There are no 3 rules that have to be obeyed. One is, it is independently, it is associated, the factor, that is your confounder, is associated with your exposure, then it is associated with your outcome, plus it does not come in the causal pathway. Okay, that is a variable To become a confounder, three factors should be satisfied. One is it is associated with your exposure, it is associated with your outcome, as well as it does not come in the causal pathway between your exposure and the outcome. Okay, for this, we'll just take the example here that is given. The exposure is coffee, the outcome is cancer, pancreatic cancer or any cancer. Okay, so you're trying to find out whether coffee drinking increases the risk of cancer, pancreatic cancer in patients. So whether coffee is linked to cancer, that is what you're going to find out. Okay. So here there is a factor called smoking that acts as a confounder in this example. What happens is smoking, smoking is independently related to your exposure as well as outcome, right? Smoking independently is related to cancer. Yes, smoking alone can cause pancreatic cancer. So smoking is associated with your outcome. Then smoking is associated with the exposure. Yes, there have been studies that say that smoking, coffee drinking is more common in smokers, or coffee drinkers have a more tendency to smoke. That's an established thing that you should know. Okay, so smoking is independently associated with the coffee. Smoking is independently associated with the cancer, but coffee causing cancer, there is no action of smoking in between. Smoking is not associated with the it doesn't come in the causal pathway of coffee to cancer. So this is confounding. It's a bit confusing, but at least you should remember these 3 points. Okay, confounder is associated with the exposure, it is associated with the outcome, and it does not come in the causal pathway. Clear? I hope it is clear now. Now your next question. Matching is done to remove option A confounding factors, option B selection bias, option C observation bias, and option D sampling error. Matching is actually done to remove confounding factors. So there are certain ways in which you can control your confounders in a study. One is matching, another one is, I'll just write it down, ways to control confounding factors. Okay, one is stratification. What do you mean by stratification? Basic word meaning is stratify, or you group them. If, for example, in that smoking example, you group them. I got a result that coffee drinking causes cancer, pancreatic cancer. Okay, that is people who are having who are coffee drinkers have a 2 times more risk of pancreatic cancer. Then to see whether the smoking thing has caused a confounding effect, then I just classify them, or I do the analysis in people who smoke and people who do not smoke. That is, I just stratify them into 2 groups and then I see for the results. So that is one way, that is stratification. Second one is matching. Matching is also done to remove the confounders. Okay, matching is done in which kind of study? Case control study. Okay, third one is your randomization, and fourth one is in statistical analysis. You can do something called regression, where you can actually adjust for confounding factors. So after this, another question is, matching can control known confounders. Randomization can control both known plus your unknown confounders. Okay, so it gives an extra edge for randomization over matching. Randomization is done in RCT, matching is done in which one? Case control, right? What are these known confounders and unknown confounders? For example, age, sex. These are known confounders. Age can act as a confounding factor in certain relations, or your gender. But sometimes you don't know the confounders. For example, the genetic composition. You don't know what is the what is the genetic composition between your study subjects and the controls and all that. So there are certain unknown confounders which we don't know. In randomization, we are taking care of both known as well as unknown confounders, but in matching, it's only the known confounders. Okay. So the answer is confounding factors here. Matching is done to remove confounders. Now what is the next question? This is the next question is, which one of the following does not represent the submerged portion of an iceberg? So you know the iceberg phenomenon, right? I hope all of you know what is the iceberg phenomenon. And the question is, which does not represent the submerged portion? An iceberg has a portion above the water and a submerged portion also, right? See, options are diagnosis cases under treatment, undiagnosed cases, pre-symptomatic cases, and carriers and subclinical cases. Which one of them does not represent the submerged portion? That is your diagnosed cases under treatment, okay? So this is your iceberg here. So iceberg, you see only a small portion is seen above the water, no? But the major chunk or the most dangerous part is seen below the water. Remember Titanic and all that, no? So you have a above wala portion and a submerged portion. So what you see, that is the top of the iceberg is what you see. It's what the clinician actually sees. That is, you see the clinical cases and the diseases. But there are a lot of cases which are invisible, that is submerged. It can include your asymptomatic infection, your carrier, subclinical cases. These patients who don't come to us, we don't find them, right? So always remember the visible cases form the above portion of the iceberg, and the submerged portion include all of these. They are the other options, that is your undiagnosed cases, pre-symptomatic cases, your carriers, everything comes under the submerged portion of the iceberg. Diseases like hypertension is a very good example for a disease that shows iceberg phenomenon, right? We say the prevalence of hypertension in India is almost 25%. That is the current prevalence of hypertension in India. That means only 25. That is only the you're saying only the above wala, the upawala portion of the iceberg. That is out of 100, 25% have been diagnosed of hypertension. That is what we know. But there are many subclinical cases or people who have not yet tested. If you don't check the BP, you don't get hypertension, right? So those are all under the submerged portion of the iceberg. So the clinician is more concerned with the above wala portion, visible one, but the epidemiologist is more concerned with the both, but mainly the submerged portion, because only if you tackle this portion, you can control or eliminate or whatever of a disease can be done only if you tackle this, the bigger chunk that is beneath. So another question is, iceberg phenomenon of the disease is not shown by rabies, tetanus, measles. So rubella is actually controversial. Some books say it shows, but actually no, because rubella has subclinical cases, right? So you cannot say rubella is showing iceberg phenomenon. But in case of rabies, tetanus, measles, if you take all these three diseases, you do not have any subclinical cases. All you see is cases. Cases come in the above portion of the iceberg, right? So rabies, tetanus, measles are diseases which do not show iceberg phenomenon. Important question. Okay. Now we'll move to the next question. Again, with this question, we'll take a short break. After this question, we'll come back. Okay. So this question is actually very simple. All of you know it, right? Triangle of epidemiology. Don't confuse it with triad of epidemiology. You see this question, you directly think, okay, triad of epidemiology. No. See, the question they've asked is triangle of epidemiology. So triad of epidemiology is different. Triangle of epidemiology is different. Okay. What is the triad of epidemiology? We all know agent, host, environment, right? This is the epidemiological triad. You have an agent, you have an host, if you have an environment. This is your epidemiological triad. And for a disease to occur, you should have something called interaction, right? There should be interaction between agent, host, and environment. Then only disease or an outcome will occur. If they just exist, disease doesn't occur, okay? So your triad is agent, host, environment. When you add time also with this, then you call it epidemiological triangle. So triangle has time also in it. That is agent, host, environment, and time. And there is one more thing. This was also a previously asked question. What is the advanced model of epidemiological triangle? In here, what you do is, instead of agent, you say causative factors, and instead of host, you're saying what groups of population, and instead of the environment, same only, but along with the environment, you have behaviors, physiological, culture, and other elements also. Why? See, this epidemiological triad, the agent, host, environment thing. This is actually very fitting for your communicable diseases, right? You have an agent, you have an host, you have an environment, you see interaction, you get the disease. But when you come to non-communicable diseases, which are on the rise now, usually instead of agent, it's not just one agent. You have a causative factors. There are many factors which lead to a disease, right? And you see it as a population. And it's not just the environment, but there are behavioral changes, many other things. So you modified this epidemiological triad into advanced model of epidemiological triangle. Okay. So I hope that is clear to you. Now we'll take a short break, and after that we'll be back soon. So hi, we are back. So I have a doubt here. Stratification and segregation is same or different? Actually, stratification and segregation are different. But stratification is the term which we use in statistics. That's a method where you stratify groups. Can be based on, you can stratify based on anything. Maybe based on the gender. You can stratify your study subjects into male, female, and see whether there's a relation, whether there's a difference in the result you got, or you can stratify based on different age groups. That is what is stratification. Okay, segregation doesn't come in the statistics as such. I didn't actually get the question. I think segregation is there in the sociology part. We are not talking about that. Here we are completely focusing on epidemiology and the statistical part. Okay, the answer is they are not the same. Okay, now we'll continue. Next question is from your levels of prevention. Levels of prevention is actually a very simple topic, but a very important topic, and usually there's at least one question from this. If your concept is clear, you don't have to by heart anything. You will easily crack all the questions regarding this levels of prevention. Okay. So the question is, all of the following represent specific protection mode of a disease prevention except. Okay. So the question is, which one is not a specific protection? Before that, you just tell me what are the levels of prevention. We'll just write it down. So you have your levels of prevention can be what all? We have 4 levels of prevention. First one is your primordial level. Then you have primary level of prevention, secondary level of prevention, and tertiary level of prevention, right? Primordial prevention is done in a group where there are no risk factors. Usually, what is this natural history of the disease? You have some risk factors, right? Then you have all your triad, the agent, host, environment, everything interacts, and then finally you get the disease. And once the disease comes, it can progress into different complications. Okay. So where all can you prevent? You can prevent the risk factors. You can prevent even before the risk factors. That is, you prevent the occurrence of risk factors can be done. Once there is a risk factor, you can prevent it from progressing to the disease. Once the disease has already occurred, you can at least prevent the further deterioration or the further complications so as to better the life of the patient. Okay, so these are all different places where you can apply your preventive strategies. Now you have primordial, primary, secondary, and tertiary. Primordial prevention is done in a population where there are no risk factors at all. Where can you do that? For example, in the case of hypertension, salt intake is a risk factor for hypertension, right? So you cannot do primordial prevention in me because I have the risk factor. I take extra amount of salt. But if I concentrate on babies, newborn babies, and if I teach their mothers, okay, see, salt is something that can cause hypertension, so you should restrict the salt intake. So that mothers can from the beginning onwards, once they start the weaning process itself, they can reduce the salt and drink. That is, in the initial phase itself, you are preventing the risk factor. That is done in primordial prevention. So usually do primordial prevention in populations where there is no risk factor, like usually children or maybe adolescents in some case. Okay, and primary prevention is the risk factor has already occurred, but you want to prevent the disease. That is the example of primary prevention. And under primary prevention, you have 2 things. What are they? You have health promotion and specific protection, right? This is your question here. So under primary prevention, I told you have the risk factor. Risk factor has already occurred, but you are preventing it from becoming the disease. Okay. So you have 2 things: health promotion, specific protection. Health promotion is a general measures that you do to reduce or control the risk factor so that it doesn't become a disease. For example, sanitation measures, hygiene measures, all these are general measures. These are coming under health promotion measures. You promote good health. Specific protection is actually specific. You are aiming at something specifically. For example, vaccination. Vaccination for measles. Measles vaccination is specific in preventing the measles disease. So specific protection is something that's specific. Now come to your question here. All of the following represent specific protection mode of disease prevention except, see, chemoprophylaxis for meningococcal meningitis. You give prophylaxis to prevent meningitis. So that is actually specific. It is specific protection. Then, use of condoms. Use of condoms is also specific protection. You are preventing unwanted pregnancies. Iodization of salt. You prevent the iodine deficiency the goiter things. So again, that is also specific. But you see the personal hygiene and environmental sanitation here, this is not specific to anything, right? Hygiene and sanitation improvement can prevent cholera, can prevent many diarrheas, many things. So this is the answer here, because it is a what? It is a health promotion and it's not a specific protection part. So here this is the answer. So now you are clear with primordial level, primary level. Now what is secondary level? You couldn't control the disease at the other two levels. So now you got the disease. That is, the risk factor has become the disease. The secondary level is you can't prevent the disease, but your secondary and tertiary levels, disease has already occurred, but you prevent the further complications. Okay. So we'll see it in detail here. So you see this diagram here. There is a above part is the natural history of the disease, and the below part, this part is the levels of prevention. This is actually a diagram given in your textbook only. And this is your natural history of the disease, right? This is how the disease process starts. Here, in each level of prevention, they've given the mode of intervention also. So here in the period of pre-pathogenesis, that is before the agent has entered into your body or before your pathogenesis has occurred. Okay, the agent is there, the environment, host, everything is there, but the disease has not started. Here you do primary prevention, whereby the modalities are health promotion, specific protection. Second one is when there is period of pathogenesis, that is, disease has already occurred. So now you do secondary prevention, whereby you do early diagnosis and treatment. You try to diagnose it very fast so that you can treat it then and there. That is coming under your secondary prevention. All your screening for a disease comes under secondary prevention. Remember it as S for S, screening for secondary prevention. Or what is screening actually? Screening is you are looking for a disease in an apparently healthy individual. That is, they already have the disease. Okay, it's not something new, but they did not know it. But you are actively finding out whether there is a disease in apparently healthy individuals. So screening is a secondary prevention. Screening is not a primary prevention. This is a very common mistake students usually make. Then tertiary prevention is basically you're preventing the disabilities and further deterioration. So under tertiary prevention, you have disability limitation and rehabilitation. Okay, I hope this is clear now. Just to make sure you got the idea, try to answer these questions. Okay, try to answer what are the levels of prevention I've given in this example. Vitamin A prophylaxis to a child. Why do you give vitamin A? To prevent? Specific, right? Vitamin A you're giving to prevent night blindness. So vitamin A prophylaxis to a child is an example of what? Specific protection, right? MMR vaccine we already discussed. MMR prevents mumps, measles, rubella. Again, vaccination is an example of specific protection. The childhood obesity prevention to reduce further CVD risk. So you want to hear the disease is CVD. You want to prevent the occurrence of the CVD. And the risk factors there. Obesity is there, but you're going to prevent it, So that is actually primary prevention. Spectacles for refractive error. Spectacles for refractive error is refractive error disease has already occurred, but you to improve the vision you give specs, right? So spectacles for refractive error is a tertiary prevention where you are trying to prevent the further disability or deterioration. Then what is self-breast examination? It is actually screening, right? Self-breast examination is a kind of screening and it is a secondary prevention. Why is it so? In self-breast examination, if I have a lump in the breast, I find it out. Okay, that disease is already there, but I find it out early. That is, there is early diagnosis and treatment, which comes under your secondary prevention. Okay. Now, the next question is just a fact. Who is known as the first true epidemiologist in history of medicine? Who is the first true epidemiologist? It is Hippocrates. Okay, there's nothing to explain here, but you should know who all are the other people. Okay, the John Snow. Why is he famous for? John Snow is known as the father of epidemiology. Okay, and the spot maps. Okay, he found out the reason for the cholera outbreak in UK, and the spot maps and all was developed by him. So John Snow is famous for that. James Lind, scurvy. He found out that vitamin C, the deficiency of vitamin C leads to scurvy in the, salesman in the ship. So that was what he is famous for. Joseph Lister for aseptic precautions, in surgery. So this is actually a simple question, but you may get one question from the history of medicine and all that. So these are I put a table here. These are some of the important personalities and their what is important. So that you should know. Hippocrates, he is the first two epidemiologists. He is the father of medicine. Yes. Then you have two Indians, Charaka and Sushruta. Charaka for father of Indian medicine. Sushruta for father of Indian surgery. John Snow, we told, father of epidemiology. Hahnemann, H for H. Samuel Hahnemann for father of homeopathy. Then you have James Lynn Scurvy. Edward Jenner. Edward Jenner is important, okay? Edward Jenner, smallpox vaccination history, they can actually ask you. Smallpox vaccination was found out by Edward Jenner. And smallpox is the only disease that has been eradicated in the world, okay? So only disease that has been eradicated is smallpox. And when did we eradicate it? It was in the 1980. It was in 1980 that WHO declared that smallpox has been eradicated from the world. Then you have Louis Pasteur. Many things is there, pasteurization. Then he found out the first vaccine for rabies. Then you have Robert Koch. You have studied Koch postulates in microbiology. Then he was the one who found out the agents responsible for anthrax, TB, and cholera. Ronald Rose, your cycle, the mosquito cycle, life cycle of Anopheles malaria mosquito, that was by Ronald Rose. And I've highlighted something, right? See, who's known as the father of public health? It is not who, it is actually what? Cholera, or the disease cholera, it's not a person. The disease cholera is known as the father of public health. That can also be a potential MCQ. Now we'll go to some questions from screening. The screening, you should know the basics of screening. What is sensitivity, specificity, positive predictive value, negative predictive value, and you should know the calculations. You'll be given the values, just like you calculated your odds ratio, risk ratio, you'll be asked to calculate the sensitivity, specificity, anything they can ask you, okay? Again, 2x2 table, and the calculation part is coming here. So we'll go to the first question from your screening. Question is, there are several points in the course of a disease process, right? In the process of disease, you have several points, right? Which are the points they have told? Disease onset, point of first possible detection, final critical point, usual time of diagnosis, and final outcome. These are the different set points. So where do you apply screening? For a screening program to be effective, in between which of these 2 points do you apply this screening? What is the answer here? Do you apply screening between disease onset and point of first possible detection? Or should you should intervene between this, your first possible detection and final critical point? When do you interfere? When do you put a screening program so that the program is effective? The answer is what? B and C, that is between this first possible detection and final critical point. This is the point where you have to put in your screening program. Okay, we'll see this in detail. Okay, so here you see you have point A where the disease onset is occurring, that is disease onset is happening here. Point B is the first possible point where you can actually diagnose the disease. We can find out the disease. Point C is final critical diagnosis. That is, at least final critical diagnosis means after this point, if you find out, no, there is no much change there is no much difference in the final output. But if at all you can catch this disease before this final critical diagnosis, then there's a scope of improvement. You can do something there, okay? And then you have your usual time of diagnosis and outcome. So remember, screening should always be between this first possible point, before that you can't find out, right? And final critical point, because after that there's no point in doing, there's no much improvement. So screening should come where? Between your first possible point and final critical diagnosis. Now what is this lead time? So lead time is the advantage gained due to screening. Lead time is the advantage gained due to screening, and that is, see, this is the usual time of diagnosis, right? In this person, this is the usual time of diagnosis. But by screening, this is the usual time of diagnosis, but through screening, I detect the disease here. Okay, so this extra time I get, this is the extra time is called the lead time. I can do, I can start early treatment, I can start all the modalities so that I have a better outcome than the other person. So that is lead time. Lead time is the advantage gain, the extra time you gain because of your screening process. Now there is something called the lead time bias. What is your lead time bias? Okay, see, you see two examples here. There are two pictures. One you have a screen group and one you have a control group. Suppose the outcome is, you are screening for cancer endometry. Suppose, okay, you're screening for a CA endometrium and you have a screening modality. In the first one, you're screening them, and at this point, your diagnosis is confirmed. Okay, you're confirming the person at an early point. In the other group, in the control group, there is no screening, nothing. So you diagnose them at a later point. Okay, when the patient started having symptoms, the patient went to the doctor and then got diagnosed. So that is the usual time. That is at the usual time only this person was diagnosed. Okay, only after symptoms came in, he went to the doctor and she went to the doctor and the diagnosis was made. So, but when you see the death of the patient, see, this is 2020. See, this patient whom you diagnosed earlier, maybe you diagnosed him 2 years before, she died in 2020. Okay, then there is another person who did not go for screening and all that, but got diagnosed at a later period. That person also died in 2020, right? Actually, both of them died in 2010. There is no much change in their outcome. But when you see the survival time, for this person, since the diagnosis was early, you can say this much is the survival time, maybe 2 years after 2 years after finding out this, the person survived. But for this person, the survival time is actually very less. The disease was found out and maybe within 4 or 6 months, the person died. But this difference, this bias that comes is called lead time bias. In real, there is no there is no improvement in the outcome, right? Both of the person, whether you screened or not, both of the ladies died in 2020. But in the person whom you found out first because of screening, you see that there is an apparent increase in the survival. But in the person who did not go for screening, who found out it very late, died very soon. So there is a lesser survival time. This bias you see is called lead time bias. Okay. Now, the next question is, it's a direct question. Which of the following is an example of prospective screening? Okay, there are two types of screening. Which are they? Prospective screening and prospective screening. Now, they've asked you to find out which one of this is a prospective screening. Cervical pap smear in a 40-year-old female, neonatal screening in a newborn for hypothyroidism, screening of immigrants in a country, urine for sugar screening in a 40-year-old male. Okay. Now, what is the difference between this prospective screening and prospective screening? See, prospective screening is for me, okay? So screening can divide into prospective screening and prescriptive. So you have prospective screening and you have a prescriptive screening. See here, as I'm replacing this E with me, okay? Whereas prospective, this is for others. Remember it like this, okay? Then you won't go wrong. So prescriptive screening is a screening that I do which will benefit me, myself. Whereas prospective screening is a screening which will benefit, not just me, but mainly it is focusing on the benefit of the others. When you see the example, cervical pap smear in a 40-year-old female. If I do a cervical pap smear and if I find out that, okay, I have a risk or I'm having a cervical lesion, I can do my treatment first and I have a better outcome. So this is actually prospective. It is for me, right? So it is prospective screening. Urine for sugar screening in a 40-year-old, again, it's for me. It's for my benefit I'm doing this. Again, this is prospective screening. Neonatal screening in a newborn for hypothyroidism. Again, if the hypothyroidism is detected fast, good for the newborn baby, right? So again, it is also for me. That is prospective. But this one, screening of immigrants in a country. Why do you screen immigrants who are coming to a country? So that they don't bring any new diseases into your country and they don't infect the other people in your country. That one is not for the immigrant. That one is for the other people there. No? So that is an example of your prospective screening. Okay. So differences already told. People screen for their own benefit is prescriptive, me. People screen for others' benefit is prospective screening. Okay. Essentially, what is the purpose? For prescriptive screening, it's for case detection. For prospective, it is for the others. That is mainly for the disease control. And the request for prescriptive screening, there is no specific request. But the other one, the prospective, usually is done by a request by the authorities. For example, during the COVID time, we were all asked to do the, rapid RT-PCR or the test and then go. That was a kind of a prospective screening for the disease control. And the examples we have already discussed, screening of immigrants, even HIV screening among sex workers. This is an example of a prospective screening. You're screening them because, they are the people who go to them don't get the disease, right? Okay, now we'll come to the calculation part. Okay, true about the following is you have a screening test given here. They have actually this question is actually incomplete. They should have given screening test was conducted so and so. So there was a screening test conducted. Okay, what was the test? With ECG we are finding out whether MI was present or absent. So the disease is MI here, and the tool or the screen tool uses ECG. And if you have positive ECG findings and negative ECG findings, and they've given you how many of the people tested had MI and how many of them did not have the MI. And the options are sensitivity is less than specificity, sensitivity is same as specificity, PPV or the positive predictive value is more than negative predictive value, PPV is same as NPV. So in this question, you cannot just, answer it like this. You have to draw your 2x2 table. You have to do the calculation. You have to find out what is the specificity, what is the sensitivity, what is the NPV and PPV. Then only you can solve this question. So basically, what is sensitivity? It is the ability of the test to correctly identify those who have the disease, right? And specificity is the ability of the test to identify correctly those who don't have the disease. Sensitive can identify those who have the disease. Specific is it is the ability of the test to identify those who do not have the disease, to correctly exclude those who don't have the disease. Okay, and the positive predictive value is it's a characteristic of the test. It is the probability that a person who actually became positive in your screening test is actually a true positive. That is your positive predictive value. And negative predictive value is the probability that the person who came negative in your test is actually, negative for the disease in real life. So these are sensitivity, specificity, positive predictive value, and negative predictive value. We'll just write down this here because this is actually very important. So you have sensitivity is ability of the test to identify those with the disease, those who actually have the disease. Okay, that is your sensitivity. And specificity is what? Ability to identify those who don't have the disease. Okay, now if you get a question to calculate sensitivity, specificity, first thing, just like your odds ratio and loss ratio, make the 2x2 table. Okay, so this is the 2x2 table here for any screening test related questions. So always this won't change. The disease is here, it's just not going to change. So this is the disease positive for the disease. This is the people who don't have the disease. Here you put your test, whatever screening test you're putting, that is added here in the place of the exposure. Okay, these are positive for your screening test, these are negative for your screening test. So suppose somebody's actually has a disease and you actually found out that okay, this person is having a disease in your test, they are the true positive people, right? They have the disease and your test is also saying okay, this person is diseased. Those are true positive. Similarly, you have what? True negative, that is people who don't have the disease and your test is also saying okay, this person doesn't have the disease. They are true negatives. This is actually easy. It's a safer part. True positive, true negative. The next one is confusing. You have something called false positive and false negative. False positive is, see, the test is saying this guy is having disease, but in real life he is not having the disease. Okay, this is false positive. And false negative is what the screening test is saying, this person is not having the disease. As per the screening test, it's negative, but the person is actually deceased. So that is false negative. Okay. So always remember, disease, not deceased. Screening positive, screening negative. This is not going to change. And this one, the second one, this is always false positive. Remember this so that you can easily make the 2x2 table. Now, how do you calculate sensitivity and specificity from this table? Simple, okay? Just draw like this. This will give you your what? This sensitivity, and this one will give you your positive predictive value. Okay, and if you draw like this from here to here, this is your specificity and this is your negative predictive value, right? So here if I draw it this side I get sensitivity and positive predictive value. This one here I get specificity and negative predictive value. So what are the formulas coming here? So sensitivity is what? I'm drawing it like this, right? So TP, true positive divided by this and this, TP plus FN, true positive plus false negative. This is your sensitivity. That is, out of the total deceased, how many actually has the disease as per your screening test. So that is TP by TP plus FN is sensitivity. What about your positive predictive value? You draw it like this. So it is again TP divided by TP plus what? This is the direction, right? TP plus FP. That is true positive plus false positive. That is your positive predictive value. So what is specificity? I'm drawing it like this, right? So specificity is TN, true negative, divided by TN plus FP. And your negative predictive value is, it's like this, right? TN divided by true negative plus false negative. So these are the formulas. This is the way you should know the concept, of course. But when you get a question in your NEET-PG, this is how you have to solve it very fast, okay? Draw the 2x2 table, put arrows, sensitivity is what? Like this, TP by TP plus FN. Positive predictive value is TP by TP plus FP. Specificity, TN divided by TN plus FP. And negative predictive value is TN divided by TN plus FN. Once you draw this, you just put the values given in the question and you solve the question, okay? So here you have, here you don't have to create the 2x2 table because it's already in the required format only, right? Disease present, disease absent. This was a question. Screening test present, screening test absent, and they have given the values. So I'm going to calculate sensitivity. What is sensitivity? 300 divided by 300 plus 25, right? What is my positive predictive value? It is 300 divided by 300 plus 100. For this, specificity 75 divided by 75 plus 100. Sorry, 75 plus 25. And this one is your negative predictive value, 75 divided by, this one is 75 plus 25, this is actually 75 plus 100 only. So you calculate it, and when you calculate, you can see that, you know, the positive predictive value and negative predictive value are the same in this. So your option is D, PPV is same as NPV, okay? So I hope you understood how to go about in a calculation for sensitivity, specificity, positive predictive value, negative predictive value. Draw the 2x2 table. This is sensitivity, this is sensitivity, this is positive predictive value, this is specificity, this is negative predictive value. This is the easy way to, you know, calculate the sensitivity and specificity. Okay. Now we are moving to the next question. Now there is something called test in series and test in parallel. You can get questions from that area also, okay? This question which we are going to discuss now is regarding this topic only. So the question is, if a hemoccult test is negative for screening of colonic cancer, no further test is done. Okay, but if the hemoccult test is positive, the individual will have a second stool sample tested with the hemoccult 2 test. So if the second is also, if the second for blood, the individual will be referred to more extensive evaluation. The effect of net sensitivity and net specificity of this method of screening is dash. Both are increased, sensitivity is decreased, specificity is increased, sensitivity is increased, specificity is decreased, sensitivity remains the same and net specificity is increased. It looks quite confusing, right? So I'll tell you how to go about this. So if such a question comes, the first step is you have to find out whether they are talking about test in series or test in parallel. Then comes your answer, okay? What is test in series? So when you're combining certain tests, you know, you can arrange some tests in series or either in parallel. If suppose I have 3 tests, so there is test 1, test 2, test 3, okay? And to find out whether the person is actually positive or negative, I'm using these tests in series. That means this is how I'm going to do it in series. That is, first I'll do test 1. If the person is positive for test 1, then I'll go for test 2. If he's positive for test 2, then I'll go for test 3. This is called test in series, okay? But if the person is negative for test 1, I stop there. I declare that this person is negative as per my test and I stop there. That is one thing with series. So in this question which they have given, they are actually talking about tests in series when you read it carefully. That is, hemoccult test is negative for screening of colonic cancer. No further test is done. That is, if your first test is negative, you stop there. If it's positive, then you go about with the next test. So this is actually test in series. Now, what is test in parallel? In test in parallel, what you do is, at the same time you do all the tests. This is what is called test in parallel. Here, for a person who's coming to you, you do the first test, you do the second test, you do the third test, all simultaneously. Doesn't matter if the first test is positive, whether you go about with the second test, no questions like that. You are doing all the tests simultaneously. That is called testing in parallel. So when you do a test in series, what happens is actually your sensitivity is decreased. Because what if I do a test in series, in the first test, if I get the person is negative, I stop there. I'm not including him for the other test. So what happens is sometimes I fail to detect people who actually have the disease. Sometimes if I had done it in parallel, even if the test 1 is negative, sometimes test 2 might be positive and he'll come positive in my study. So series will always decrease the sensitivity, but specificity will be increased. So this is the change. The answer here is net sensitivity is decreased and specificity is increased. But how do you remember this? It's quite confusing. So I've made a mnemonic for you guys. Okay. So the mnemonic is, study this. TV series decrease sensational news viewers. You know it, right? You have all kind of TV series, Netflix, everything. So you are more, all of us are more watching TV series than news channels. We have stopped watching news channels and we are more focusing on TV series. That is the mnemonic here. TV series decreased sensational news viewers. We are not watching any sensational news. We are more focused on the TV series thing. Okay. So TV series decreased sensational news viewers. Here, how do you decode it? TV series stands for what? Test in series. Okay. Decrease, that is the change. So there is decrease in what all things? S and N. S stands for your sensitivity and N stands for your what? Negative predictive value. That is, when you do test in series, two things decrease. What are they? Sensitivity and negative predictive value. Both these decrease in test in series. And so what will increase? Just the opposite. If sensitivity is decreasing, that means specificity is increasing, right? If NPV is decreasing, that means positive predictive value is increasing. And for test in parallel, it's just the opposite. Okay. In specific, sensitivity is decreasing in series, but when you do the test in parallel, sensitivity is increasing. Similarly, when the PPV is increasing in series testing, it decreases in parallel testing. So if you study just this sentence, you can just write the opposite for the other ones. So TV series decreased sensational news viewers. That is testing in series. In testing in series, what all are decreased? Sensational for sensitivity. News viewer, that is N for negative predictive value. So sensitivity and NPV are decreased in series testing. Don't forget this mnemonic, okay? So, and now this is the last one from screening. What you see on the screen, this is something called a ROC curve, right? What is this ROC curve? It is a receiver operator curve. So what is the use of this ROC curve? ROC's curve is nothing but a graph which helps you to compare different screening tests to say which one is better. I have 4 or 5 screening tests. I plot my ROC curves and then I can decide which of this is a better option for me. So what do you plot in ROC curve? Here you have the y-axis has what? Sensitivity or true positive value. And your x-axis have 1 minus specificity or false positive value. Okay. When you say that the test is best, so you need highest sensitivity and highest specificity to say that this is the best test. When you have in this graph, this is the point, okay, this is the point where you get highest sensitivity and higher specificity, because this is sensitivity is increasing. This is 1 minus specificity. So towards this side, you get better specificity. So when you are given the question will be, what is this ROC curve? Second question, there are different graphs given. Which is the best one? Which is the best test? This one, the one which is closer to the upper towards this y-axis. This one is always the best one. Okay, so if you are asked to find out which is the best one, always choose the one which is upper and closer towards the y-axis. This is the best test. This is the use of ROC curve. Now we'll take a lunch break, and while we are back, we'll be studying the rest of the topics. I'll be starting with biostatistics after the lunch break. Thank you. So welcome back. Now we'll start discussing questions from biostatistics, okay? So for NEET-PG, you get some amount of questions from biostatistics, but usually they don't go that deep. Superficial questions you get. But if it's for INI-CET, you have to go, in more depth. So we'll go to the questions. So first question, which of the following variables is measured on the ordinal scale? Okay, which among the following is a ordinal scale measure? So how do you classify variables? So basically, variables can be of three types, right? They can be either nominal, ordinal, or metric. So what do you mean nominal? A nominal scale or a nominal variable is, norm means name. Something related to names, okay? When you have a, for example, this one, types of anemia. How do you say types of anemia? It can be iron deficiency anemia, it can be megaloblastic anemia, it can be anemia due to chronic diseases. These are all names, right? There is no particular order, nothing, it's just names. So it's such a variable, such a scale you call a nominal scale. This is one as a nominal, okay? Now ordinal is when there is some kind of an order. For example, you're grading the cancers, stage 1, stage 2, stage 3, stage 4. They have a particular order. Or the severity of anemia, mild, moderate, severe. It is coming in an order. Those are your ordinal variables. So the answer here is, of course, severity of anemia. Now, what is this metric? Metric is what can be measured. The hemoglobin level, the ferritin level, calcium level, all those things which can be measured, they come under your metric variable. So here the answer is severity of anemia, which is it's an order, right? So it's an ordinal variable. So this is just a summary of this, what I just told. So you have nominal scale, ordinal scale, and metric scale. And nominal and ordinal, both these are, categorical or qualitative variables. Metric is which you can measure. That is, you have the you can quantify. So that's a quantitative variable. Also, just go through the examples, okay? For example, quantitative, you have blood glucose level, hemoglobin, serum cholesterol, etc. And ordinal, you have severity of diseases, TNM, staging, all those things. So, and the statistics is for, nominal variables, you usually say in terms of mode or chi-square. And for ordinal, it's the median. Whereas for a metric scale, or which you can measure, usually you have the mean, standard deviation, standard error, and all that. Okay, now we are going to the next question. The question is, a scatter diagram is drawn to study which one? Option A, trend of a variable over a period of time. Option B, frequency of occurrence of events. Option C, mean and median value of the given data. Option D is relationship between two given variables. So what is why do you draw a scatter diagram? What is a scatter diagram? See, the answer here is, scatter diagram is used to find out the relationship between two given variables. So option D is the answer here. So you can see here, what is a scatter diagram? You just have, so there are two variables, okay? Suppose I want to see whether there is any relationship between the height and weight of the students sitting in my class, okay? So I plot your heights and then weights, okay? These are two different variables, right? Then we just plot it down and you see whether there is any relationship. So it's a spot. It looks like a scatter. That is called a scatter diagram. And with this, we come to inferences, whether when one variable increases, the other variable increases or decreases. That is, when x increases, what happens to the y variable, whether it increases, whether it decreases, or whether there is no such relationship. That is the correlation. This is what you get from your scatter diagram. So you should be able to identify scatter diagram. Maybe they can give you, just see, these are all scatter diagrams, okay? They can give you one image like this and ask you identify. So that's a scatter diagram. So you see here, you see figure A. They have actually plotted the relationship between hemoglobin level and triglyceride level. You see the points here. See, these are this is scattered. You cannot make out a relationship like that. So this is a weak correlation, okay? Whereas in this one, in the B, you have a scatter diagram between heart rate and body temperature in a fever patient. Here you see most of the points are scattered like this. They form a line. So this is actually a strong positive correlation. And here you see the third one, you have BMI and physical activity. And you see when you connect these dots, you can get a line like this. So it's actually a opposite way, right? So it's a strong negative correlation. Okay, and then, so this is how you interpret scatter diagrams. You can say it's a strong correlation, weak correlation, or maybe there is no correlation. It's like that. And there is something called a correlation coefficient, or you write it as R. Based on this also, you can identify whether there's a correlation or no correlation. So R can range from +1 to -1, okay? When the R value is +1, okay, R is +1, you say there is a very strong or a positive correlation. When R is -1, it's a strong negative correlation. When your R is 0, then there is no correlation. Okay? In these images, here in this one, probably your R is 1. Here maybe R is minus, somewhere around the -1. When there is no correlation, when if I get an image like this, even this one has a weak correlation. If I get an image where there's like no relation at all, here the R is actually 0. Okay, so you know what is scatter diagram, you know what is correlation coefficient. Okay, and in statistics, you have two terms which people usually confuse. One is correlation, one is regression. So both these are procedures in statistics which help you to find out relationship between two variables. Suppose there are two variables X and Y. In correlation, when I do a correlation test in statistics, what I get is what happens to Y when X changes. That is, whether X increases with Y or X decreases with Y, or whether there is no relation. Only that much I get with correlation. Whereas in regression, you can actually predict the value of your Y with respect to X. Suppose if Y is 10, how much will be the X? So not just the relationship, you also get actually you can predict what will be the dependent variable with respect to your independent variable. So that is what makes regression superior to correlation. Okay. Now the next question is, these are regarding the graphs. Okay. Question is, which of the following is used to denote a continuous variable? For a continuous variable, which one do you use? Simple bar, histogram, pie diagram, or multiple bar? You use a histogram. Okay. So histogram is a chart which you use to depict continuous variables. Okay. So this is an example of histogram. What have they done? They've actually plotted BMI. BMI is a continuous variable, right? So they've plotted the BMI of a population of a study group, and that is the histogram you see here. Now I'll just show you some graphs. You have to identify which one. Okay. The first one, what is this? The first one is a bar, right? First one you see is a bar diagram. And when do you use bar diagram? This is in case of when you want to show the frequency of discrete variables. Then you use a bar diagram. Then there are different types of bar. You have simple bar, you have multiple bar, compound bar. Okay, this is a simple bar. If I have something like this, maybe if I'm showing male, female separately, this becomes a multiple bar. Compound bar is something looking like this. Okay, the same bar, only you show different things. That's a compound bar. So all these are bar diagram. Okay, here you can see between the bars there's a space. Whereas when you come to histogram, this one is what? This is your histogram. When there is a histogram, it's a continuous variable. It's not discrete. So there is no gap in between. After one bar, you get the next bar. Okay, you get the next bar. There's no space. But here, you see, here in a bar diagram, you have space between the two bars. In histogram, there is no space. That is one way you can diagnose it, answer it very easily. Then, when I plot the midpoints, when I am plotting the midpoints of each bars in a histogram, and when I join, I get something called a frequency polygon. Okay. So in this diagram, the green part you see is the histogram, and the red part, which is you got by joining the midpoints of the bar, that is a frequency polygon. You should be able to identify all this. That's why I'm showing you this. What is this? This is your pie chart, right? Pie chart, and total of 5 is always 100%. And what is this? This is a Venn diagram. In Venn diagram, we can actually show the overlap. If there is something common between the two groups, then you can show that overlap in a Venn diagram, 2 or 3 or any number. And this is what it's already written there, right? It is the stem and leaf plot. So they can actually ask you, they can show you one of the graphs, and you may be asked to identify or interpret. So that is one area in biostatistics which you should know. Now, what is this? I have not shown you this in the previous slides. So identify the statistical diagram shown in photograph. What do you see here? Yes, this is you see something like this, right? What is this? You have a box and you have a whisker. So this is called a box and whisker plot. So box and whisker plot, how to interpret a box and whisker plot? So in a box and whisker plot, you have a box, right? And you have towards the side, you have whiskers. So if you want, you have some data, you can show the data in a simple way. That is a box and whisker plot. Here, this thing, this box, it is the, the data between the first quartile and the third quartile. This is the Q1, this is the Q3. The Q2 becomes the median. The Q2 is the median, okay? And what are the whiskers, two sides of the whisker? Here you get the smallest value in your data set, and this side you get the greatest value. And this distance between the smallest and the greatest, what do you call that? That is the range, okay? So it's clear, I hope. Line in boxes, what is that middle line in this box? It's your second quartile or the median. This is a question actually. Whiskers end, both the whiskers, that is the end part, it is the minimum and the maximum value. Between that you have the range. And edges of these boxes, this is your Q1, first quartile, and this is your Q2. So this diagram should be known to all of you, okay? Okay, now we are going to the next question in biostatistics. This is a question on measures of your central tendency. Which are the measures of central tendency? Mean, median, and mode, okay? The question is, the number of malaria cases reported during the last 10 years in a town is given below. They have given you certain numbers of the cases reported. 250, 320, 190, 300, 5,000, 100, 260, 350, 320, and 160. The epidemiologist wants to find out the average number of malaria cases reported in the town during the last 10 years. Okay, so they have given the 10 years, each years, how much is the number of cases they have given, and you are asked to find out the average. In the last 10 years, what is the average of the number of malaria cases reported in that particular town? So, which is the most appropriate measure of average for this data? Is it the mean? Is it the median? Is it the mode, or is the geometric mean? Okay. What is the answer here? Yes, come on. So, see, what is the mean? Mean is actually the average. If you have 10 numbers, you add all the 10 and divide it by 10. That gives you the mean. What is the median? Median is the given set of numbers, you arrange them in ascending or the descending order, and the central value you get, that is your median. Mode is the most repeated value. If you have 10 set of numbers and I have, one number repeating most of the times, then that number becomes the mode. In this case, when you see the numbers, you see 250, 320, 190, you will be expecting an average of somewhere around 200 to 300, right? But you see the number here, there's a 5,000. Just because of this 5,000, this is actually an outlier, right? It is not fitting into the group of the other numbers, 250, 320, 160. No, 5,000 is huge. So if I go for the mean, if I calculate the mean for these numbers, just because of that 5,000, I'll get a very bigger mean. So which is actually wrong. This is not the average number of cases. So in this case, the best answer would be your median. How do you do the median? Whatever numbers are given, you arrange them in ascending or descending order, and then you choose the middle value. The middle value will be your median. So in this question, the answer is the median. Okay. So we have discussed what are the measures of central tendency. You should know, and you may be asked, you may be given the values, and you may be asked to calculate. In our question, they just have asked which one you should use, mean, median, or mode. But mostly you'll be given the values and you'll be asked to calculate mean, calculate median, calculate mode, like that. Now, another question. In a bimodal series, if mean is 2 and median is 3, what is the mode? So they've given the mean is 2, median is how much? 3. And you are asked to find out the mode. This is a bimodal distribution, okay? So for this, you just need to know what is the relation, what is the equation connecting mean, median, and mode. It's given here. Mode is equal to 3 median minus 2 times mean. If you just know the simple equation, you can easily get the answer. So what is the mode here? 3 into median, that is 3 minus 2 into mean. This will give you the mode. How much is it? 9 minus 4, which is 5. So the answer here is 5. Such a simple question. You can save a lot of time if you just know this one equation. So study this, okay? Now, next one is standard deviation. Standard deviation is a measure of chance, central tendency, Deviation from mean value? None. What is the answer? See, standard deviation is a measure of deviation from mean value. So when you have a set of values, you have a mean, right? That is, mean and all is a measure of central tendency. What will be the average? What is the central value? But sometimes, usually what happens is when you have individual points, they usually don't come towards the mean. There's a certain amount of variation so that they move away from the mean. So that variation, how much is your particular data differing from your mean of the whole data set? That is the standard deviation. So it's a deviation from the mean value, okay? And what is the measure of chance? Chance, usually you get p-value. P-value is the one that show you the chance, how much is the chance and all that. So here the answer is deviation from the mean value. And how do you calculate standard deviation? It is the square root of variance, okay? That is, you have mean minus, the sum of the difference between the means by the sample size, and then you take the square root. So this is the formula for standard deviation. You can get calculation, so you should know standard deviation is the square root of variance, and this is the formula for standard deviation. Now, what is this difference between standard deviation and standard error? See, standard deviation is for a particular data set, but standard error is for a population, okay? Both are not the same. Both are not the same. Standard deviation and standard error are both different things. So I'll tell you what is the basic difference between both these. See, standard deviation, it denotes the variability within a sample. Here I have a sample, okay, I have certain values, and this is the mean of my, maybe I have 10 numbers, okay, this is the mean number, and standard deviation is showing the variability between the individual numbers and your mean. That is what standard deviation is, okay. That is, it's a variability within the sample. Whereas, it's a, what do you call it? It is a sample statistics. Whereas sample error, what is it? It denotes the variability among multiple samples from a population. Or in other words, it says how close your sample mean is to the population mean. So standard deviation is something for a sample. Whereas in standard error, what happens is, see, from a population you take different samples, and the population sample will have a mean, right? So what your individual multiple samples will vary from this population mean. That difference is the standard error. At least remember this much: standard error is for your population statistics and standard deviation is for your sample. Okay, and what is the relationship between both? Standard error is standard deviation by root of number of samples you take. So SE equal to ST by square root of N. This formula is also very important. You can get questions from this. Okay. So here there's a question. Among 100 women with average HB of 10 gram, the standard deviation was 1. What is the standard woman? So what have they asked? They are asking you the standard error, right? Standard deviation is how much? It is 1. And your N, that is the sample size, is 100 women. So simple, SC is equal to ST by root N. What is ST? 1 by root of 100. So you get 1 by 10, which is 0.1. The answer is 0.1 in this question. Okay. So the next question is the standard normal distribution. So you have something called a normal distribution curve and not normal distribution curve, okay? So this question is about the normal distribution. So the standard normal distribution, which is skewed to the left, no. that is a skewed distribution. Normal distribution is not skewed. Whatever is not normal, that becomes skewed, okay? Has mean of 1? No. Has standard deviation 0? No. Has variance 1. This is the correct answer. A standard normal distribution has a variance of 1. See, this is the, we'll just see what is a normal distribution, okay? This graph you see here, there's a small mistake here. It should go like this. It shouldn't touch this. Or it's like this, okay? This one that I've drawn now, this is what is called a normal distribution. It's also known as Gaussian curve. Okay, you should know some of the properties of this normal distribution of this Gaussian curve. So, this, what is the shape of it? It's a bell-shaped curve. First point, bell-shaped curve. And the peak is coming in the exact center, okay? This peak will be coming in the exact center. And what is this peak? This will be the mean, equal to median, equal to mode. So, in a central, it's in a normal distribution or in a Gaussian curve, mean and median and mode are equal and they will be coming in the peak of that curve, okay? And it's a symmetrical curve, yes. And it's unimodal, there is only one peak. And you see the ends, no, these tails, they don't touch here, okay? That's why I told what is given here is wrong. These things don't touch, it just goes like this towards infinity, okay? This is another feature and you call that asymptotic. That means the, the x-axis, the curve does not touch on the x-axis. And now you say all the, you see 95% confidence interval, you say 99% confidence interval, 68%. All these are based on your normal distribution, okay? So in a normal distribution curve, there are certain facts. That's what we are going to show in this. So this is your normal distribution curve here. And this one, this much is one standard deviation. And usually we say 68% CI corresponds to one standard deviation. And 95% CI for 2 standard deviation. And 99% CI for how much? 3 standard deviation. This also you should know, okay? So what does it mean 95% CI? So when I say that, when I give a value and say that 95% CI is this much, that means the value I got, I'm 95% sure that this will be, the value will be between this, between the 2 standard deviations in the normal distribution, okay? Now that is central tendency. Now you go about, that is when the data is distributed in a normal way. Now you have what? Skewed distribution. The skewed can be either positive skew or negative skew, okay? So you have 3 types of distribution basically. One is your normal distribution or the Gaussian distribution, which we just discussed now. Then you have a right skew and you have a what? Left skew. Fine. So in right skew, it's also a positive skew. See the tail will be towards the right side. This is a positive skew. When the tail is towards the left side, it is a negative skew. That is how you identify. Okay, in a positive skew, this tail, it will go like this. This tail is towards the right side in a positive skew or right skew distribution. But when the tail is towards, the left side, it becomes a negative skew distribution. In a symmetrical distribution, in a Gaussian distribution, there is no tail like that. No, it is equal on both sides, right? Now, what is the relationship between mean, median, and mode in right skew and left skew? How do you remember it? Just write it like this, okay? So here, right, mean, median, mode. Fine. If it's a normal distribution, all these are equal, right? If it's a left skew distribution, left. If it's a left skew distribution, just write L in between. L. That means mean is less than median, less than mode. The highest one is the mode in a left skew distribution. Fine. So in the right skew, it's just the opposite. If I put the arrows like this, then it becomes a right skew distribution. This is how you can memorize it. Okay. Now the next question is regarding sampling. For an epidemiological study, every 10% selected from a population. This type of sampling is called what? When you're selecting every 10% from a population, this is called a what? It's a systemic random sampling. Okay, you should know the types of samplings. Basically you classify them as random sampling and non-random sampling, right? Under random, you have simple random sampling, thematic random, stratified random, multi-stage random, okay, cluster random. These are all coming under your random sampling. Under non-random sampling, there you have non-probability, or the examples are purpose of sampling, convenience sampling. That is no random. So in a random sampling, every person has the equal opportunity of being selected as a study participant. But in non-random, there is nothing like that. Non-random, one example is convenience sampling. That is, I'm doing a study and according to my convenience, I choose the patients. Whoever is coming to me, I take them. There is no randomization, nothing. So that is random and non-random sampling. Then one word you should study here is this thing, snowball sampling. So usually asked. Snowball sampling is especially to find out, cases of STDs and all that, sexually transmitted diseases and all. You do snowball sampling. That is, you find one person and then you ask who all are the contacts, because it's sexually transmitted, right? So you get he or she says another person's name, so you go meet him. So like that, you find out the people who are involved. So this is an example of a snowball sampling. It's not a random sampling, it's a non-random sampling. Okay, now you should know the tests of significance. They won't ask you to, do the test of significance and give the answer, but they'll ask you which is a test that should be used in a particular scenario. Now the question here is, in a study, variation in cholesterol was seen before and after giving a drug. So they are checking the cholesterol variation, right? This is a quantitative variable, right? Before and after. Okay, and which is the test of significance that you can use? Unpaired t-test, Fisher test, paired t-test, and chi-square test. What is the answer here? Here the answer is actually paired t-test. Okay. So when there is a quantitative variable, when there are quantitative variables and you are saying the before and after change, the test you use is paired t-test. Okay. Now this table shows you which are the tests you should use. It's a bit difficult one, but you have to study this table because usually you can get a question asking which is the test used in this particular scenario. Okay. So we have parametric test and non-parametric test. Parametric is for your normal distribution, the bell-shaped Gaussian distribution. Non-parametric is for all your skewed ones. That is non-normal distribution. And parametric test, the type of data you deal with are quantitative, that is measurable variables. The other one, non-parametric, you have qualitative variables. And which are the tests under parametric test? You have, student tests. Student t-test can be paired, unpaired, ANOVA. These are coming under the parametric test. Non-parametric, most important one you should know is chi-square test. Okay, this is very important. Other than that, you have sign test, Wilcoxon test, and Wilcoxon rank-sum test and all that. But usually, you get questions from two of the tests. That is the t-test and the chi-square test. So when you find out that, okay, this variable is a qualitative variable you're asking about, that means you go for the chi-square test. When the variable is a quantitative variable, then you go for t-test. Whether it's connected, that's before and after, you go for the paired t-test. Otherwise, you'll have to go for the unpaired t-test. Okay. Now, next question is about, p-value. See, all are true about p-value except you have four options here. Option A is the probability of committing type 1 error. Option B is equal to 1 minus beta error. Option C is a chance that the presence of difference is concluded when actually there is none. Option D, when p-value is less than alpha, the result is statistically significant. Okay. So what is this p-value actually? What does p-value tell you about? So, whenever you do a test, any test, you are checking the relationship between two variables, right? Whether there is an association between this exposure and this outcome, you're seeing that. But there is something which you cannot exclude, that is called chance. Sometimes some variables, they tend to show a relation purely due to chance. Actually, there might not be any relationship, but just because of chance, randomly or just because of chance, it happened. Okay. But otherwise, it might be a really existing association. So this is what your p-value tells you. When I say p-value, acceptable p-value is 0.05. What does this mean? P-value 0.05 means this is 5%, right? 0.05 can be written as 5%. So here I'm telling I got a result. Okay, this is the mean or this thing, something like this. This is the mean value, or I got some result. And here, and if I say acceptable p-value is 5%, that means whatever result I got, 95% times it is true. Okay, it comes in that, within your confidence interval and all that. But 5%, I'm not sure. 5% maybe because of chance. So in any test, we have actually fixed the p-value. We can take p-value as 0.05 or 0.01 based on that is the investigator's choice. So if I take 0.05, I'm telling that, okay, my result, 95% of the time, I'm sure that this is the result, but there's a chance, at the 5% chance that it can be due to chance alone. That is the simple idea of what we mean by p-value. So when you get a p-value of, suppose I'm fixing that p-value of 0.05, that is the most commonly used one, is significant. So if I get a value less than that, that means my result is significant. If I get a p-value more than that, that means my result is not significant. And you know about the hypothesis, right? We always have a null hypothesis. We have a alternate hypothesis. Usually the null hypothesis says, for example, if you are comparing two drugs, there is no difference between the efficacy of drug A and drug B. That is your null hypothesis. Your alternate hypothesis will be there is a difference between drug A and drug B. Or you can say drug A is superior to drug B. That's your alternate hypothesis. So this is a 2x2 table, where you plot this your hypothesis and the decision that we make. So here, this is the truth, okay? And this is the decision that we are making. And we have what HO is your null hypothesis, and HA is your alternate hypothesis. So what happens is sometimes you reject the null hypothesis, okay? And actually the null hypothesis must be wrong also. So in that you are making a correct decision. And sometimes you accept the, you reject the alternate hypothesis, and that will be the correct one. That time also you are making a correct decision. But sometimes what happens is there is a null hypothesis, there's an alternate hypothesis, but what you do is you mistakenly, the null hypothesis was actually true, but you rejected it. Or the other way around, the alternate hypothesis was true, but you rejected it. So those cases that can cause errors, and you have type 1 error and type 2 error. Okay. See, this is type 1 error. See, this guy, this is how you can memorize what is type 1 error and what is type 2 error. Type 1 error is this doctor is saying to this man that you're pregnant. That cannot happen, right? That means this is false positive. This is your type 1 error. Here, the null hypothesis was true, but you actually rejected it. Okay. And the other way around, that is, this is a type 2 error or the false negative. This lady is actually pregnant, but you are telling, no, you are not pregnant. So that is a type 1 and type 2 error. So which is p-value related to? Always remember, p-value is related to your alpha error. Type 1 error is also called alpha error, and type 2 error is called beta error. I know this is a bit confusing, but at least remember this one. P-value is related to type 1 error or alpha error. Okay. The beta error, the beta one talks about the power of your test. So type 1 p-value alpha error. How can you remember it? P has only one laddu in it. Okay. Alpha also has only one laddu. So it is 1 error. So p-value is related to type 1 error or alpha error. Remember this. So in this question, what is the wrong option? It is equal to 1 minus beta. No, it is wrong. Okay. Rest all the options are correct. So just a summary, p-value can be, I'm taking significance at 0.05. In that case, when I see p-value is less than 0.05, that means it is what? Significant. Okay. When I say p-value is more than 0.05, it is not significant. Significance means the effect is actually observed. Here, you don't get no effect is observed. And if p-value is less than 0.05, whether if the p-value is significant, what you do? Your null hypothesis. Okay. Null hypothesis is rejected and you accept your alternate hypothesis when it is significant. But in the other one, when the p-value is not significant or when it is more than your permissible level, you actually accept the null hypothesis and alternate hypothesis is rejected. Okay. Last point in this, p-value related to which one? Type 1 error or alpha error. Okay, so that was a brief on biostatistics. Now we'll go to another important topic, that is vaccines. Okay, we'll just discuss some of the most important questions coming from vaccinology. So first question, acute encephalitis syndrome cases are being reported from Gorakhpur, Uttar Pradesh. The health team decides for mass vaccination, which comes under universal immunization program. Identify the vaccine and type of role. Okay, so you have to actually identify, there are actually two questions in this. First one is you have to identify the disease from the given history, and then you should know what is the vaccine and what is the route of the vaccine. Okay, so what is this acute encephalitis syndrome? What are they talking about? Acute encephalitis syndrome is usually put in which one? This your JE, Japanese encephalitis. That is the disease they are talking about. Okay, and they have already told, see, this is coming under the universal immunization program. So under the UIP, the one which presents with this acute encephalitis is none other than your JE. Now the question is simple, right? What is the vaccine type and route of administration of JE? For JE, you have a live attenuated vaccine. Yes. And what is the route of administration? It is subcutaneous. Okay. Route of administration is subcutaneous. So the answer is live attenuated subcutaneous vaccine. Which is the other vaccine that is subcutaneous? You have JE and the one which is given along with JE during the same time, your MR, your measles vaccine. Measles and JE are given subcutaneously. Okay. Now the next question. See, a female child has history of recurrent yeast and respiratory virus infection since the age of 3 months. Immunity status studies are being undertaken, which is the vaccine that is contraindicated. So from the history, you know that this child is having recurrent, respiratory infections, yeast infections, pointing out towards some immunodeficiency, right? The child is being evaluated also for that. So which is the vaccine contraindicated? In simple words, which is the vaccine contraindicated in immunocompromised people? Which one? You don't give what? Live vaccines. All live vaccines are contraindicated in, immunosuppressed people, immunosuppressed patients or patients who are maybe on steroids, and even in pregnancy. Pregnancy also you don't give any live vaccines. So to find out the answer, you should know actually which one of them is a live vaccine, which is a killed vaccine, which is a toxoid vaccine, right? Here the options are TT, you have measles, MMR, DPT, killed IPV. Which one is the live vaccine? Killed IPV you can easily rule out, right? So measles is the live vaccine. So measles is contraindicated in a child with immunodeficiency. So what is the Salk vaccine? You have Salk vaccine and which one? Sabin. Which one is, both these are vaccines for what? Your polio vaccines. One is oral polio and one is the injectable, right? So you have OPV and IPV. Which is OPV, which is IPV? Yes. Salk vaccine is the killed vaccine or the IPV vaccine, and the Sabin one is the live vaccine or the oral vaccine. Okay. So again, IPV, OPV comparison can be a question. You can get some true or false sentences from this. So you should study this. Okay. OPV, Sabin, live attenuated virus. IPV is your killed vaccine. OPV again, just like the name says, it's oral. The other one is your injection. You can give either a subcutaneous or IM injection. Both are can be the route of administration of IPV. Now, the immunity it gives is humoral plus intestinal, or the local immunity is given by which one? Your live vaccine. But their killed vaccine can give only the humoral immunity. What is the complication? Cost and all everything is more for IPV, right? OPV is actually comparatively cheap. It's easy to give. But what is the complication about, OPV? What is the dreaded complication is the VAP, that is vaccine associated paralytic polio. You can say this can be a side effect or complication for your OPV, but it is usually not seen in your IPV. Okay. Now, should know which all are the kill vaccine, which are the toxoid vaccine, which are the live vaccine. So I have a mnemonic here for you. Okay. Toxoid vaccine, you don't need any mnemonic. Toxoid is your DT, your diphtheria and tetanus. Diphtheria toxoid, tetanus toxoid. These are your toxoid vaccines, right? Even recombinant vaccine, you have only one, hepatitis B. Hepatitis B is a recombinant vaccine. So both these, there is no confusion. You should know. Recombinant is hepatitis B and the DT is your toxoid vaccine. Now coming to the live vaccine and kill vaccine. This is where you go wrong. Okay. So remember it like this. The code for the mnemonic for live attenuated vaccines are live, replace live with love. Okay. Be my top Valentine. That is your, see, it's a romantic mnemonic. Be my top Valentine. That is your mnemonic for your live attenuated vaccine. B stands for BCG. M is for MR, measles and mumps, rubella also. Y for what? Yellow fever. T is for typhoid oral and typhus. O is for OPV. P is for plague and V. This last V is for varicella. Okay. Be my top Valentine is a mnemonic which can be used to remember your live attenuated vaccines. So once you know the live vaccines, you know the tetanus toxoid vaccines, you know the recombinant vaccines, rest of the vaccines will be killed vaccines. Okay, next question. In one single visit, a 9-month-old unimmunized child is coming to you. He can be given which of the following vaccination? Again, unimmunized child. You can definitely expect a question on this. They'll give you an unimmunized child at some age group. And when the child is coming to you, which all vaccines can be given at this point of time? See, at a point of time, you can give n number of vaccines. Okay, you can give them together. But once that is over, between the next time, you should have a gap of at least 4 weeks. Okay. So in this case, you should know which all are the vaccines that can be given up to 9-month-old. So for that, you should know this, which is what is the age limit for each of the vaccines. BCG can be given up to, BCG will be given only up to 1 year. After that, there is no point in giving BCG. OPV is given up to 5 years, okay? Hepatitis B, you're giving this to prevent, hepatitis B infection in the child or the mother-to-child transmission. This should be given within 24 hours. This is important. Then your measles can be given up to 5 years. DPT you have, DPT can be given up to 7 years. J is the longest, okay? J you can give up to 15 years. TT, there is no age bar. And then you have Penta, which I have not written here. Penta can be given up to 1 year. Then you have Rota, again up to 1 year, okay? Now this is a simplified. These are all the vaccines that are there in your national immunization schedule. Repeat with me. Hepatitis B, 24 hours. BCG for 1 year, up to 1 year you can give. Rota for 1 year, Penta for 1 year. DPT, 7 years. Measles, your OPV for 5 years. JE for 15 years. So if you get a child, who have crossed 7 years, maybe 9 years or something, 9 years, 10 years, whatever, when the child is brought to you, you can give JE and TT. That's only 2 vaccines that you have to give. Okay. And what are some of the side effects of these vaccines? Some of the named side effects you should know. What about BCG? BCG is notorious to cause what? Lymphadenitis. OPV we told what? Paralytic polio, right? Then your measles, one of the complications with measles is your SSP. Then TPT, in the pertussis component, the pertussis actually, it's not the whole TPC. It can cause neurological complications. Plus, the child can continuously cry. You won't be able to manage the child. Okay, insoluble cry can occur. So these are some of the named complications. And yeah, Rota. Rota, what is the name complication? Rota, you're scared about your intussusception. That is the complication associated with your rotavirus vaccine. And very important slide, what is the national immunization schedule? They can ask you any question from national immunization schedule. You should know the whole schedule. You should know all the vaccines, the route of administration, the dose, everything should be clear to you, okay? When all do you give vaccines? You have at birth, 6 weeks, 10 weeks, 14 weeks, then 9 completed months, 5 years, 16 to 24 months, 5 years, then you have 10 and 16 years. And then you have something that is a vitamin A, which you give every 6 monthly after 9 months onwards. That is 9 months onwards, you get every 6 monthly what vitamin A. So national immunization schedule should be by heart to you. Just tell me which are the vaccines. At birth you give BCG, OPV, Hep B, right? 6 weeks you have OPV1, you have your Penta1, fractionated IPV1, PCV1 and your Rota. Then 10 weeks, again OPV2, rotavirus 2 and Penta 2. Your RVV, the IPV and the PCV will again come back in your 14th week only. So 14th you have OPV3, Penta 3, fractionated IPV2, your PCV2 and Rota 3. At 9 completed months, you can give what? 9 months is the time you give your MR1, PCV booster and fractionated IPV3. This has actually been recently added. Initially, we only had fractionated IPV 1 and 2 given at 6 weeks and 14 weeks. Now we also give at 9 completed months, you give the third dose, that is fractionated IPV3. This is a recent update, okay? Then 16 months you give, 16 to 24 you give the MR2 and JE2. 5 years what you have the DPT booster. 10 to 16 years you have the TD vaccine, and every 6 months vitamin A. Vitamin A, what is the dose? First 9 months you start with 1 lakh international unit. After that you give 2 lakh international unit. So totally you give up to 5 years. If a child is taking all the vitamin A doses, he or she gets 70 lakh international unit of vitamin A. And 2 oral vaccines you give, OPV, RVV, Rota and oral polio vaccine. OPV is only 2 drops, Rota is 5 drops. Now this is just a diagram, I'm not going to explain it. This diagram shows the route of administration for all these vaccines. Rota, OPV, vitamin A through oral route. Then intradermal, what you have BCG, JE, you have subcutaneous in the upper, both in the left side. Right side you have intradermal IPV and measles subcutaneous. Then you have no antiviral aspect of thigh. Rest of the vaccines you give in the thigh. Right side you give PCV. Rest the hepatitis B, Penta, DPT, everything you give on the left side. Maximum vaccines you give on the left side, okay? Now, which is the most heat sensitive vaccine? So, vaccines, the storage of the vaccine is very important. If they have a particular temperature range and all in which you're supposed to store it, if that is not maintained, your vaccine can get, damaged. It can cause actually harm rather than your benefit. So, which is the most heat sensitive vaccine among these? BCG, polio, measles and DPT. The answer is polio. Polio is the heat sensitive vaccine among the given list. Now, this is a image showing, temperature sensitivity of each vaccines. Sensitivity to heat and sensitivity to cold. The T vaccines, T vaccines are actually, remember T for temperature. T vaccines actually like temperature. The TT, your hepatitis, So hepatitis and all these are, they don't care. They don't mind temperature. They like temperature, but they're sensitive to cold. But your OPV, your IPV, these are actually very sensitive to heat. So this is the order of sensitivity of the vaccines to cold. Reconstituted BCG followed by yellow fever, then OPV. In the options given below, you did not have this reconstituted BCG. It was simple BCG. So in the question that we have discussed, the answer is polio. If these are there in the options, then your answer will change. So this is the order: reconstituted BCG, yellow fever, OPV, measles, and reconstituted measles, then hepatitis B, DPT, DT, BCG, and finally TT. Most thermostable vaccine is TT. Most thermolabile vaccine is reconstituted BCG. It's not the simple BCG, it's the other one. It has been used, that is the reconstituted one. Okay, what is this? This diagram? This shows a Iceland refrigerator. Again, the vaccines are arranged in an Iceland refrigerator according to your temperature of the vaccines. Then open vial policy is not applicable for which one? PPT, OPV, BCG, pentavalent. What is this open vial policy? The open vial policy is there. It says that, see, once you open a vial of the vaccine, certain vaccines you can actually store the vaccine and reuse it up to a period of 28 days. If I open a vaccine and something is left, I don't have to throw it. I don't have to waste the vaccine. I can actually reuse it up to a period of 28 days, provided I store this vaccine in the proper, maintaining all the cold chain in the proper temperature, and the vaccine vial monitor and all is proper. That is open vial policy, but it is not applicable. That is the most important part. It does not apply to your BMJ vaccines. B for BCG, M for measles, and J for JE. These three vaccines, you cannot do the open vial policy. That is, once BCG is opened, even if it is waste, you cannot reuse it again. You have to throw it. Similarly, in case of measles and JE, so BMJ is a famous journal. I hope you know it. So BMJ is the code for remembering the vaccines that do not follow open vial policy. BCG, measles and JE do not follow open vial policy. Usually the open vial policy is applies to the other vaccines like DPT, TT, OPV, pentavalent and all. Once it is open, if you're storing it properly, then up to 28 days, you can actually reuse it. It is after this vaccination session, I go and store it, and the next week when I come, I can use the same vaccine. Okay. What is this image showing you? It is the vaccine vial monitor. Okay. This shows whether your vaccine can be used or not. Especially in case of these reconstituted, those with the open vial policies, this is very important, right? When can you use and when can you not use? So the VVM actually has a outer circle and an inner square. When the inner square is white, or it is of a lighter color than the outer circle, you can actually use the vaccine. In these two cases, you can use the vaccine. But if the circle and the square are of the same color, or your square is darker than the circle, that means something has happened, something is wrong with the vaccine, it has not been maintained properly, discard it. You cannot use in these two conditions. Okay. So that was vaccine. So one thing very connected to vaccine is your biomedical waste management. Again, simple topic, high yielding topic. If you know a few points in biomedical waste management, you can easily score that MCQ answer, right? So the question is, as per BMW or biomedical waste management guidelines, latex gloves after use is discarded to which bin? Yellow, red, white, blue. What is the answer? Glove. It's a glove. It is not contaminated. Glove is what? It's a recyclable waste, right? You can actually recyclable or recyclable go into your red bag. R for recyclable, R for red. So gloves is in your red bag. So this table, you have to learn this. You'll be provided with the PDF of this class. So just go through it, and all tables and important points that are given, try to study those. So you have your yellow bin, red, white and blue. Yellow is mainly for human anatomical waste. All human anatomical waste, which can be infectious, non-infectious, all the human anatomical waste go to your yellow bag. Even if, things contaminated, the soil with human blood, or, the cotton with human blood, all the soil waste also go into your yellow bin. And your medicines, this is where people go wrong. Anatomical waste, yellow bin, you'll remember. But this point you tend to forget, okay? Expired or discarded medicines, the chemical waste, these also go into your yellow bag. Okay. Now for red, you have recyclable. The things that can be recyclable, those are put in your red bag. Which all are coming under that? Can be tubings, bottles, IV tubes, your gloves, syringes, urine bags, all these without needles. Because you should make sure that there is no pointed thing when you're putting in a red bag. These all go into your red bin. Then white is for sharps, including all metals. And the blue is for your glassware. Okay. So if there is a question asking you, so there's a syringe with a needle, which one will you put? If there is needle along with the syringe, you are supposed to put it in the white bin, because it can actually, it's a sharp, no. But if that's a syringe without a needle, then you go for the red bag, or because syringe is recyclable. So in that case, you go for the red bag. But if they say syringe with a needle is there, which one you will put? Of course, it is your white. Now we'll discuss some questions from contraception, family planning, and contraception. First question, 10 women got pregnant out of 100 women. Mean interval was 2 years. Calculate the Pearl index. So what is Pearl index and how do you calculate Pearl index? Okay. So Pearl index is the number of pregnancies, into 12 in a year divided by the number of women during that period. So this is the formula for Pearl index. You should know it is the number of pregnancies per number of women. Number of pregnancies that happen per number of women during your study period. So all the values have been given here. What is the number of women in this question? 100 women, right? So number of women is 100. Duration they have told 2 years. So it is 24 months. Number of pregnancies were 10, right? So 10 got pregnant. So your Pearl index is number of pregnancies is 10 into 12 divided by number of women was 100 into duration of study months. 2 years is 24 months. The whole thing into 100. This is your formula, and when you do it, you get the answer of 5. So the Pearl index is 5. Learn the formula for Pearl index and how to calculate it. Okay. Now, next question is, for a net NRR to be 1, the couple protection rate should be how much? Options are 60%, 100%, 40%, and 80%. This is actually a theoretical question. For your net reproductive rate to be 1, your couple protection rate should be more than 60%. Okay, the answer is A, 60%. So what is this couple protection rate? It is the percentage of eligible couples effectively protected against childbirth but by any of the approved method of family planning. It is how many of the couples who are eligible for contraception are actually taking contraception. This is your couple protection rate. So if in a community or in a country, at least if 60% people, if 60% use, eligible couples are using contraception, or 60% is the couple protection rate, then your NRR becomes, or net reproductive rate becomes 1. That's what was asked in this question. Basically, NRR is the couple protection rate is the indicator of the prevalence of contraceptive practice in a community. We have to, our aim is to achieve NRR 1, okay? Net reproductive rate should be 1 so that we can stabilize the population. To achieve that, first thing we have to do is, we have to make sure the couple protection rate is above 60%. Now, what are the fertility indicators? I've been talking about NRR, right? What is this NRR? What are the other fertility indicators? See, even your crude birth rate is a fertility indicator, okay? But now, at this point of time, I'll be discussing 4 fertility indicators. You should know what each one is. You can get questions from each of these, and this is quite confusing thing. So I'm going to discuss 4 fertility indicators. The first one being your GFR. Second one is your TFR. Third, GRR. And fourth will be NRR. What is GFR? GFR is the gross fertility rate. TFR is the total fertility rate. GRR is the gross reproduction rate. NRR is the net reproduction rate. Okay. Now, what is the GFR? GFR is the total number of children a female will bear during her reproductive years. The total number of children a female will have during her reproductive years. That is your GFR, or gross fertility rate. There is no age-specific things or any mortality rate in the community. It's just simple as that. Total number of children a female will bear during her total reproductive years. That is your gross fertility rate. If I have 2 kids in my whole reproductive period, then my GFR will be 2. Okay. Now, what is this total fertility rate? This is also quite similar to GFR. The first part is the same. It is total number of total number of children a female will bear during her reproductive years, assuming the current age specific fertility rates. Okay. In TFR, you are assuming the current age-specific fertility rates and then calculating, okay? So GFR and TFR is the total number of children One is assuming your current age-specific fertility rate. One is not assuming such things. Next, you have your GRR and NRR, the gross reproductive rate and net reproductive rate. In both, no, there is R. So, it is the total number of daughters. Your GRR is the total number of daughters a female will bear during her reproductive years, assuming the current age-specific fertility rate. So GRR, or the gross reproductive rate, is the total number of girl child or daughters. That is easier to remember, right? Total number of girl child or daughters a female will bear during her reproductive period, assuming the current age-specific fertility rates. What is NRR, or net reproductive rate? The net reproductive rate is the total daughters a newborn girl will bear during her entire life. Assuming you fixed age-specific fertility rate and age-specific death rate. So NRR, or net reproductive number, this is out of all the fertility indicators, this is the most important one. This is the total number of daughters a newborn girl child will bear during her entire life, assuming the current age-specific fertility rate as well as the mortality rate. See, NRR is kind of a replacement thing, okay? Net reproductive rate. That is, if I give birth to a girl child and if a person gives birth to a girl child and that girl child should be alive, and how many more girl child she can have, that is your net reproductive rate. It is basically, my generation is over, now comes the second generation. So if it is 1, that means I give birth to one child, she gives birth to another one child, that means your population is stable. It is not propagating. Instead, if it is 2 or 3, I give birth to 2 girls and again they give birth to 2 more girls. It's like it's increasing, right? The population is going to increase. If that is not the case, if it is 1, I give birth to one child, she gives birth to one child. So each generation, your population is becoming stable. It's just replacing the older generation. It's not propagating, it's not increasing. So that is what we want. We want the NRR equal to 1. Then only we can attain population stability. And for that, your CPR, your couple protection rate, should be above 60%. Okay. So that is fertility indicators. Now let's go to a question regarding the demographic cycle. What is true about late expanding phase of demographic cycle? Option A, birth rate is lower than the death rate. Option B, death rate begins to decline while the birth rate remains unchanged. Option C, death rate declines still further and the birth rate tends to fall. Option D, high birth rate and high death rate. Here the answer here is death rate declines further and the birth rate tends to fall. This is the answer. So to find out the answer, you should know what is this demographic cycle, what are the phases of demographic cycle. Only if you know that, then only you'll be able to answer questions like this. So this is your demographic cycle. Basically, demographic cycle is it's a graph showing different phases of your demographic progression. And this side you have your birth rate. It shows your birth rate, the death rate, everything. So there are 5 stages of a demographic cycle. Which are the 5 stages? You have high stationary, so demographic cycle has 5 stages, okay? Which are the high stationary, then you have early expanding, late expanding, low stationary, and declining. These are the 5 phases of a demographic cycle. You should know each one. Okay, see here, this graph here showing the blue line, not the blue line, this one is the birth rate, and this purple color line shows the death rate. These are the stages: stage 1, stage 2, stage 3, stage 4, and stage 5. Stage 5 is your what? High stationary. So initially, all countries will be in this phase, right? That is, you have high birth rate and high death rate. Both are extremely high, and that is your high stationary. So the population is here. Then afterwards, what happens is your birth rate is still high, but the death rate tends to fall. So your birth rate is still high. Once your death rate tends to fall, then you enter the second phase, which is your high stationary. Still it is at a higher level. One is falling, the other one is not falling. Birth rate is high, but death rate starts falling. That is your high stationary. Then what happens is your both birth rate is also falling, death rate is also falling. So, but the fall in death rate is more. You see, death rate is falling more than birth rate. Birth rate is falling, but it is less. In this case, it is called it becomes a low stationary. Sorry, late expanding phase. Early expanding. So you have high stationary, then you have early expanding, then you have late expanding, okay, then you have low stationary, and finally you have declining. Okay, so initially birth rate and death rate both are high stationary. Then birth rate is there, but death rate tends to fall. That becomes your early expanding. Then afterwards, what happens is both are falling, but death rate falls at a higher rate. So that becomes your late expanding. Then you have low stationary and then declining where both are falling. Okay. So this table you should know. High stationary, birth rate and death rate both are increasing. Early expanding, death rate is falling, birth rate no change. Late expanding, both are decreasing, but death rate is falling more. Low stationary, both are falling, and declining happens once your birth rate is falling more than your death rate. And next question you can get is, where is India now? India is currently in the late expanding or stage 3 at present. Initially, before the 1920s, we had a very high population. We still have high population, but the phase was different. We were in the high stationary phase before the 1920s. But afterwards, we shifted and now we are at a late expanding phase. See, certain countries like Germany and Hungary, they are actually at a declining phase. So they are trying to increase the population. And the best phase is this one, stage 4 or low stationary. Most of the developed countries, UK, Sweden, Belgium and all are in this low stationary phase. So this stages of demographic cycle, what happens to death rate, what happens to birth rate, and some important countries like where is India at present. These things you should be knowing. Okay. Then there is something called dependency ratio. Dependency ratio is how many people are dependent on your the earning population, or it is obtained by number of dependents or non-working age group divided by total people aged between 15 to 64 years. This 15 to 64 years, the people, these are the ones who go for work, right? This is the productive age group. They go for work, they earn, they get money. So this 15 to 64 is the productive age group. The other one, the numerator, is the number of people who are dependent on them. That is those who are either below the 15 years, that is children, they're not going for work. And those are elderly, more than 64. That is, they are also not fit for work. That are not, we are assuming they are also not going for work. They are dependent on your productive age group. So this is your dependency ratio. It gives the amount of dependence in a population compared to the population, compared to the productive age group or the 15 to 64 years. And now we have some questions from contraceptives. One is, what is the characteristics of an ideal candidate for copper T insertion, including all of the following except for copper T insertion? Which one you won't prefer copper T? Has born at least one child? Yes, you can give copper T. It's one of the best options for spacing. Is willing to check tail? Yes, if you are giving, if you're putting a IUD, a copper T is an IUD basically, that women should be willing to check the IUD tail. Has normal menstrual periods? Yes. Has history of ectopic? No. Ectopic pregnancy is a contraindication for using the IUD. So absolute contraindications for IUD are suspected pregnancy, you don't give IUD, you don't put an IUD. Pelvic inflammatory disease, you can't. Vaginal bleeding of unknown etiology, any cancers, previous ectopic. All these cases are contraindications or absolute contraindications for IUD. You should know all these. Then we have certain relative contraindications. So one is anemia. Why? Because the most common side effect of IUD is bleeding. So when there is bleeding, when there is anemia, menorrhagia and all this, you don't prefer IUD. Then if there's a history of PID in the last pregnancy, purulent cervical discharge and all, you don't actually prefer IUD. But the absolute contraindications should be known to you by heart. And all are true about sencroman. Sencroman is another contraceptive. Yes, It is a non-steroidal contraceptive, correct. Developed in India, yes. Failure rate is 1.83, 2.84, correct. Useful for females with PCOD, no. Sencroman is a contraceptive, you don't give it for females with PCOD. This is the Sencroman tablet. It's also known as, it is sold in the brand name of Chaya, and the content is the ormeloxifene. This is the component of this tablet. Now Mala N, OCPs, we have Mala N, Mala D. What is the difference between Mala N and Mala D? Is there a difference between the dosages of estradiol or gestrel? No, it's almost the same. Sold under social marketing scheme. Both are sold under social marketing scheme. Supplied free of cost. No. One of them is supplied free of cost, one is not. Which is free, which is not. Okay. The Mala N. N stands for no cost. This is absolutely free. The other one you have to pay a small amount of money. So Balan and Mana D, both are combined OCPs. Both have estrogen and progesterone. But N is given free of cost, whereas the Mala D, you have to give 5 rupees per packet. That is the main difference between Mala N and Mala D. Okay. Next question is postpartum sterilization. Which is the ideal time to perform postpartum sterilization as per Government of India guidelines? The answer to this question is 24 hours to 7 days. From 24 hours to 7 days of delivery. This is actually the ideal time to perform postpartum sterilization. You have no different types of female sterilization. One is postpartum. Ideal time is 24 hours to 7 days. Then you have interval sterilization. That is during your menstrual period. First 7 days of the menstrual period. Interval sterilization you can do. Then sterilization can be done along with MTP as well as following spontaneous abortion. These are also types or timings for female sterilization. So with that, we have completed family planning and demographics. Now we'll just take a short break. Welcome back. Now we have another question. This question is from your disaster cycle. Okay. Arrange the following phases of disaster cycle in a logical sequence. You have 4 options given. So for this question, you should know what is the logical sequence of a disaster cycle. So the answer here is actually disaster impact, response, rehabilitation, mitigation. Okay. So what are the phases of a disaster cycle? You have here the disaster occurs. First thing what you should do, you should respond, right? You have to give the immediate response. So first comes the response, then comes the rehabilitation and recovery. Then you go for prevention and mitigation. In mitigation, you have, this is how the disasters happening. These are the side effects. So you design some engineering measures and all that. So that next time this does not occur. Then you do preparedness. So this is the cycle: response, rehabilitation, recovery, prevention, mitigation, preparedness. This is your disaster management cycle. Next question is, again now we have 2-3 questions from occupational health. First question, useful screening test for lead is measurement of what? So lead poisoning is the question. They have asked for screening test. Okay, which among this is a screening test for lead poisoning? The answer is A, CPU or coproporphyrin in urine is the screening test for lead poisoning. Okay, so these are the lab tests in lead poisoning. You have CPU, it is the screening test. Okay, then you have ALAU, that is amino levulinic acid in urine. The level is also given, it's more than 5. This indicates lead absorption. Then the blood lead in blood, this is important. The content of lead in blood, once it becomes more than 70, that is when your clinical symptoms appear. When the content is more than 70, then the patient start to showing manifestations of lead poisoning. Then the lead in urine is more than 0.8. Then you get something, when you take a peripheral smear, you get a finding called basophilic stippling of RBCs. This is again showing what? Lead poisoning. So your answer was coproporphyrin urine, that is a screening test for lead poisoning. Now what are the clinical manifestations of lead poisoning? I have a mnemonic for you, that is ABCDEFGHI. This is the mnemonic to remember the clinical manifestations of lead poisoning. What is A? A stands for anemia, amenorrhea. Patient can have anemia, amenorrhea. B, for basophilic stippling in the peripheral smear. Then you get something called a Burton's line. You see here, this is the Burton's line. You see a grayish blue line on the gums of the patient. That is a finding in lead poisoning. Then C is for colic, constipation. D for drop. See, colic. Patient has colicky pain. Lead poisoning is also known as painter's colic. You know why? Occupation, painters. Paint can have lead. So painters, it is seen. And the symptom they present with is usually a colicky pain. So painter's colic is lead poisoning. Then D for drop. You can have wrist drop. E is for encephalopathy. Encephalopathy is usually not seen in adults. It is a feature of children. It's seen in pediatric lead poisoning. And F is for facial pallor, again connected to anemia. G for growth retardation, H for hyperuricemia, and I for infertility. This we've already told. The level of lead in blood, which can manifest with clinical signs and symptoms, is more than 70. Okay. So next question. Which of the following pneumoconiosis is caused by micropolyspora fini? So they have given pneumoconiosis and they've given a organism, right? So the answer is what? The answer is farmer's leg. So, and next question is bagasosis. Bagasosis can be prevented by spraying what? Bagasosis is another pneumoconiosis. Bagasosis is caused due to what? Sugarcane dust. Okay. It can be prevented by spraying 2% of propionic acid. Okay, this is the question. Now, few words about pneumoconiosis. Pneumoconiosis, also known as dust diseases. These are some of the diseases under occupational health. You have different types of pneumoconiosis. For basically what happens, dust enters your lungs and then causes symptoms, manifestations, and you get the disease. Okay, usually due to some occupational exposure. What is the size of the dust that is entering your body in pneumoconiosis? That is important. That is 0.5 to 3 micron. This is the size of the dust. It can be any dust. It can be silica dust, asbestosis dust, whatever. Size is 0.5 to 3 micron. This is the size that causes pneumoconiosis. So we have listed the most common types of pneumoconiosis. One is silicosis, anthracosis, bisonosis, bagasosis, asbestosis, and farmer's leg. So silicosis, as the name indicates, due to exposure to what? Silica. Silicosis is the most common type of pneumoconiosis in developing countries like India. Okay. In developed countries, it is asbestosis. Asbestosis is due to exposure to what? Asbestos. Yes, it is most common in developed countries. Okay. Why are you worried about asbestosis? Among all these, this is the one which causes most of the cancers. It can lead to mesothelioma of lung. Then it can cause cancer of the bronchus. It can cause cancer of GIT. In many other cancers, asbestos has been linked to many of the cancers. Okay. Then farmer's lung is due to moldy hay. Then anthracosis is due to coal dust. Anthracosis is also known as black lung. Okay. Coal is black, right? So black lung. These are the two things which you confuse. You have bagasosis and bisonosis. One is due to inhalation of cotton fiber dust, so people working in the cotton industries. The other one is due to sugarcane dust, people working in sugarcane, paper making industries. So remember G, bagasosis is for sugarcane. And bisonosis is the one you get due to inhalation of cotton fibers. Okay, I hope this is clear. You should know details about all the pneumoconiosis and some of the characteristic findings. Okay, for example, in asbestosis, characteristic finding is in sputum of the patient, you get something called as asbestos bodies. This is what you can see on screen. Okay, this is a finding of it's a clinical finding where you get, it's a finding, laboratory finding in case of an asbestos patient. Now you have to know some of the antigens related to the diseases, like the question which we just discussed. Farmer's lung, Micropolyspora feni, bagasosis, Thermoactinomyces sakari, compost lung, Aspergillus, and chemical workers lung, isosonate. Study this table, okay? Now, occupational health, we have two acts. One is the Factories Act, one is the ESI Act. You should know the major points of all these acts. This question here is, under ESI Act, the state government share of expenditure on medical care is how much? It is 1/8. Okay. So ESI Act, study what all are the benefits under ESI Act. You have sickness benefits, you have extended sickness benefit, you have maternity benefit, then funeral expenses are covered. You should know what is the period of time for each of this. For example, maternity benefit is given for how many weeks? 26 weeks. Then funeral expenses, how much money do you get? That's 15,000. Then what is the share of the employee and the employer in for ESI scheme? So the employee has to spend 0.75% of his wages. This is employee. Whereas the employer, how much? 3.25%. Okay. And where are under ESI Act, what happens? These the people registered under the ESI Act, they can get free medical care, medical checkup, everything from either the ESI clinics, or there are hospitals embedded. ESI hospitals are there, or hospital embedded to this ESI Act. So from there, they can avail free medical services. Okay. Now, next question. All of the following are approaches to health education, except. So what are the approaches to health education? Mainly you have 4 approaches. One is your service approach, then you have your regulatory approach, health education approach, and primary healthcare approach. Mass media is the wrong answer. Mass media is not an approach to health education. Okay. See, what all are these approaches? Regulatory approaches, you are forcing on some laws on the people so that they follow health education. For example, taxes is an example, or wearing helmet. If you don't wear helmet, you'll be charged. Okay. So that is a regulation that you're putting in to bring about a change or a health education. So that is regulatory approach. Service approaches, you are providing services at your doorstep. For example, ASHA worker distributing condoms at doorsteps. That is a service approach. What is the disadvantages? You are not checking for the felt need. You're just giving the service at the doorstep. You're not finding out whether the person actually needs it or not, or whether the person actually perceives it as a felt need. So that is your service approach. Then you have 2 more approaches, that is health education approach and the primary healthcare approach. And the primary healthcare approach, they are also involved. It's a kind of there is community involvement. Whoever is your beneficiary is also involved in the primary healthcare approach. Okay. This is a question from sociology. What do you mean by acculturation? Acculturation is nothing but the culture contact. Okay. When there is contact between different cultures, that is termed as acculturation. When does this occur? Culturation is what? Cultural contact or mixing of two different cultures. It can occur through trade, commerce, during industrialization, propagation of religion, education, conquest. There are different stages, but you should know cultural contact is acculturation. Okay. Now, family cycle. Next question is from sociology is your family cycle. Arrange the following stages of family cycle in chronological sequence. This is a very simple question. If you know the meanings of each of these words, you can actually answer this very easily. Okay. What is the answer? Formation, extension, complete extension, dissolution, contraction, complete contraction. What is the answer? Answer is your formation, extension, complete extension, contraction, complete contraction, dissolution. Okay. We'll just see in fast what are the phases of a family cycle. The beginning of the phase and end of the phase. So when does a family formed? Okay. There's this guy and there's this girl. Okay. They get married. So marriage is the first step, right? Here the family is formed. This is the formation phase. So when they have their first child, the stage is extended. The family has been extended now, right? Extension. Now when they have their last child, after first child, they have maybe 1, 2, 3, 4 children they have. So now they have birth of last child has occurred. Then what happens? There is complete extension. You can't extend anymore, okay? So formation, first child is extension, last child is complete extension. After that you have what? Contraction. Now children tend to leave, right? So the first child leaves, so maybe got married and left off for education purposes, somehow he's leaving. So in that case, the family starts to contract. And when the last child, when all of the children leave the home, then it becomes completed contraction, okay? And finally, if one of them, the husband, wife, if one of the member dies, what happens then? There is a dissolution, then there is no more family. Then probably the children will have their separate families. That is different. So now I think you got an idea of the family cycle, right? Don't forget the order. First is formation, then extension, complete extension, contraction, complete contraction, finally dissolution. Okay. Next question. UNICEF Go Big campaign. Yes, Go Big campaign. O stands for what? Okay. Go Big. It's not just Go Big, it's FFF. Go Big is a campaign by UNICEF. It is an example of selective primary health care. Okay. We have two types of primary health care. It can be comprehensive primary health care or selective primary health care. Go Big is an example of selective primary health care. What does each of these letters stand for? G is for what? Growth, monitoring. O is your ORS. That is what they've asked, right? O is for oral rehydration therapy or ORS. B is for breastfeeding. I is for immunization. We have 3F, family planning. Then you have food fortification. And last F is for female literacy. Okay. This is the full form of COBIF. This is also frequently asked. Now, next one. All of the following are most important potential agents which can be used for bioterrorism, except. So, which one is not a bioterrorism agent? Which one? Smallpox, plague, botulism, tuberculosis. Yes, TB. TB is not a bioterrorism agent, okay? But all the other three, all three are bioterrorism agents. The answer is TB. So you have category A, category B and category C. Bioterrorism agents, you can classify them as category A, B, C. So and then under each of the category, you have certain agents. So you should know which is the category A agent. They can even ask you that. They'll give you an agent and you might be asked to answer whether botulism is a category A, B, C or none. So how do you study this? So you have category A, B, C. First we'll study category C, okay? Category C, these include emerging pathogens which are having high morbidity and high mortality. Emerging ones, the new ones. We have only two examples under category C. Remember it as A. H and A, okay? One is Nipah. And then you have Hanta. So AH or HA, two viruses you have, two viruses you have for bioterrorism under category C. Nipah virus and the Hanta virus both have this AH in common. Okay, now category C is over. For category A, the agents are botulism, tularemia, anthrax, smallpox, plague, viral hemorrhagic fevers. These are, the category A are like very dangerous. They can be easily disseminated. You just leave one smallpox virus in a country, you cannot imagine the destruction it can cause. So it can be easily disseminated, high mortality rate. It can cause public panic, disruption, everything. So category A is very dangerous. Smallpox is the best example you can give. And how do you remember them? You have a mnemonics. Bioterrorism agents include smallpox virus. This is a mnemonic to remember. Your category A agents: B for botulism, T for tularemia, A for anthrax, smallpox, S is for smallpox, P is for plague virus, V is for viral hemorrhagic fevers. All the others come under your category B. Category B actually moderately easy to disseminate, but actually they have a morbidity and mortality is lesser than compared to your A and C categories. Brucellosis, Clostridium, your Q fever, resins, staphylococcal, everything comes under this B. Okay. Now one question on primary healthcare. So what are the elements of primary healthcare except? So they are given some elements of primary healthcare, and which is the exception? Adequate supply of safe water and sanitation. Yes, it is an element. Prevention and control of local endemic diseases. Yes, again, it is one of the elements of primary healthcare. Immunization against major infectious diseases. Of course, yes. Providing employment to every youth. No, this is not a component of. This is not an element of primary healthcare. So primary healthcare you should remember 8 elements of primary healthcare and 4 principles of primary healthcare. Okay, this is a frequently asked point. 8 elements can be remembered with the mnemonic ELEMENTS elements. Okay, E for education regarding concerned health problem, L locally endemic diseases, E for essential drug, M maternal child health, E EPA or your immunization, N nutrition, T treatment of common illnesses, S is for safe water and sanitation. So this is the code to remember the 8 elements. What are the 4 principles of primary health care? So you can remember it with the mnemonic care. What are these? You have community participation, appropriate technology, so equitable distribution, and intersectoral coordination. Okay, these are the 4 principles of primary health care. Now, next question. One PHC is located for a population of how much? 5,000, 30,000, 1 lakh, 500. Easy question. Population of PHC, 30,000. Okay. By heart this table. So, subcenter, PHC, CHC and Anganwadi. You have to know what is the population limit. Like, if I say population is 5,000 for subcenter, that means for every 5,000 population, there should be at least 1 subcenter. Similarly, for every 30,000 population, there should be 1 PHC. For 1,20,000 population, there should be 1 CHC, the higher one. Okay. Again, the norm is different for the hilly area and plain area. Hilly area, it's a bit lesser because you have lesser number of, inhabitants there. No. So you should remember this value. Subcenter 5,000 for normal area and 3,000 in hilly area. PHC is 30,000 and 20,000. CHC 1.2 lakh and 80,000. Anganwadi, it is for 400 to 800 and 300 to 800. Remember all these values. Okay. Okay, now we'll go to the next important chunk of questions in PSM. That is from your communicable diseases. Okay. As far as NEET-PG is concerned, majority of questions come from communicable diseases, nutrition, your national health programs, then your epidemiology and biostatistics part. Okay. So the main part is actually coming. Yeah. So you have to study different communicable diseases. I'll just rush through one question or 1 or 2 questions each for each of the diseases. But you should know, sir, there are certain things that are important. Something that is pathognomic of a disease, or the incubation period, or a particular vaccine, period of communicability, isolation, or the prophylaxis, the treatment of choice, and the chemoprophylaxis. There are some points which are important in all the diseases which you are supposed to learn. Okay. So we'll start with chickenpox. Chickenpox is characterized by all except options. Scabs are infective, pleomorphic stages, rashes symmetrical, centripetal dewdrop, palms and soles not affected by the rash. It is A. Scabs are not infective in chickenpox. Okay. So this question is basically asking about the rash of chickenpox. Okay. So you see the image here. This is a typical rash of chickenpox. What happens in chickenpox? You get different forms of the rash in the same person at a time. When you take a photo, you see different. You can see some macules here, some have become papules, some have become pustules, some have started crusting. So you see different forms of the rash at the same time. This is called pleomorphism. Pleo means different, morphism means forms, right? So pleomorphism is one characteristic feature of the chickenpox rash. Another feature is, what is this transition? First it becomes a macule. Macule is something flat, right? Then it starts rising from the surface, it becomes a papule. Then you get a pustule when there is pus filled. Then you have a vesicle, and finally you have a scab, that is, it bursts out. Once the lesion reaches a scab phase, then the virus cannot survive. So once all the lesions in the body becomes the scab phase, then that patient is not infectious anymore. So your first option, no, scabs are infective. No, scabs are not infective. Okay. Actually, the period of isolation is decided based on that. Once every lesion is crusted, once everything becomes scab, then you can actually end the period of isolation for that patient. So what are the features of chickenpox rash? One, I told you, pleomorphism. Then it has a centripetal distribution. Okay, you see, even smallpox also, it's similar to chickenpox, right? But the lesions are more painful and it's kind of different, but still you can get confused. So smallpox and chickenpox, when you compare, the lesion of chickenpox is centripetal distribution, that is more towards the center of the body. In smallpox, it is centrifugal, that is more lesions you get in the extremities. So smallpox is centrifugal. So pleomorphism, I told you, centrifugal. Then palms and soles. Palms and soles are usually spared in chickenpox, but in smallpox, as I told you, it's centrifugal. Even palms and soles, you get this lesions. This is an image of smallpox, okay? And this is chickenpox. In chickenpox, we got pleomorphism. In smallpox, there is no pleomorphism. You see, all these lesions, at a time, they are of the same shape. Either all of them are macules or all of them are papules, whatever. But you don't see this pleomorphism thing in smallpox. Then what is this rose petal doing here? Okay. There is something called dewdrop or rose petal. This description denotes your chickenpox rash because dewdrop, that is the vesicle, fluid-filled vesicle, looks like a dewdrop on the erythematous or the red end surface of the skin, rose petal. So dewdrop on rose petal is seen in chickenpox again. Okay. So other than that, about chickenpox, we have a vaccine. Yes, it's a live vaccine. The strain is Oka strain. Then we have two more things which you have to study about chickenpox. One is the congenital varicella syndrome. Next one is the herpes zoster. That is, the virus can remain latent in the sensory ganglia, and finally, once you're aged or once you become immunocompromised, then this thing can reactivate and cause something called a herpes zoster. Okay. Now, moving on to the next question. Which of the following is not true of measles? It has a high secondary attack rate. Only one strain causes infection. Not infectious in prodromal stage, and infection confers lifelong immunity. The answer is not infectious in prodromal stage. Measles is actually very infectious in the prodromal stage also. It has a high attack rate, correct? You have only one known strain causing the infection. Once you are infected, then you get immunity for lifelong. All those are correct answers, okay? So what is this 4C of measles? 4 C's. Actually, it is 3 C's, okay? Cough, coryza, conjunctivitis. This is, the 3 C's are the symptoms you get in measles. But the 4th C I've added, it is not actually C, it is Koplik spot. This is for you to remember, okay? Koplik spots, this finding is pathognomic of measles. What is Koplik spot? This, like the pinhead, that will be the size. Small spots, bluish gray color spots you see on the buccal mucosa opposite your upper molars. First and second upper molars, you see small grayish or grayish white colored spots in the buccal mucosa. This is actually pathognomic of measles, okay? So that can be asked as a question to identify this. What is this, or which is the disease concerned? And what about the rash of measles? You get a maculopapular rash. Where does it start? Usually behind the ear, retroauricular origin, and then it comes down. Okay. And period of infectivity, 4 days before the onset of rash and 4 days after the onset of rash. Measles, we have vaccine. We have MR vaccine, MMR vaccine. In MR, you give measles and rubella. In MMR, you're combining measles, mumps, and rubella. Both are live vaccines. What is this measles vaccination campaign between 9 to 14 years of age for elimination is called what? Keep up, follow up, mop up, catch up. So the answer here is catch up. Okay. So for elimination of measles, our WHO had a campaign called catch up, keep up, and follow up. Okay. What is this mop up? Mop up is coming in your what? Polio. Right, mop up round and all. It is not linked to measles, it's polio. So what is catch up, keep up, follow up? This is catch up is, it is done in countries at a single time. At one period of time, you are giving the one dose of MR vaccines to all children between the age group of 9 months to 14 years at a period of time. That is called the catch up campaign. These are all steps to eliminate measles. So one is catch up. Keep up is, keep up your routine immunization activities. Whatever immunization routinely is happening in the country, keep it up, and make sure that children under the year of 1 are getting vaccinated properly. Follow up is in a country where the catch up campaign has already occurred maybe 3-4 years back. You can do a follow up campaign if there is somebody missed or if some other child, so a new birth cohort has come, to vaccinate them. So catch up, keep up, follow up is related to your measles. Next question. All the following statements are true about congenital rubella syndrome, except option A, it is diagnosed when the infant has IgM antibodies at birth. Option B, it is diagnosed when IgG antibodies persist for more than 6 months. C, most common congenital defects are deafness, cardiac malformation, cataract. D, infection after 16 weeks of gestation results in major congenital defects, which is not true about congenital rubella syndrome. Okay, so rubella, we have what all? We have an acquired rubella and a congenital rubella syndrome or CRS. So if I get rubella, it's an acquired rubella, right? But if I'm pregnant and I get rubella and I pass on this infection to my fetus or the baby and the child is born with congenital rubella, then it becomes a congenital rubella syndrome. Acquired rubella, we are not that much concerned. It's actually a mild fever with a rash, usually less symptomatic than when you compare to measles and all that. Patient can have mild fever, rash, lymphadenopathy can be there. But if acquired rubella is, infecting a pregnant woman, especially who is in the first trimester, she can pass on the infection to the baby, and the baby, it can affect the organogenesis in the baby, and the baby is born with congenital defects. That is your congenital rubella syndrome. Okay, so when is the time for organogenesis? First trimester, right? So maximum damage occurs in the first trimester. Not just the first trimester, rubella is actually notorious. Even up to 20 weeks, it can cause congenital defects. But after that, usually there is no congenital defect in the baby if the mother gets a rubella after maybe 20 weeks of gestation. And what are the triad? The child, there is a classic triad of CRS. You can remember it as CDC, cataract, deafness, and cardiac defect. So cataract, deafness, cardiac defect is the triad. So this option is correct, right? Most common congenital defect are deafness, cardiac manifestation, and cataract. Infection after 16 weeks results in major? No. Infection before 16 weeks results in major issues, not after 16 weeks. Then how do you diagnose? So you have two antibodies here, right? You have an IgM. You have IgM and IgG. See, IgM is a bigger molecule, okay? It is a bigger molecule. It cannot cross the placenta. It cannot be transferred from the mother to the child to the placenta. It's big, M for mega, big. Okay, so if you see an IgM antibody for rubella in the baby, that means the child has got the infection. The IgM that is seen in the blood of the baby is actually produced by the child's body alone. Okay, so that means the child is actually having rubella. So you can diagnose the infant with rubella if IgM antibodies are present at birth, yes. What about IgG? IgG can be transferred. It's a smaller molecule. It can transfer from the mother to the baby through the placenta. So IgG can be from the mother or from the child, right? So if the IgG level persists more than 6 months, then also it is diagnostic of CRS. Fine. We have already told this. The triad is congenital cataract, deafness, and cardiac defect. Among cardiac defect, the most common one is BDA, most common one. And then if I ask you which is the one among these three, among the CDC, which is the most important one, pointing out towards rubella, it's deafness. How do you remember it? Rubella, right? There's a bell. Bell is for hearing, deafness. So the most important one is deafness here. Okay. What are the other symptoms? You can get a blueberry muffin rash, microcephaly, mental retardation, glaucoma, VSD, heart defects, hepatosplenomegaly, radiolucent bone disease, salt and pepper fundus. All these are, findings of a baby with the CRS. 2 food items, blueberry muffin, you have salt and pepper fundus you have, okay? Now, next question. Which of the following is not true about influenza virus? So the options are influenza virus A is subject to frequent antigenic variations. Antigenic drift is a gradual antigenic change over a period of time. Antigenic shift is due to genetic recombination of virus, and major epidemic are due to antigenic drift. You have 4 options. So influenza virus, how do you name influenza virus? You have H and N, right? It can be H1N1, H5N1. All these are examples of influenza viruses. H stands for hemagglutinin, N stands for neuraminidase. I hope you know that. H1N1 is what? Other name is swine flu. H5N1 is your bird or the avian flu. Fine. So, a major question that you should remember about influenza viruses are they are viruses which can rapidly undergo changes. These changes can be either antigenic shift or antigenic drift. We'll see what it is, okay? So antigenic shift and drift is there. Shift is always a major change, okay? Shift. When you say shift, you're shifting a house, you're shifting a locality. So shift is always a big change. So here what happens is you get a new subtype. There are some changes in the genetic recombination and it leads to a new subtype. This is usually a sudden change. It's a shift. It occurs all of a sudden, and the shift is responsible for most of your epidemics and pandemics due to influenza viruses. Whereas drift is a small thing, balloon drifting. Drift is always a small thing. Drift is a point mutation and it is a gradual or insidious onset change, and due to drift you get maybe sporadic cases. So in the options here, influenza virus A is subject to frequent antigenic variations, true. Antigenic drift is a gradual antigenic change. Yes, it is gradual. Shift is due to genetic recombination. Yes. Major epidemic are due to antigenic drift. No. Major epidemic are due to antigenic shift and not drift. Okay. Now we have your bird flu, avian flu, H5N1. What is the reason for H5N1 not becoming a global pandemic? You have swine flu, H1N1 being a global pandemic. We have seen in papers. We have many reported, epidemic pandemics, but H5N1 has not become a global pandemic yet. Why? The reason is man-to-man transmission is rare. That is the answer here. Because when there is man-to-man transmission, then there is a more chance of spread, and then there is a higher risk for the disease to become a pandemic, epidemic, and all that. In H5N1, luckily, we have lesser man-to-man transmission. Usually, the patients who get H1N1, they are persons dealing with, birds. So that is from where that will be the source. So that is the answer is man-to-man transmission is rare, hence it is not becoming a global pandemic. Next, positive Schick test indicates what? Schick test. Don't confuse it with shake test. Schick test is different and shake test is different, okay? What is Schick test? It is for diphtheria. And shake test is for, vaccine. To check the cold sensitive vaccines, whether it has been over frozen and whether you have to discard or not, that is your shake test. Here they are asking you is the Schick test, okay? Schick positive indicates what? It indicates susceptibility to diphtheria, okay? So Schick test is nothing but a, intradermal test. Just like you do your tuberculin test in tuberculosis, you have that PPD thing which you're injecting. Just like that, you have something called a Schick test. Here you see, you're injecting 0.1 ml of diluted diphtheria toxin. You're injecting the toxin, a very small amount of toxin, is injected intradermally in the Schick test, and then you check for the reaction. You check for the in duration, whether it is increasing or decreasing. Whether it is increasing after 2 to 4 days, okay? And how do you read the results? Usually, if you are immune to diphtheria, nothing is going to happen. If you are immune to diphtheria, that is, you're already immunized to diphtheria, you have good titers in you, then there is no reaction, okay? So there is no reaction, it's negative if you are immune to diphtheria. But if you are susceptible to diphtheria, then you have a, you have a positive reaction here. So that is the importance of Schick test. But now you don't do it actually. Now this has been replaced by a better test we have heme agglutination test, okay? So this is serum test. This is what is done now. But questions can come from Schick test also. Okay. What are the other named tests for immunity status? For diphtheria, you have Schick test. TB, we told we have the tubercular or the Monto test. Leprosy, Lepromin test. Kala-Azar, you have the Leishman test or Montenegro test. Okay. These are all the named immunity tests you have. Then what is Shake test? Shake test is, see, you have two vaccines. This is also mainly, most commonly you do it for DPT only. Okay. DPT vaccine, whether you can use it or not. See, here's a vaccine which was never frozen, and here is a vaccine which was frozen. Okay. Now, immediately after shaking, you take 2 bottles. One is your control, one is your vaccine. So you shake it, and immediately after shaking, you see one becomes smooth and cloudy. The other one is not smooth. You can see some granular particles here. And after 30 minutes of shaking, you just, you shake, after 30 minutes, after shaking, you keep these bottles both for 30 minutes and then you observe. So after 30 minutes, if you see there is no sediment, it's starting to clear, that means this vaccine is not destroyed. This is actually good. You can use it. But if you see like this, that is, you see a sediment here, then some clear area, a sediment area, this means this vaccine is not good. So you should not use it, or you should discard this vaccine. This is what Shake test tells you. Okay. What is this clinical picture? Yes, this is a patient with diphtheria. This is your, the edema here. It is called bull neck deformity. And characteristic finding, you get what? Pseudomembrane in the oral cavity in a diphtheria patient. Okay, now about the treatment. I've written about the context. I'm just asking you how do you treat a case of diphtheria? What cases the treatment is, you give antitoxin, diphtheria antitoxin plus antibiotic. Which one? Erythromycin. You can give penicillin also. It's either erythromycin is better, okay? Drug of choice is actually erythromycin or penicillin plus antitoxin. This is for cases. Now, for the contacts, what do you do? Contacts, what you have to do is, if you can have 3 scenarios, okay? If the primary immunization or booster was received in previous 2 years, then you don't have to do anything. Within the last 2 years, the patient had got the full booster dose, so the immunization is complete. No need to do anything. He won't develop the disease, okay? But if the primary immunization or booster was received before 2 years, more than 2 years ago it was received, then now you have to give a booster dose. So up to 2 years, no worry. But after 2 years, now it's time for you to give a booster dose. If your contact is unimmune, the patient has not received any vaccine or DPT vaccine, nothing has been taken, you're getting an unimmune contact, then what you have to do? You have to give active immunization plus, active immunization plus you have to give antitoxin and you have to give prophylactic penicillin or erythromycin. Fine. Okay. And how long should you isolate a diphtheria patient? It is not same as the period of communicability. Why? Because in diphtheria, you're giving an antibiotic, right? So once you start the proper antibiotic, you're giving erythromycin and all that. And once you get, after 24 hours, once you get culture, you take throat cultures and check for them. If you get 2 negative throat cultures, both taken 24 hours apart, in that case, you can stop the isolation. So isolation can be stopped. When? When can you stop this isolation? You should get at least 2 negative throat cultures. And these cultures should be taken 1 day, 24 hour apart. If we get this, then okay, you can stop the isolation of this patient. Okay. Now, next question is about meningitis, meningococcal meningitis. Causative agent is gram-negative diplococci. Cases are the most important source of infection. Treatment with penicillin eradicates carrier state, and vaccine can be given in pregnancy, which is true. Causative agent is gram-negative diplococci is the correct answer. Cases are not the most important sources of infection. It is the carriers. Okay. Treatment with penicillin is for the treatment only. It cannot eradicate the carrier state. To eradicate the carrier state, you need something strong. Usually you give rifampicin, okay? Rifampicin can eradicate the carrier state, but not penicillin. Vaccine can be given. No, it cannot be. This is a meningitis vaccine is a live vaccine. You cannot give it in pregnancy. So the correct answer is, it is caused by gram-negative diplococci. And one more thing, what is this? This is your African meningitis belt, okay? See, in this area, in these African countries where you call African meningitis belt, the diphtheria is now very prevalent, okay? And for them, you have different criteria. You have a WHO certain cutoffs which define when you call it as low endemicity, moderate endemicity, high endemicity, and epidemic. Epidemic is when there are more than 100 cases per 1 lakh population per year. This is point 1. If it's more than that, it is epidemic. If it is 0.01, it is high endemicity, okay? Okay. Now, next question is pneumonia. Okay, you have a child. This is also a commonly asked question because it's a clinical question. It's based on your IMNCI guidelines. How do you manage a child with pneumonia? Okay, a child aged 24 months was brought to PHC with complaints of cough and fever for past 2 days. On examination, the child weighed how much? 11 kg. And the respiratory rate was 38. Chest indrawing was present. Most appropriate line of management for this patient is age is 24 months. So now you have to know how to classify pneumonia as a child with symptoms suggestive of pneumonia. It can be either no pneumonia, pneumonia, or severe pneumonia. You just have 3 classifications, okay? Child ages 2 to 59 months brought to you with cough, difficulty breathing. You have no pneumonia, pneumonia, and very severe disease or severe pneumonia. Only 3 classifications are there at present. This is actually the revised classification. The older books, if you see the 26th or 25th edition of PARC, they have given 4 classifications. Pneumonia, severe pneumonia, very severe pneumonia, and no pneumonia. Don't confuse it with this. Forget that. At present, this is the latest classification. 3 groups: no pneumonia, pneumonia, and severe pneumonia, okay? When you say the child is having no pneumonia, that is just cough and cold. There is no fast breathing, chest indrawing. The most, the things you check for are fast breathing, chest indrawing, and danger signs. Especially what? Stridor in a calm child. And there are others also, okay? These are clinically, when a child is brought to you, you are supposed to check for fast breathing, chest indrawing, and presence of any danger signs. So when there is nothing, there is no fast breathing, no chest indrawing, no danger signs, that means the child is having no pneumonia, cough and cold. Just home care advice is enough. You don't even have to give antibiotics also, okay? But if the child is having fast breathing or chest indrawing, even if one is present, then also it is pneumonia. This fast breathing and or chest indrawing, patient is having pneumonia, classify as having pneumonia, and here you give what? Oral amoxicillin. Mox is the treatment of choice, okay? You give oral mox and you send the patient home with home care advice. It is OPD based management with amoxicillin. Now, when there are general danger signs of pneumonia, then you can't do OP based management. You have to admit the patient, okay? What at a peripheral level center, what can you do? Give the first dose of antibiotic, then refer the patient to a facility where he can be given injectable antibiotics. In case of a severe pneumonia, your oral tablet is not going to work. You'll have to give injections. So you'll have to refer the child to a higher facility. Right. So what is this fast breathing? What is the cutoff? You see the respiratory rate of the child for 1 minute, okay? If the child is, less than 2 months of age, breathing more than 60 is called fast breathing, 60 per minute. For 2 months to 12 months, more than 50 is fast breathing. Okay, 50 or more, 60 or more. And other than that, 12 months to 5 years, more than 40 or more per minute is fast breathing. So you see for the fast breathing, and you check for chest indrawing. You know, the chest wall is indrawn. That is what you see in this diagram. This is chest indrawing. So if any one of this is present, it is a case of pneumonia which have to be managed with amoxicillin. Now, what are the general danger signs? If there are danger signs, then it is a severe pneumonia. You cannot do OPD-based management. You have to refer the child for IV antibiotics, right? So what are the general danger signs? It's actually very simple. You think about a pediatric casualty. Which all are the emergencies that you see there? The child is brought with either of these things, right? Any one of these things most commonly. One is not able to drink. Second one is vomiting. Whatever you give, the child is vomiting. Third one is seizures, convulsions. Fourth one is very lethargic, tired child. Fifth is stridor in a calm child. Sixth is severe malnutrition. This one is the one you miss, okay? Severe malnutrition is also pointing towards a general danger sign, okay? So now, in our question, you see, here in this child, it's a 2-year-old child with breathing is normal, right? This is not fast breathing, but chest indrawing is present. That means it is pneumonia. So in case of pneumonia, what you should do? Classify as pneumonia, start antibiotics and give home care advice. And here, one thing you should notice is, see, they've given the weight of the child, okay? 11 kg is given. In this case, it's okay because 2-year-old child, 11 kg weight is okay. Suppose if the weight given was 5 kg or a very less weight, then this child would have become classified as malnourished, right? Malnourished. Then in that case, your this thing changed. Severe malnutrition means your classification becomes severe pneumonia. Okay. So then you'll have to do classify as severe pneumonia and refer urgently. So always in this question, in such a question, always check for the weight. See whether the weight is appropriate or if the weight is showing severe malnutrition. In that case, that it can actually change. It can change from pneumonia to severe pneumonia just because of that malnutrition part. Okay. And what is the guideline? We just told what we just discussed. This is the INCI guideline. INCI have guidelines not just for pneumonia, it has guidelines for different diseases like diarrhea, and almost all the common, otitis media, everything is there. And you have heard of something called IMCI. See, IMNCI and IMCI are not the same. These are different. This is the WHO one. Okay, this is the Indian version. So WHO created IMCI guidelines for all the countries and asked the countries, okay, you can tailor it according to your country's need. Now, what did India do? We made IMCI into IMNCI. We added the N component also. That is N component mainly the first 7 days, early neonate or the child of age 0 to 7 days. The 0 to 7 day age old child was not included or neonate was not included in the IMCI. But in India, in our management, we incorporated that age group also, such a small baby also, and it became IMNCI. So IMNCI is the Indian version and IMCI is the WHO version. Okay. This we have already discussed. Now, what is SANS? This is actually a new one. That's why I've added it here. SANS is actually an awareness program for pneumonia. SANS was launched in 2019, November 2019, actually to build awareness, and it's an action plan, or the full form is, it is to accelerate action to reduce deaths due to childhood pneumonia. Full form is what? Social Awareness and Action Plan to Neutralize Pneumonia Successfully. That is what is SANS. So this is related to pneumonia. That much you should know. Okay. Next is a question from TB, tubercle bacilli. Number of positive for tubercle bacilli if count in AFP sample is more than 10 per oil immersion field. That is whether it is, you have more than 10 per oil immersion field of AFP in your sample, whether it is 1 plus, 2 plus, 3 plus or scanty. The answer here is actually 3 plus. So I'm not describing this. You have to study this, okay? This question, it's a overlap. It can be asked in microbiology also. But you should know how much is the, based on the slide, you stain it with the AFP stain and then you see. This is how it looks like, okay? You stain it and then you see, you count for the number of bacilli. Based on that, you say whether the patient is having, sputum positive. whether it is candy. You see the reports like that, 1 plus, 2 plus, 3 plus sputum, whether the result is negative, positive and all that. So see, even if there is scanty AFP, that is only 1 to 9 AFP per 100 oil immersion field, that you're seeing 100 immersion fields, still you get only less than 9 AFP, then also, then you call it scanty, even then it is positive. Even if you see 1 AFP, no, it is a positive case of TB. Okay. Now, what are the current prevalence? What is the present prevalence of TB in India, incidence of TB in India? You can be asked such questions. This is based on the value I've given here. These are from the latest global TB report. The prevalence is from a national-wide TB prevalence survey, which happened in 2019-21, which was recently published. So these values you should know, okay? The total TB incidence is 199 per 1 lakh population. And the point prevalence of microbiologically confirmed TB is 316. That is the prevalence of TB. 316 per 1 lakh population. That is for aged more than 15 years. All forms of TB, that is not just pulmonary, every TB, the prevalence is 312. So 199, 316 and 312. Fine. So I think now we'll take a short break. So coming to the next question. A lactating woman has sputum positive TB and her neonate child is 3 months old. What is the recommended chemoprophylaxis? So, chemoprophylaxis for TB, or they are asking mainly the TPT, tubercular preventive therapy. The drug of choice is always INH, okay? Isoniazid, and the dose is 5 mg per kg for 6 months. This is the option D. INH 5 mg per kg for 6 months is the answer for this question. And you have particular guidelines for chemoprophylaxis in children less than 6 years of age who are in contact of a sputum positive TB case. So you have to go through this, and it is basically based on the clinical decision as well as the tuberculin skin test in children. Okay, then what are the other groups who are given TPT? Whom do you give this TPT? Other groups are, one we have already told, right? Children less than 6 years. Then HIV positive children, all regardless of the age, okay, who are exposed, or either they are exposed, or if they are not exposed but they show a positive tuberculin test, then also you give it. Then all tuberculin skin test positive children who are immunosuppressed, you have to give preventive therapy. And also to the child born to mother while she was having TB during her pregnancy. All these cases you have to give INS prophylaxis, okay? Now, WHO defines multi-drug resistance strain as one that is what? At least resistant to INH, resistant to rifampicin, INH rifampicin, without resistance to other anti-TB drugs, resistant to streptomycin. C. Easy questions. MDR-TB is when the patient is resistant to both H and R, that is rifampicin as well as INH. If the patient is resistant to both, it is MDR. Okay. What is your XTR? So resistance, based on resistance, you can classify the patients as monodrug resistant. Then you have MDR, that's multi-drug. Then you have XTR, you have pre-XTR. So you should know what each one means, okay? You have to revise this. So MDR, I told you, H plus R resistance, right? XTR, the patient is resistant to H plus R, that is isoniazid rifampicin plus one of the what? Fluoroquinones plus at least one of your second line injectables. In this case, you have XTR. Now, what is the and also you should know the treatment, okay? In drug sensitive TB, you have continuous phase and intensive phase and continuous phase, 2 HRZD and 4 HRE. In MDR and XTR, you have different regimens. You should know the regimens. And this is the diagnostic algorithm of TB. You know, any patient you coming with the TB, you have to go for smear examination and chest X-ray. If even one sputum smear is positive, you're taking 2 samples, right? When do you take 2 samples? First sample on the time when the patient comes, and the second sample will be the early morning sample. The next day, he has to take the sample. Even if the one sample is positive, patient is positive for TB, okay? Microbiologically confirmed TB. Then you have CBNAT. CBNAT is the test with this having the highest sensitivity and specificity. For patient is a HIV patient, you directly go for the CBNAT test. That is always better. And what is the advantage of CBNAT over your sputum? CBNAT not only detects the TB, but also it can detect the rifampicin resistance to TB. That is an added advantage. And now the criteria is universal screening. Drug sensitivity. Universal sensitivity screening is advised. That is, every patient has to get a CBNAT also done, so that you can identify if there is any resistance, you can identify those cases early. Fine. Now we have different definitions for TB based on the history of previous TB treatment and based on their treatment outcomes. You have a new case when the patient is new, not having TB at all, or if he had taken anti-TB drugs for less than 1 month, that's also a new case. Otherwise, more than 1 month, he has already taken TB treatment, then it's a previously treated patient. Then based on the treatment outcomes, you have cure, treatment completed, failure, loss of follow-up, died, not evaluated, treatment regimen changed. You should know what each one of these means, okay? For example, you say somebody's cured. This patient is, the outcome is cured. That means the microbiologically confirmed TB who was smear or culture negative at the end of the treatment. That is completed 6 months of treatment, and at the end of the treatment, you took a sputum AFP which was negative. Those patients are called treatment cured. But somebody, suppose the patient completed treatment, okay, but forgot to take that sputum AFP at the end or did not take the AFP in the end. That case is not cured because we don't know whether the patient has become negative or not. But you can say it's a treatment completed case. Okay. Now, pertussis. What is true about pertussis? Most of the infection are subclinical. Most infective stage is paroxysmal stage. Drug of choice is erythromycin. Cerebellar ataxia may be a chronic common complication. So the answer here is drug of choice is erythromycin. For pertussis, most of the infections are cases. You don't have subclinical or carrier stage in pertussis. Most of the infections, it's always cases, okay? And most infectious stage is not the paroxysmal stage. There is something called a catarrhal stage, which comes before the paroxysmal stage. That is the most infectious one. Drug of choice is erythromycin. That is correct. And the common complications are B's, bronchitis, bronchiectasis. Those things are the complications. It's not the ataxia. So pertussis, source of infections, cases, subclinical case do not exist. Infective period, catarrhal stage. Drug of choice is erythromycin. Complications, bronchitis, bronchopneumonia, bronchiectasis. Convulsions common is there, but ataxia is not there, okay? Next question is polio. Again, polio, you can get questions from polio, then your AFP, surveillance, then the vaccine, and the vaccine associated paralytic polio. All these are, question areas. So you should be thorough with polio, okay? So regarding poliovirus, responsible for poliomyelitis are all true except type 3 is most common, type 1 is most common, type 1 is responsible for the epidemics, and type 2 is eradicated worldwide. The answer is type 3 is more common in India is wrong. It is type 1, okay? This is correct, okay? So few words, WP, wild poliovirus, you have type 1, type 2, type 3. Type 2 has been eradicated, okay? So, which all are the diseases that are eradicated? We have smallpox that has been eradicated. In polio, only the wild poliovirus type 2. This has been eradicated in the world in September 2015. Okay. And we have 1 and 3. But type 1, type 3 also after November 2012, we did not get any case of type 3. But we have not declared eradicated. As of now, the sole remaining, one that is circulating is the wild poliovirus 1. So that is the most common type. And what about vaccine-derived poliovirus? So vaccine-derived poliovirus is due to what? Due to your Sabin or OPV. It is the cause for vaccine-derived poliovirus, right? VDPV. And here you have most common, you have three types actually. You have CVDPV, you have IVDPV, and AVDPV, okay? This is the communicable one. This is the isolate and this is the ambiguous one, okay? Out of this one is more important. CDPV, it's like it almost is similar to the wild type, okay? The answer here is, which is not a type of vaccine-derived paralytic polio, M. There is nothing called MVDPV. You have C, A, and I. There is no M, okay? And now coming to the stool examination. So, how do you dictate, how do you, take this virus? How do you identify it? Is from the stool examination, right? So, isolation of white poliovirus from stool is the recommended method of laboratory confirmation of paralytic polio. Question. What is the recommended method of laboratory confirmation of paralytic polio? Isolation of the wild poliovirus. That is to be done in every case of acute flaccid paralysis. Whether it's polio or not, you'll get to know only after you test, right? So you have to take this stool sample in every case of AFP. And what is this? When can the virus be found? It can be found from onset for up to 8 weeks after paralysis. This is the time then you can get the virus in this stool sample. And the highest probability is during the first 2 weeks. That is the time when that's a higher chance of getting a positive stool test. Okay. Now you should know what is this switch. Okay, switch is, see, I told you we have eradicated wild polio type 2, right? Now we have only 1 and 3. So initially we had a trivalent OPV. Okay, that is, it was protective against 1, 2, and 3. Then after this 2015, we have shifted it to what? Bivalent OPV. Because we don't need this protection against 2 anymore. We have eradicated 2, right? So this change, this is called the switch. That is between April 17 and May 1, 2016. Many countries now switched from trivalent to bivalent OPV. This is one of the largest vaccine rollout in the history of the world. So the switch is related to your trivalent OPV converted to bivalent OPV. Now, next question is on your hepatitis viruses. Which of the following is not transmitted through sexual route? Hepatitis A, E, both A and E, D. So you have different hepatitis viruses. A is there, B is there, C, D, E. Out of this, the only DNA virus is which one? Hepatitis B. And here, the answer to this question, which is not transmitted through sexual route, is hepatitis E. E cannot be transmitted to sexual route. It can be transmitted only through fecal-oral route. The area where you go wrong is most of you have a tendency to give the answer as C, both hepatitis E and E. No. Even though hepatitis A is also a majority is through fecal-oral route, but it has a chance for sexual transmission also. So the sole answer here is your hepatitis E. This is a box on hepatitis, types of viruses, A, B, C, D, E you have. You have the incubation period and route of transmission. Hepatitis B is the only one which is a DNA virus. All others are RNA. So mainly through sexual, perinatal, percutaneous transmission. Okay. Now these are some of the most commons in hepatitis. Most common fulminancy seen in hepatitis T. Chronicity, C, C for C. Carriers, B. Cancers, most common. B and C can cause cancer, okay? Hepatitis C is the most common one. And DNA viruses for hepatitis B. Fine? Now, markers for hepatitis B. What is the marker for infectivity of serum in hepatitis B? It is your HBeAg. This is the one which shows infectivity in hepatitis B, okay? So this is the interpretation of serum markers. You have HBsAg, anti-HBc, IgM anti-HBc, anti-HBsAg. This is the interpretation. So when both HBsAg and anti-HBc is negative, that means there is no hepatitis B infection, right? When the person is having infection, this will be positive. Both will be positive. If it's a chronic infection, then also both of this will be positive. Okay. What about somebody who's immune? Due to vaccination, you get HBsAg will be negative, but you the anti-HBs, this is a titer, protective titer more than 10. This, if anti-HBs is positive and your HBsAg is negative, that means this is person has taken the vaccine. Okay. Next question, that is regarding the mother to child transmission of hepatitis B. So mother is HBsAg positive, so she's a hepatitis B patient, right? At 32 weeks of pregnancy. What should be given to the newborn to prevent neonatal infection? So what will you give? Is it the immunoglobulin alone, or should you give the vaccine, or nothing? So the answer is both. Okay, hepatitis B vaccine plus immunoglobulin has to be given to this child to prevent the mother to child transmission. So hepatitis B vaccine, it's universal. To prevent the mother to child transmission, hepatitis B vaccine is given, it is included under the program, and universally you are giving it to all the kids. But immunoglobulin, you give it only to the child with a mother who's positive to HBsAg, okay? Otherwise, hepatitis B is given to all kids. So next is ORS. The freshly prepared ORS should not be used after 24 hours. Yeah, you have to use, making the ORS, it has to be completed within 24 hours. After 24 hours, discard it, okay? So then there is something called a reduced osmolarity oral rehydration solution, or the ORS. That is a WHO new ORS. It actually has a lesser sodium content in it. So you should know the concentrations of that also. And again, another question, potential question from diarrhea ORS is, they can ask you how do you manage a patient? How do you classify the patient based on the dehydration, whether it is some dehydration, severe dehydration, no high dehydration, what is the management? So they'll give you a clinical scenario, just like in the case of pneumonia you were given, right? Was child was brought to you. Just like that, diarrhea also they can show you, they can give you a scenario where the child was having diarrhea, loose stools and all this, sunken eyes or not able to feed. And then you have to classify it and you have to treat according to the classification. And which is the IV fluid of choice, you give ringer lactate, okay? Ringer lactate, it is not NS, you give ringer lactate. If at all you have to give IV for fluid correction in diarrhea kits. What else? Now the next question is, what is the drug of choice for chemoprophylaxis of cholera? Chemoprophylaxis of cholera, drug of choice is tetracycline. Remember, antibiotic of choice is tetracycline for chemoprophylaxis. But for the treatment, you have doxy. So in cholera cases, you give doxycycline. But for prophylaxis, that is for contacts, you give what? Tetra. Fine. Okay. So the antibiotic of choice is doxycycline for adults, but you can't give doxy in pregnancy. You have to give azithromycin. Okay. And for chemoprophylaxis, you give tetracycline. Now, regarding typhoid, here's your next question. Which one of the following gives strong evidence of typhoid fever carrier status? The answer is isolation of VI antigen. This is the one which gives the strongest evidence for a carrier being a typhoid fever carrier status. Okay. Now, when do you do for the time for diagnosis? What is the test? Whether you have to do blood test, whether you have to do antibody, that is a Vidal test, stool culture, urine test, which is a test that has to be done to diagnose typhoid. So the code is BASU, EASU. So in the first week, A, second week, third week, and fourth week. This is a mnemonic, okay? Remember BASU here. So in the first week, ideal thing is to do a blood culture. Second week's antibodies, A, that's a Vidal test. Third week is stool culture, and fourth week you for a urine test, okay? Next question, Chandler's index. First question, it's already here. It's given Chandler's index is for hookworm. What is the health problem? They've given the name of the disease and then they've asked you to classify when it is a health problem. What is the range they are asking? Sometimes you can ask, which worm infestation. Where do you do this Chandler's index? It is for hookworm. Remember the Chandler from Friends, okay? Chandler is scared of hookworms. So Chandler's index is for hookworm. Don't forget this. And the above 300, that is when you say it is a public health problem. So what is Chandler's index? It is the average number of hookworm eggs per gram of feces for the entire community. That is number of hookworm eggs per gram of feces for the entire community. This is the Chandler's index. How do you interpret it? If it is more than 300, it is an important public health problem. This was your question. 250 to 300 days, it's a minor public health problem, but more than 300, it is a important public health problem. Okay. Next is dengue, which is not true of dengue fever. Options are Aedes aegypti is a primary vector, correct. Breakbone fever is characteristic. Yes, it's another name for dengue. You say it is a breakbone fever, right? Because of the symptoms. Serotype 4 is more dangerous than other serotypes. Tourniquet test is positive. Tourniquet test is positive, but serotype 4 is not more dangerous than the other serotypes. The most dangerous one is serotype 2. 2 is the most dangerous one. It is not 4. There are 4 serotypes, right? 1, 2, 3, 4. Out of this, 2 is the most dangerous. And how does a dengue patient manifest? It can be classical dengue. It can be dengue hemorrhagic fever. It can be dengue shock syndrome. So, okay, next question is on dengue shock syndrome. It is characterized by the following ENII-CET: hepatomegaly, pleural effusion, thrombocytopenia, decreased hemoglobin. Yes, the answer is decreased hemoglobin. No, you don't get decreased hemoglobin in shock syndrome. You get all the other things in shock syndrome. Okay. Now, what are the dengue vaccines? See, this is something new. You have 2 vaccines. One is the one which has been approved as Dengvaxia, or also known as CYD TDV. Now you have something called TD003. This is a newer vaccine. This is actually under trial only, phase 3 trial. Dengvaxia. What is important is In case of dengue vaccine, there are some issues in giving it to already, seropositive people. So before giving dengue vaccine, you have to check for the seroprevalence or whether it is seropositive, whether seronegative. Then only you can give a dengue vaccine. But in this newer vaccine, you don't have to go for the seroprevalence. That is the advantage of this newer one over your older dengue vaccine. And what is the vaccine for malaria? You have Mosquirix, right? This is the approved vaccine for malaria. So among the vaccine vector-borne diseases, you have vaccine for JE. Yeah, you already have. It's already there in the program. Now you have vaccine for malaria as well as for dengue also. Okay. Now, what is API? Where have you heard this API? API is related to which one? Which program? Which disease? It is your National Vector-Borne Disease Control Program and malaria. API is nothing but the annual parasitic incidence. What is API? So it is the confirmed cases during 1 year divided by the population under surveillance into 1,000. It's actually a measure. It's an impact indicator. Okay. You have a program going on. You have a National Vector-Borne Disease Control Program, which is aimed at controlling 6 major vector-borne diseases, and the major one is malaria. And to see whether your this is actually working or not, you have to have some indicator, right? For that, the indicator is API or annual parasitic incidence. It is the total number of confirmed cases during a year divided by the population under surveillance into 1,000. So what are we aiming at? We are aiming to bring down this API to less than 1 per 1,000. This is our target. Okay. Based on the API, actually, we divide the states into, elimination phase, pre-elimination, control, and all those things. So API has different uses here. Now there are some other indexes. That is the ABR. This is the annual blood examination rate. Then you have a slight positivity rate also. ABR is actually a operational indicator. That is the total number of slides examined in a year divided by the total population. That is your annual blood examination rate. Basically, it's an operational indicator just to see whether whatever is there in the program is actually happening in field or not. That is your ABR. And SPR is a slight positivity rate. That is out of the slides checked, how many are positive. SPR is useful in warning about impending outbreaks. See, if there is a higher SPR, then you should be careful. Okay, SPR is high. That is the positivity rate is more. There's a chance of an outbreak happening there. Okay, so these are the other indexes. Then you have certain mosquito indexes. The most important one be the Brutto index. This is specific for your Aedes aegypti, the one causing the dengue fever. Okay, the aim is you have to bring it less than 1. What is this Brutto index? It is the number of containers showing breeding of Aedes larvae divided by total number of houses surveyed. You go and survey many houses, and where do you find this Aedes aegypti? In containers, right? In artificial containers you get, maybe coconut shells or your flower pots and all that. So you go and survey for all those things, and it is the total number of containers that show this Aedes larvae divided by total number of houses that you have surveyed into 100. That is your Brutto index specific for Aedes aegypti. And it should be less than 1% in towns and seaports in endemic areas to ensure that you are safe from yellow fever. Okay. Just like dengue, yellow fever is caused by Aedes aegypti. At present, India, we don't have yellow fever, but we have very strict restrictions in all the airports and all the seaports to prevent yellow fever from coming from outside, and also to keep our country, yellow fever free. We have to have this Brutto index less than 1%, because there's high chance of, just like dengue, yellow fever can also be a threat to our country because the Aedes aegypti, it is there. So Brutto index should be kept less than 1 to protect from yellow fever, and vaccination, of course. So next question is, in a chloroquine resistant zone, the presumptive treatment of malaria is given as what? So the treatment of malaria again is an important topic. Okay, treatment of malaria depends on whether you have your Plasmodium vivax, Plasmodium falciparum, or sometimes you get mixed infection. So the treatment of choice differs. This is for the cases, the malaria cases. For Vivax, what you give? What's the drug of choice is Vivax? You give chloroquine for 3 days, plus you give primaquine for 14 days. This is for Vivax. For falciparum, you see falciparum, stronger one. Your chloroquine is not going to act on falciparum. So you have to give ACT for 3 days. Okay. ACT is what? RT is artesunate. Artemether combination therapy is ACT for 3 days. Plus you give primaquine single dose. Okay. Not the 14 days thing. Single dose on day 2. Okay, and if it's a mixed infection, that is you have Vivax and falciparum, you give what? ACT again for 3 days plus primaquine for 14 days. This is your treatment of malaria. Okay, for Vivax, chloroquine 3 days plus primaquine 14 days, falciparum, ACT 3 days plus your primaquine only on the second day. Mixed infection, you give ACT and primaquine. ACT 3 days and primaquine for 14 days. You're mixing both the options. And the question here is chloroquine resistance shown. The presumptive treatment of malaria could be, what should you give? It is ACT, right? And ACT you have sulfadoxine and pyrimethamine. So this ACT, you can be either ACT AL or ACT SP. SP is sulfadoxine and pyrimethamine with artesunate, and ACT AL is lumefantrine, artemether with lumefantrine. So where do you give ACT AL? Where do you give ASP? AL is given in northeast states because they have again SP also it is resistant. So you give AL in northeastern state, and all other states you give ACT SP. So that is the treatment. And what about the chemoprophylaxis? If somebody is going for a travel for less than 6 months, you give mefloquine. If it is, more than 6 months, mefloquine. Less than 6 months, you give doxycycline. Okay, that is the prophylaxis. Now next is filariasis, DEC. DEC is extensively used as a chemotherapy for filariasis, right? It is effective against what? Microfilaria, adult form, infective stage larvae, all of the above. DEC is given to tackle your microfilaria. It is not effective against your adult form, okay? So chemotherapy of filariasis is again DEC, and it is effective in killing microfilaria only, not effective on your stage or the larva stage. And what is this? So chemotherapy is something called triple drug therapy. Now you give, it's not just DEC for chemoprophylaxis. You give triple drug therapy, that is IDA. I is for ivermectin, DEC, and A is for albendazole. All three are given now as chemoprophylaxis. Fine. Diagnosis of filariasis is confirmed most commonly by which one? Detection of microfilariae. Now we are coming to rabies. Which of the following statements about rabies is false? Convulsions are generally not seen in patients with rabies. True. You don't see convulsions much. Presence of meningitis suggests against the diagnosis of rabies. Yes, if it is a case of meningitis, then it is against the diagnosis of rabies. Then you have incubation period 20 to 80 days, correct. Intracytoplasmic basophilic inclusion bodies are seen in the brain. What are they talking about? Intracytoplasmic inclusion bodies. They are talking about something called your Negri bodies, which are pathognomic or which is characteristic of this rabies infection. You get it after, from the brain cells only you get this. But it is not basophilic. It is eosinophilic inclusion bodies. That is wrong here. So this is wrong. Okay. So this is your Negri body. It is not basophilic. It is eosinophilic inclusion body. And this is pathognomic of rabies. Okay. It is seen in the neuron. Now, what is the pre-exposure prophylaxis of rabies? It is given on pre-exposure. That is before you get a bite. You give it to persons dealing with occupational risk and those who have this risk. You give pre-exposure prophylaxis is given on day 0, 7 and 28. That is the option C is the answer. Okay, here you need to learn some things. So regarding the vaccination, you have post-exposure prophylaxis. Yes, you have pre-exposure prophylaxis. Then you have your re-exposure prophylaxis. True. Again, under post-exposure, you have SN regimen and your Thai Red Cross regimen. Okay. Now I'll tell you the days when all the patient should get the shot taken, the vaccine taken. Under SN, you give IM. You give the rabies vaccine, anti-rabies vaccine IM on 0, 3, 7, 40, 28. On 5 days you give, okay? But that according to the modified Thai Red Cross regimen, you give it ID intradermal on 0, 3, 7, 28 only. Now for pre-exposure prophylaxis, you have for days 0, 7, it's either 28 or 21. Both are fine. For re-exposure, you have for 0, 3. What is re-exposure? Somebody has already taken this 0, 3, 7, 28, the whole post-exposure prophylaxis before. Now he got a dog bite. Now you have to take it again. Re-exposure, that is, you are taking the vaccine after already completing the course before. So these are the days. So for post-exposure, you have either SN or Thai regimen. For pre-exposure, 0, 7, 28. For re-exposure, 0, 3. How do you remember this? See, post-exposure, you have SN. SN has 5 letters, right? So you have 5 days, 0, 3, 7, 14, 28. Thai has how many letters? 4 letters. So you have 4 days, 0, 3, 7, 28. Pre-exposure has 3 letters. So you have only 3 days. Similarly, your re-exposure has 2 letters only. So you have only 2 days. Fine? I hope this is there in your mind. Now one more question that can be asked is re-exposure after how many times? After how many days? So up to 3 months. See, if I have completed my all the 4 doses as per the post-exposure prophylaxis, and within 3 months, if I got another dog bite, I don't have to take the vaccine. I have my protection. Since 3 months, I've just taken, so it's okay. But if I get a dog bite after 3 months, you have to take a re-exposure prophylaxis, that is 2 days. You have to take injections on 2 days, that is on day 0 and day 3. So don't forget this 3 months period. Okay, next one is again a question from rabies only. For the treatment of case 3 dog bite, all of the following given are correct except options given: give immunoglobulins for passive immunity, give ARV, immediately stitch wound under antibiotic coverage, immediately wash wound with soap and water. Yes, this is wrong. You never do suturing. Don't do suturing, okay? In a case of rabies wound, you have to, if at all, if it's such a big wound. So here they have given category 3. Category 3, we are assuming there has been using of blood. So it's usually, obviously, can be a big wound. Even in that case, you take packing the wound or something. Do not do suturing. If at all you have to give suturing, first give the immunoglobulin vaccine, everything, and then just put very loose sutures. So immediately suturing is very wrong. So this is just a category. You should know the category of dog bite and what treatment. Category 1, category 2, category 3. Category 1, it is just touching or feeding animals. Animal sits on intact skin. You don't have to do any PEP. What you have to do is wash. Washing only is and reassurance. Category 2, no bleeding, but minor abrasions, wound washing and vaccination. In category 3, when there is bleeding coming, you have to do washing, vaccination plus immunoglobulin. These are the management guidelines for rabies. Okay. Now yellow fever. So which is not true about yellow fever? Exotic, incubation period 2 to 6 days, validity of vaccine 6 years, live attenuated 17 days stay. This is wrong. See, initially we thought it was decided that the validity of vaccine was for 10 years. So after 10 years you had to take another vaccine. Now it has been changed. Yellow fever vaccination validity is for lifelong. It is not 6 years. Okay. So once you take in, that means you're protected for lifelong. Now, yellow fever is one of the diseases coming under your international health regulations. Okay, there are 7 diseases which are covered under the IHR. That is, how do you remember these 7 diseases? Remember this girl. Okay, this is our Sarah. She's a 7-year-old girl. She's a cute girl with yellow hair, right? So my mnemonic is cute Sarah paints her small hair white yellow. So you have 1, 2, 3, 4, 5, 6, 7. So cute for cholera. Okay, Sara, there is no code, okay? This is just a name. Cute, Sara, pains, plague, yellow, smallpox, wild polio, human influenza, and SARS. You get all the diseases here. Next question is on JE. JE virus life cycle in nature runs between pig mosquito, cattle bird, pig human, human pigs. The answer is pig mosquito, okay? JE, virus, this is the transmission cycle. That is the JE virus can transmit between pig, mosquito, it goes. And what about man? Man is an accidental host and a dead end host, okay? Dead end host. Once the infection reaches man, then there is no more transmission. That cycle is stopping there. So here it is pig mosquito. Okay, and also remember, just go through all the transmission cycles of all the communicable diseases at once, because they can give you images like this and ask you to identify. Last NEET, Nipah was asked, Nipah transmission cycle was shown, and the question was to identify which is the disease or which is the virus. Okay. Next one, KFD, Cassandra forest disease, is transmitted by housefly, mosquito, rat flea, heart tick. The answer is heart tick. Okay, these are tick-borne diseases. So you have two types of tick: hard tick, soft tick. Right? Soft tick, you have Q fever, relapsing fever, and KFD outside India. Okay, so mainly Q fever and relapsing fever by soft tick. All the others, this is KFD in India, tularemia, tick paralysis, viral encephalitis, tick hemorrhagic fevers, everything is caused by your hard tick. It is not the soft tick. This is your hard tick, this is the soft tick. Well, now, maximum explosiveness of plague is determined by which of the indexes? All these indexes are specific to plague, and the explosiveness is determined by the Cheopsis index. What is this index? See, it is the average number of fleas of each species found per rodent. This is the Cheopsis index. It's also known as specific flea index. If this index is more than 1, then it is an indicative of an outbreak, explosiveness, or there's a chance of an outbreak occurring. Next question, you have a clinical scenario and the vector here. A man presents with fever and chills 2 weeks after a louse bite. This is the catchword here, the louse bite, okay? Then you get maculopapular rash on the trunk which spreads peripherally, the cause of infection. What is the cause of infection in this? So the clue here is a louse bite, more than the symptoms, okay? What is it? It is epidemic typhus. You have two options confusing, endemic and epidemic. So how do you study this? Again, we have a mnemonic here. The rickettsial disease vectors, you study it like this: let, fen, try, PSM. This is your mnemonic, okay? What is L? Let is for louse. Louse can cause ET, epidemic typhus. That is for let. Fen is the name of a boy. Fen, F is for flea, and E is for what? N, endemic. Endemic what? Endemic typhus. So fen ho gaya. Then you have try. T is for tick. R is for what? Your Rocky Mountain fever. So tick is for Rocky Mountain fever, and PSM. PSM is here the your vector is coming behind. Okay, M is for mite. P is for pox. What pox? The rickettsial pox. And S is for scrub. Scrub typhus. So remember, let, fen, try, PSM. With that, you will be knowing all the rickettsial disease vector and which is the disease concerned. Okay. Again, this is a bigger table of the disease, the agent, the insect vector, and the mammalian reservoir. Just go through this also, but at least remember this much. Let, fen, try, PSM. This should be there in your mind. Question. Next question. Women traveling from Bihar to Delhi suspecting to have Kala Azar. Suitable investigation. Simple. Test for Kala Azar is what? RK39 test. So RK39 is also called recombinant K39 test for Kala Azar or visceral leishmaniasis. And the solution is colloidal gold, and the time taken is less than 10 minutes. In 10 minutes, you get the test result. Okay. Safe. Safe strategy is for which disease? First tell me it is for which disease, and then we'll expand it. Okay. Safe strategies for prevention of trachoma or blindness related to trachoma. S is for what? A is for what? F is for and E is for what? S is not for screening. What does S stand for? S is for surgery. Okay. So under safe strategy, you have S is for surgery, A is for antibiotic, F is for face washing, and E is for environmental improvement. So the answer is A. WHO safe strategies by WHO. Why? To eliminate blindness due to glaucoma. And which is the A antibiotic of choice is azithromycin. And India was declared free from this infective trachoma in 2017. So India, we don't have trachoma now. Next question is regarding tetanus. All are true regarding Clostridium tetani infection except man-to-man transmission is false. I told you tetanus cannot be transferred from man to man. That is wrong. Okay. Notice this. This thing is called the opisthotonus or the severe hyperextension you get in a patient with the tetanus. Positive agent is Clostridium tetani and it acts through your tetanus neurotoxin. That is why you all get all the neurological spasm and all symptoms like that. False about leprosy. It has been eliminated from India. It can be transmitted through breast milk. Lepromin test is not a diagnostic test. MDT is contraindicated during pregnancy, which is false. MDT can be given during pregnancy. It is not contraindicated. Tests all are true. It has been eliminated from India. The less than 1 per 10,000 cases. This was the cutoff for elimination of leprosy. India has already achieved leprosy elimination. It can be transmitted through breast milk. Lepromin test is not diagnostic. It's just like a screening test or just like your tuberculin test, okay? And the elimination of leprosy, we already told, defined as prevalence less than 1 per 10,000. This was the WHO cutoff, and India could eliminate leprosy in 2005. And as of 2021, your prevalence is very less than 1, that is 0.41 per 10K. This is the present prevalence, that is the latest one which we have. And why is this leprosy not eradicated? It has been eliminated since 2005. We are aiming for eradication, right? National Leprosy Eradication Program. Why? One thing is leprosy has a very long incubation period. That is, average is 3 to 5 years or more. This is one reason that is making this leprosy eradication difficult. And symptoms, sometimes it can take even more than 20 years for the symptoms to appear. All these things make leprosy eradication difficult, but it is not, it can be done. And the next one is WHO staging for HIV. WHO stage for HIV include all except oral thrush. All the rest come under stage 4. So just go through the staging for HIV. Next one is your most effective to prevent HIV vertical transmission or mother to child transmission, which is the most efficient one. This is the ART, heart. Okay, this is the most effective one. Initially, very early, we used to give pseudovidin. But then it was found that no, pseudovidin alone is not that much effective. You have to give the 3 drugs. Which are the 3 drugs? TLT, tenofovir, lamivudine, and dolutegravir. All these should be given for TB. Okay, that is a triple ARV prophylaxis has to be given. It is not pseudovidin anymore. Okay, post-exposure prophylaxis against HIV infection should not be delayed beyond how many hours? That is, you went to the ward, you got exposure from an HIV patient, got a prick from an HIV patient, you have to take post-exposure prophylaxis, right? It should not be delayed beyond what time period? None is the answer, because the answer is actually 72 hours. Within 72 hours, you have to give the post-exposure prophylaxis. It cannot be delayed beyond that time, okay? So as soon as possible is, of course, the best answer, but within 72 hours, not beyond that. Okay. Now, another one question which usually comes is from the STIs, sexually transmitted infections. You have something called the syndromic management of STIs, right? So in that, urethral discharge treatment includes treatment for which one? Neisseria, gonorrhea, and chlamydia, trachomatis. C. So what is the treatment? Again, you have color coding kits, and according to this, it is gray kit, azithromycin, and cefixime has to be given. So this is very important. I'm not going to read the whole thing. You have to study this. You have 7 kits. For example, green is the color coding for vaginitis. The treatment is secnidazole, fluconazole. Your question was urethral discharge, which is kit 1, gray. you have to give azithromycin, cefixime. Likewise, you have, red for genital ulcer, herpetic. So each one, which is the color coding, which is the disease, which is the agent and what is the treatment should be known. Okay. Now, which is a disease with incubation period less than few hours? Hepatitis, food poisoning, influenza, rabies. Food poisoning. You get your result very fast in food poisoning, right? So food poisoning, the incubation period is usually in hours. Salmonella, it is 12 to 24 hours. Staphylococci, again lesser, 1 to 6 hours. Staphylococci and Bacillus cereus, both these, the emetic form, they have a very lower incubation period. That is, within 1 to 6 hours, you get the symptoms. Then for botulism, it is actually 12 to 36 hours. That is kind of longer among these, but still, or food poisoning within hours. Okay, you should know this also because they can give you a scenario. Okay, there is food poisoning, and what is the this thing, which is the agent responsible. So based on the incubation period, you can get an idea on what is the agent responsible. Okay. So one more question. The following dietary changes are advised to reduce prevalence of coronary heart disease except. So in coronary heart disease, we have certain dietary changes advised. The answer is D, that is both B and C. Because increased complex carbohydrate intake is correct. Saturated fat intake more than, no, it should be less than 7%. Salt intake should be less than 5. So the advice is called prudent diet. Okay, these are the dietary goals which is to be used for the prevention of CHT. These are the WHO recommended goals. Okay, so our goal is to bring the cholesterol to HDL ratio to less than 3.5. What all should be done? Fat intake reduced to less than 20 to 30% of the total energy intake. Saturated fat less than 7. Dietary cholesterol less than 100. Increase complex carbohydrate consumption. It is increase. Okay, rest all are reduction. Reduce salt to less than 5 and avoid alcohol. These are the the steps in the dietary goals under the prudent diet to control or to prevent CHTs. Okay. So now we'll take a short break. Okay, now we'll have a discussion on few questions from obstetric, pediatrics and preventive pediatrics and obstetrics. First question, which of the following is not included in the 5 cleans in conducting a delivery? Clean hands, clean perineum, clean cutting and care of cord, clean surface. It is clean perineum. Okay. One more point. Now it's not the 5 cleans. Now we have 7. Okay, it is 7 cleans. Okay, 5 cleans are practices under strategies for elimination of neonatal tetanus. All these things, why are we doing? To eliminate neonatal tetanus. We have eliminated still. These are the 5 cleans. You have clean delivery surface, clean hands, clean cord cut, clean cord tight, clean cord come. Plus 2, that is clean water and clean towel for hand washing. That is also important. Just like you have the 7 cleans, you have 6 F's, which are called the sanitation barrier. Okay, which are the fingers, flies, fomites, food, feces, and fluids. These are the known as the 6 F of sanitation barrier. Okay, next question. A 37 weeks pregnant woman attends an antenatal clinic at a primary health center. She has not had any antenatal care till now. Best approach regarding tetanus immunization in this case would be. So you have a 37-week pregnant lady coming to you for the first time without any TT taken before. What would you do in this case? So what you have to do is you have to give a dose of TT and explain to her that it will not protect the newborn and she should take the second dose after 4 weeks, even if she delivers in the meantime. So she's already reached 37 weeks, right? So, but still, you are supposed to give, according to the guideline, you have to give at least 1 dose of TT. You don't have time to give the second dose, right? It's already 37 weeks. So you give the first dose. You tell her that this cannot protect the newborn. The child can have risk of tetanus and she should take the second dose once the 4 weeks are over. That is usually probably after the delivery. That is the answer. And what about the infant? Infant needs protection, right? So infants born to unimmunized mothers, that is mothers who have not taken TT, or partially immunized mothers, like our case here, should be given what? 750 international unit of antitoxin within 6 hours of birth. This is very important. Okay. So if a mother has already taken TT properly, then you don't need to give all this antitoxin. Suppose somebody is coming with partially immunized status or unimmunized mother coming to you for delivery. To prevent the tetanus in the baby, within 6 hours of birth of the child, you have to give 750 international unit of antitoxin. Fine. Now, all are criteria for identifying at-risk infants except birth weight less than 2.8 kg, birth order 5 or more, PM diarrhea and working mother. The answer is birth weight less than 2.8. It is not the risk factor. No, it should be not 2.8. It's 2.5. So, whom do you call at-risk infants? This is basically a risk approach where these babies are at a higher risk and higher risk of what? For death. They can have more perinatal, neonatal, all kind of mortalities will be more in them. So you have to give special attention. That is the main purpose of classifying patients or subjects according to risk. So which all babies come under this high category or high risk category? Your birth weight less than 2.5, which is a low birth weight. Twins. Then birth order more than 5. Artificial feeding, that is also not breastfed. Weight is 70% of the expected. Failure to thrive. And children with PM diarrhea and working mother or single parent. Again, this one is also a at-risk infant. Fine. Okay, this question we've already discussed. It's a repetition, okay? You're asked to calculate the MMR. I'm not discussing it here now. So, the next question is about breast milk. The following statements about breast milk are true except, again, breast milk is an important topic. You should know the composition of breast milk. You should know what is baby-friendly hospital initiative and comparison between breast milk and cow's milk. So all these are potential questions that can be asked. So here the question is, which is false about breast milk? Okay, first one, maximum milk output is seen at 12 months. No, that itself is false. It is seen around 6 months. 5 to 6 months is the time when there is maximum milk output. The coefficient of uptake of iron in breast milk is 70 is correct. Calcium absorption is better. Of course, it's better than that of cow's milk. And the calories, it's around 70 kilocalorie per 100 ml. This is also important. 70 kilocalorie is the calorie per 100 ml of breast milk. And which is absent in breast milk? The vitamin that is not there in breast milk is vitamin D. Your breast milk does not have vitamin D, okay? So, So remember the nutritive value of breast milk. I'm not discussing this here because due to lack of time, but this PDF will be provided to you. So just go through it and just study this, okay? Now, deficit in weight for height in a 3-year-old child indicates weight for height. What is this weight for height showing? It is acute malnutrition, okay? Weight for height is acute malnutrition. When there is height for age, when the height of the child is decreased, that shows chronic malnutrition. Fine. So weight for height is acute malnutrition. Then you should know about the Anganwadi ICDS growth chart. So Anganwadi, they have separate growth charts. So these are the growth charts for the girl child and for the boy child. You have separate growth charts. You have separate growth chart for weight for age, height for age, weight for height, etc. And you have 3 zones, okay? There's a normal zone, which is gray color. Then you have undernutrition, below -2 standard deviation. Severe underweight is less than -3 standard deviation. So it's not gray color. This is wrong. You have color coding here, see? You have green, yellow, and orange. This is normal. This is your less than -2 standard deviation, and this is less than -3 standard deviation. What is the use? This is for plotting the weight of the babies in the Anganwadi, okay? So that even the Anganwadi staff there, the worker, the Anganwadi teacher, she'll be able to find out whether the child is having a, going towards malnutrition or not. And what is the other name? This chart, the growth chart, it's also known as what? Road to health chart. And you should know something called this MGRS. This is a multicentric growth study which happened. It was based on this study that we have the present growth charts that you see now. Now, who looks after the work of Anganwadi worker? Who's above Anganwadi worker? It is the Mukhya Sevika. So in Anganwadi also there is a, administrative cadre coming. So the administrative unit of ICDS is called your Community Development Block. So under each block, it covers a population of 1 lakh. Okay, in rural or urban areas, and under this you have one CDPO, or she's the Community Development Project Officer. She is in charge of 4 Mukhya Sevikas, also called as the supervisors, and then 100 Anganwadis. So you have the Community Development Project Officer. Under her, she is in charge of 4 supervisors, and under each supervisor there is 25 Anganwadi. So total of 100 Anganwadis. So Anganwadi teacher or Anganwadi worker, just above her you have the Mukhya Sevika. Above the Mukhya Sevika you have CDPU. Okay. What is false regarding Indian reference women? Indian reference women, the age, it is 18 to 20. And this is actually an old question, The Indian reference woman. Anyway, this is wrong. The 50 kg weight is wrong. Its weight is always 55 kg for reference woman. Now they have a newer thing. They have slightly changed. So you have an Indian reference man and Indian reference woman as per according to the latest guidelines. So the age group for both is, it was earlier it was 18 to 29. Now we have changed it to 19 to 39 years for both, okay? And the weight, for man it is ideal weight 65 kg, women 55 kg. In the question it was 50. The height is 1.7 meters. Here it is 1.62 meter for women. BMI is 20.75 and 20.95 BMI. And the rest of the things are the same. That is, the person is free of disease, healthy, and is engaged in 8 hours of work, 8 hours of sleep, 2 hours of walking around, and all those things are the same. So the basic difference is, this is new. This age group has been changed, okay? It is 19 to 39. This is new. And even the calorie, 22, 20.75, 20.95. Now, low glycemic index is for sucrose, potato, white bread, fruits. It's fruits. Fruits have the lowest glycemic index among those given here. Even among fruits, fruits like mango, banana, watermelon, these have very high glycemic index, okay? So usually ask, these are to be avoided by whom? By patients who are having diabetes mellitus. Fine. Okay, now we'll move on to some questions from nutrition. So due to lack of time, I'll be going through the questions very fast. If you have doubts, if you find it difficult, please go back and revise your nutrition modules, or we'll be giving the PDF also. So if you find some questions difficult, please do revise, because nutrition is a very important area as far as NEET-PG is concerned. You get a majority of questions do come from nutrition. Okay, so serophthalmia. In serophthalmia, what is this 1B? That is bite or spot. Okay, so this is the primary signs you have, and secondary signs you have X1, A, B, then 2, then 3, 4. Here you have under B you have bite or spots. This is the diagram. This is what? Serophthalmia is due to deficiency of which one? Vitamin A. This is the bite or spot. Okay. Again, this can be an image question, a spotter. Maybe asked to identify also. Now, pasteurization of milk. Pasteurization by Holder method is heating milk at what temperature, what time? Pasteurization is for 65 degrees Celsius, for time is 30 minutes. Okay. Option B is the correct answer. So what are the other methods? You have the Holder method, you have HTST method, HST, UHT, and different methods are there. Different temperatures are there. You should study this also. Okay. Now, some other noteworthy temperatures. See, for cold chain, temperatures 2 to 8 degrees Celsius. Then your yellow fever vaccine, it is different. For reverse cold chain also, it is 2 to 8 degrees Celsius. Parboiling, 65 to 70 degree. Heat stroke happens if the temperature goes more than 110 degree Fahrenheit. Autoclave, 121. Autoclave 121 is also very important. Okay. Now, endemic ascites. Now you have, food adulterants. Diseases caused due to certain food adulterants. You have endemic ascites, you have laterism, then you have what? Your epidemic dropsy, many things are there. So all these are important. Go through all these, and you'll definitely get at least 1% from these area. Okay. So for endemic ascites, the causative agent is pyrrolizidine alkaloid. Okay. So these are the toxins and these are the adulterants. Laterism, it's a neurological defect. The toxin is BOAA due to adding kesari dal or Lactaris sativus, hence the name. Epidemic doxy is due to Argemone mexicana oil. That is the mustard oil, nothing else, the mustard oil. The toxin is sanguinarine. Then endemic ascites is due to the crotalaria seed. And the toxin is pyrrolizidine. And aflatoxin, aflatoxin. This is due to Aspergillus fungus. Okay. And you have ergotism due to Claviceps fusiformis. Again, the toxin is, name is easy to remember, it is clavin alkaloid. Okay. So any of these questions, any of these conditions, they can give you a clinical scenario. A patient is coming to you with this, identify the toxin or identify the disease. Anything can be asked. So this part, all these diseases are very important. You have to learn. Example, here's a question here. See, 42-year-old woman from a dry state, ingested dry for a long time, presented with complaints of weakness, so neurological, in both the lower limbs, nausea and fatigue. Over due course of time, she is completely unable to walk. What is the likely cause? So she is unable to walk. So initially she had weakness, then it had a particular neurological stages, and finally she is unable to walk. The cause is Lactaris sativus, and we are talking about what? We are talking about laterism here. Okay. So here laterism, initially the patient is able to walk, then later on there are different stages of laterism, different manifestations. Please go through it. Finally the patient is unable to walk. Now we'll just have some important, I have 7 slides for you. We'll just brush through all those 7 slides, and just these are all important things. Okay. So what is the first slide? What am I showing you? There is a Wernicke's encephalopathy, Korsakoff syndrome, also known as what? Wet beriberi. And what can you see here? Polished rice. So what are we discussing? What is this slide all about? It's about your thiamine deficiency or vitamin B1 deficiency causing beriberi. That is your Wernicke's encephalopathy and Korsakoff syndrome. What is the cause? Cause is polished rice. You may be given, clinical scenario of this Wernicke's encephalopathy. You may be asked which is the vitamin deficient. Okay. Second one, what is this? Which is the deficiency showing here? What is this? You see a necklace here. You see dermatitis here. So there is dermatitis, dementia, diarrhea, death. 4 Ds. And this is caissons. necklace. This is seen in niacin deficiency, also called as pellagra. Okay, pellagra can be asked as a clinical question. Next one, egg. Egg is known as your reference protein, right? You know the 6 rule of egg. 60 gram egg has how many kilocalories? 60 kcal. It can have 6 gram protein. It gives you 6 gram fat. And cholesterol, what is the cholesterol level? Is 250. 250 is the cholesterol level in a single, single 60 gram egg. And the calcium level, calcium is 6 into 5, okay, 30. So 60 kcal, 60 is the calorie, 6 gram protein, 6 gram fat, 250 is the cholesterol content, and 30 is the calcium in an egg. Okay, now, but what is the limiting amino acid in cereals and pulses? If for cereals, remember calicut, CLT. This is the code, CLT. For cereals, the limiting amino acid is lysine and threonine, okay? So CLT, cereals, lysine and threonine is the limiting amino acid in cereals. What about pulses? Pulses, you remember it as PCM. Initially, we used to have a scholarship exam, PCM. If you have written that, you might be remembering this code. So PCM is for pulses. So pulses are deficient in which all amino acids? C is for again cysteine, M is methionine, okay? So cereals are deficient in lysine and threonine, CLT. Pulses are deficient in PCM, cysteine and methionine. And you have maize. Maize is actually deficient in MLT. L is the same thing just like your cereal lysine. But the T is actually tryptophan. It's not threonine, it is tryptophan. Fine. So what is this? This is the, what are you seeing here? You are saying vitamin D deficiency or rickets. Again, clinical scenario can be asked. What are the symptoms you see? You see craniotabes. You see a particular rosary, a bead-like appearance here. That is called your rachitic rosary. PG and test deformity should be there. Hairs and sulcus you get. Then knocked knees or bent knees, bow legs, everything is symptom or characteristic of your rickets. Now what is this? This is your dropsy, okay? Epidemic dropsy, that's what they're showing in this picture. This is that seed. And now this is endemic ascites due to panicum seeds. So now few questions from environment. First one is about chlorination. All the following statements are true about breakpoint chlorination except option A, free chlorine is released in water after breakpoint chlorination. Chlorine demand is the amount needed to kill bacteria, oxidize organic matter and neutralize ammonia. 1 ppm free chlorine should be present in water after breakpoint has reached contact period is 1 hour, which is false. See, the false statement is C. 1 ppm free chlorine should be present. It's actually 0.5. It's not 1 ppm. So this is wrong. Okay. So what do you know about chlorination? First thing, chlorination is a form of disinfection. Agree with me? Yes. What are the other forms of disinfection? Boiling. Boiling of water. Simple boiling is a disinfection. Then you have chlorination. Then you have treatment with ozone. Things like that. So which is the best method of disinfection? It is not chlorination. It is actually boiling. This is the best. The second best method is chlorination. Okay. And in chlorination, what happens? You're adding chlorine to water, right? What are you adding? You're adding bleach. What is bleach? CaOCl2. This is your bleach. You're adding bleach to water. If you directly add bleach to water, it is not stable. You have to add lime to this and then you add this to water. Okay. And what are the active ingredients? This chlorine, this combines with water and it forms HOCl. That is hypochlorous acid, and OCl. That's hypochlorite ion. Both these are responsible for the disinfection. Out of this, 90% work is done by your hypochlorous acid, HOCl. 10% is done by your OCl or the iron. Okay, and another MCQ that can come is, the 33%. That is the chlorine content in bleach. That means if you take 100 gram of bleach, there will be 33 gram of chlorine in it. There's another question that can come. Then you should know about what is chlorine demand. is residual chlorine. What is superchlorination? See, all these are important MCQs. You have to read about chlorination. Then your apparatus that are used for chlorination. You have Horrocks apparatus, then you have chlorinometer, you have chloroscope. Horrocks apparatus is used to estimate the chlorine demand. The picture you see here, this is your Horrocks apparatus. Uses estimating the chlorine demand. Then you have two tests. One is your OT test. Then another one is your OTA test. OT is orthotoluidine test. OTA is orthotoluidine arsenide test. Okay. So what is the difference between this OT test and OTA test? OT test can detect, free chlorine as well as combined fluorine. But OTA test can actually detect both of them differently. That is the main difference between OT and OTA. Better one is, of course, orthotoluidine arsenide test is superior over your orthotoluidine test. Then, so next question is, most reliable evidence of fecal contamination of water is provided by coliform bacteria, Clostridium perfringens, fecalis and welchii, Clostridium welchii. So the answer is coliform bacteria. Okay, you remember this. So coliform bacteria is the most reliable evidence for fecal contamination of water. Now, question about your sand filters. You have rapid sand filters, you have slow sand filters. Rapid sand filters, as the name indicates, your filtration process is very fast, right? And slow sand filters is comparatively slow. And all are true for rapid sand filters except question options are no preliminary storage of raw water is required. That is true. Operation requires high skilled persons. Yes. Can be gravity type of pressure type. Yes. Frequent washing is not required. Wrong. You need to do frequent washing in rapid sand filter. So this is a table showing the basic difference between a rapid sand filter and slow sand filter. Go through this. You should know this. You can get questions from this area also. These are the diagrams of rapid sand filter and slow sand filter. Now, what is the flight range of Aedes mosquito? Aedes mosquito flight range is 100 meters. Okay. So different mosquitoes, you have Anopheles, Culex, Aedes and Mansonia. The flight range is 3 to 5 kilometers in case of Anopheles, which is responsible for the malaria. Culex 11 kilometer. Aedes actually has a very less flight range, that is 100 meters. So you should know to differentiate Aedes, Anopheles and Culex mosquitoes. Aedes is also called your tiger mosquito, right? Then you have the larva form, pupa form and all that. In the larva form, you see, this is something called a siphon tube. In Aedes mosquito, the siphon tube is in line with the body of the mosquito. Whereas in Culex, it is at an angle. You see, it's in an angle. It's not in line with the body of the mosquito. That is how you identify the larva. And for Anopheles, you don't have this siphon tube. You just have something like a brush here. You don't have the tube there. So that is a differentiate. That is how you identify the larva of all these three mosquitoes. Aedes mosquito, where do you see it? Mainly it breeds in artificial containers, causative agent for dengue. So artificial containers are the main source. Culex you see in dirty water, and Anopheles you see in comparatively clean but stagnant water you see. Okay. Now, all are indicators for air pollution except soiling index, McArdle's index, suspended particle count, SO2 concentration. The answer is McArdle's index. It is not a indicator for air pollution, but all the others are indicators for air pollution. Now, Carter thermometer measures what? It measures three things. It actually measures your air temperature, humidity, and air movement. So, this is the image of a Carter thermometer. It measures the cooling power of the air. Basically, your air temperature, air humidity, and air movement combines to see cooling power of the air. That is what your thermometer is measuring. Then, what is this? This is your AQI. Again, this is a potential question that can come. Air quality index. So you have different stages from 0 to 500. You monitor the air quality, and you can say the air quality of this place, Delhi, it is maybe very unhealthy. The air quality is the AQI is this much, so it is unhealthy. In Kerala, it is this much, so it is maybe healthy. So whatever that you do with this air quality index. Now we'll see some questions from the programs. We have many national programs. Some of them I've already discussed along with your communicable diseases. We'll see some others, okay? So anti-tubercular drug contraindicated during pregnancy. Easy question. Isoniazid, rifampicin, streptomycin, ethambutol. Of course, it is streptomycin because it is teratogenic. You don't give streptomycin in a pregnant lady. Not just TB, you don't give streptomycin in a pregnant lady, okay? Next question. 45-year-old male patient comes to OPD with cough and diarrhea since last 3 weeks. On diagnosis, he is found to be HIV positive with tuberculosis. So what do you do? So you have a patient coming to you. He is having HIV and TB. The question is whether you start treatment for HIV first or whether you start treatment for TB first. Whether you start ATT or ART. What is the answer here? You start ATT first, okay? First you start ATT, then you wait for 1-2 weeks so that the patient, gets used to that ATT drugs, and then only you go for the ART. Again, this is also important. So patient with HIV plus TB comes to you. First you start ATT, then you go for ART. So objectives of NTP. A, detect at least 85% of cases, achieve at least 85% cure rate, no help from NGO, achieve at least 90% cure rate. What is the answer here? It is 90, okay? Your NTP or National Tuberculosis Elimination Program is achieving at least a cure rate of 90%. So these are all the objectives of given here. Achieve at least 90% notification rate, 90% success rate, and you have to incorporate private sector also in this. Now next question is, what are the 4 statistic pillars of NTP? What is this NTP? There is National Tuberculosis Elimination Program. They had a strategic plan. Okay, under that 4 pillars were described. What are those? The answer is DTPP. These are the 4 pillars of your National Strategic Plan, or maybe of your NTP. D stands for detect, treat, prevent, and build. This is the 4 pillar. Okay, option is D. So remember this 4 pillars of NTP or 4 pillars of the National Strategic Plan is detect, treat, prevent, build, DTPB. So under AFP surveillance, follow-up examination is done after how many days of residual paralysis? Again, 60 days. Simple question. So you have to do a follow-up analysis, or you have to check for residual paralysis in a patient with AFP after 60 days of the onset of paralysis. Okay. Now, Anemia Mukt Bharat questions. Elemental iron and folic acid contents of pediatric iron folic acid tablets supplied under Anemia Mukt Bharat are. You should know the doses, okay? You should know how much is the dose of elemental iron and how much is the dose of folic acid given in all the different categories under the Anemia Mukt Bharat program. You have pregnant lady, you have reproductive age group female, you have adolescent girls, you have pediatrics, children. So in children, pediatric children, it is 20, okay? 20 mg of iron and 100 micromolar of folic acid is given weekly for pediatrics. Whom do you give this 60 mg? 60 mg and 500, it's not 100, 500 microgram is given in pregnant women as well as women of reproductive age group. The dose is 60 mg elemental iron and 500 microgram of folic acid. But in pregnant women, you give it daily, 180 days before delivery and 180 days after delivery. But for reproductive age group women, you have to give it only once a week. And what else is you should know about Anemia Mukt Bharat? Anemia Mukt Bharat program, it is 666. That is, you have your 6 interventions, okay? 6 mechanism and 6 beneficiaries. This is 666 is for your Anemia Mukt Bharat. Okay. Now another question. 46-year-old female presented at the IOPD. Vision in the right eye is 6/16, left eye is 3/16. So under the National Program for Control of Blindness, she will be classified as what? So you should know that the classification of blindness slightly differs from WHO and what's given in your national program. So WHO has a separate definition for certain things, whereas your national program has a slightly separate definition. So in this case, 6 by 60 is actually low definition because the question is under your national program. So what is WHO say and what does the national program say? So WHO defines blindness as visual acuity less than 3 by 60 in better eye. Whereas your national program defines blindness as visual acuity less than 6 by 60. Okay, so when there's a question, you see whether they're asking for the WHO cutoff or the national program cutoffs. Okay. Now, drug used to prevent mother to child transmission of HIV in India is which one? It is lamivudine. Actually, it is not lamivudine alone. To prevent the mother to child transmission of, HIV, in India you give the triple drug therapy. That is, you have to give ART, tenofovir, lamivudine and dolutegravir. In this option, you have only lamivudine, so I'm taking it. Otherwise, it is actually not lamivudine alone, it's the triple drug therapy is given. Okay, BDCP does not include NVBDCP, stands for National Vector-Borne Disease Control Program. It has 6 diseases, right? What are the 6 diseases under NVBDCP? You have malaria, Kala-Azar, filariasis, chikungunya, dengue, and Japanese encephalitis. So option here is none. All of these 3 are included under NVBDCP. Plus additionally you have 3 more. So it's a total of 6 diseases. Next question. Treatment of malaria in pregnancy. A pregnant woman in 3rd trimester having fever was diagnosed as a case of falciparum. Okay, so she's having falciparum malaria. Which is the trimester? 3rd trimester. So under the National Health Program, which drug is recommended? So here in pregnancy, first trimester you cannot give chloroquine or ACT. If the question was first trimester, then the drug was quinine. In first trimester, you give quinine. After that, after the first trimester, whether it is 2nd or 3rd, you can give ACT. Okay. So the answer here is ACT only. What about primaquine? Never give primaquine in a pregnant woman. It is completely contraindicated in pregnancy. Don't give primaquine in a pregnant woman. So your treatment is, if the person is coming in the first trimester, you give quinine. Afterwards, you give ACT. Whether to give ACT AL or ACT SP depends on the state. If she is from a northeastern state, you give ACT AL. All other states you give ACT SP. Okay. Remember, primaquine is contraindicated. Okay. Same thing only, treatment of uncomplicated falciparum cases in pregnancy. First trimester, what do you give? Quinine salt, 10 mg per kg, 3 times for 7 days. 2nd and 3rd trimester, area-specific ACT as per the dosage, that is ACT AL in Northeast and ACT SP other states. Okay, clear? So you should know the treatment of malaria, general population as well as pregnant women thoroughly. There should be no confusion in that. Now, about ASHA. ASHA stands for Accredited Social Health Activist. All are true except they are preferably females. True. 1 ASHA per 1,000 population. True. ASHA skilled birth attendants. No. ASHA will not take any deliveries. ASHA is not a skilled birth attendant. She's a volunteer from the community who helps or who acts as a contact between your population and the health system. She's not skilled in attending births. She provides primary medical care for minor ailments is true. She can. And she's actually, so what are the functions of ASHA? She's also a depot holder. She have to, counsel the mothers, the children and all about the nutrition and all the health related things. Then she's a depot holder for many things like the deworming tablet, your family contraceptive things, all those. Then other works include, home-based newborn care. You have something called home-based newborn care, home-based young child care. All these, who's going? ASHA. ASHA worker has to go to the houses of the newborn and see for any danger signs, or if the mother is having any doubts regarding breastfeeding, counsel the mother and help her to pick up any danger signs. All these are done by whom? Your ASHA worker. And ASHA came in which program? NHM, National Health Mission. Okay. Okay. This is a question which you guys might miss. Impact indicators of monitoring and evaluation of ASHA's work. What is the impact indicator whereby you can monitor ASHA's work? It is infant mortality rate of that area and child malnutrition rate. Okay. Also, the number of cases of TB or leprosy detected as compared to last year. So you should know the criteria, who is eligible to become an ASHA, what all are the functions, and how is the money getting? How is she getting the money? This is based on the work she do. Okay. It's an incentive base. So for certain things, she get an incentive. That is the how the salary of ASHA comes from. Then next question. Which of the following is not true for stepwise approach developed by WHO for non-communicable disease surveillance? So there is something called the WHO steps approach for NCD risk factor disease surveillance. Okay, this is the question asked here. So they're saying step 1 consists of interviewing for collecting relevant data as true. Step 2 includes measurement of blood pressure and audiometry. True. Step 3 includes blood sample collection. Step 4 consists of treatment of NCD. No, you don't have a step 4. You have only 3 steps. Step 1, step 2, step 3. Just 3 steps are there in this. So this is the diagram here. So under step 1, so basically this is a surveillance thing which can be utilized by any country to do a surveillance in their country regarding the WHO risk factors. Anyone can do the study. Okay, so basically they say 3 steps: step 1, step 2, step 3. The step 1, interview. That is, you have a questionnaire, you go to the population or to your study subjects and you ask them about the risk factors, age, and all those things. You take history basically. Step 2 is you do physical measurements. You take the height, weight, BMI, PP, all the physical measurements come under step 2. Now step 3, you have to take blood. Okay, you have to go for the biochemical measurements. That is, you have to take blood and do the testings. That comes under step 3. So we have only 3 steps, 1, 2, and 3. There is no 4th step. Okay, so that is the wrong answer. Now, link worker scheme is in which national health program? Link worker scheme comes under the NEET-PG or National AIDS Control Program. So who's a link worker? In AIDS control, we have certain populations, right? We have high-risk groups, we have bridge population, we have the general population. Whom do you consider high-risk group? High-risk group are those persons, maybe men having sex with men, transgenders, ISRAs, then your drug users, IV, drug abusers. Then you have your, commercial sex workers. All these people come under the high-risk group. Okay, that is, they have a higher chance of having HIV. Then you have your general population, and then there is something called a bridge population. Bridge population are the people who go to this high-risk group, take this HIV infection, then who can give to the general population. They act as a bridge between your high risk and your general population. Bridge population consists of 2 people. Who are they? Long distance truck drivers and single male migrant. This is the bridge population. When you do HIV surveillance, you have HIV sentinel surveillance done by NACO, National AIDS Control Program. Basically, there they find out the prevalence. The surveillance is done in different groups. They do surveillance in the high risk group, in the bridge population, as well as the general population. General population means they do it actually in the ANC mothers. Okay, so the ANC, that is the antenatal mother, the pregnant woman, is taken as a proxy for the general population. So the question here was link worker scheme. So the link worker scheme is to address populations with high risk behavior. You actually choose someone. See, high risk behaviors and all. It is difficult for the somebody from outside to go and talk to the people, to the high risk groups, because the topics are kind of sensitive, right? We'll have to talk them about the sexual practices and things like that. So you choose someone who's not an alien. You choose someone from that neighborhood, from the community, from that neighborhood. Just like you choose an ASHA is from the community only, just like that you choose a link worker, and their main objective is to address populations with high risk behavior. So somebody who's accepted by the village communities, somebody who can discuss things, somebody who can give counseling and all that. So link worker scheme is for NEET-PG. Okay. Now, PCPNDT Act. What is PCPNDT Act? What are we doing there? So, PCPNDT Act is to prevent female feticide. What is the full form? It is the Preconception Prenatal Diagnostic Techniques Act of 1994. That is, before, you are not supposed to reveal the sex of the baby before birth. Scanning, whatever you do, you're not supposed to reveal the sex of the baby before birth. Why? Because there is a high incidence of female feticides. If the parents, they have a preference for a boy child, if they come to know that this is a girl child, they can go for abortions, right? To prevent that, we have this act, which is the PCPNDT Act in 1994. Now, what else? What is the other act which you should know? The MTP Act. Your MTP Act is important, 1971. Now, you have a recent amendment of MTP Act in 2021. No. What was the amendment? See, MTP is allowed in India up to 20 weeks only, according to your 1971 MTP Act. But now, it is allowed about 20 weeks also. That is, up to 24 weeks, MTP can be done. When? Under special situations only, not for everyone. This is for special situations, like for example, a rape victim, incest, or things like that. You have to consider what is the situation, then it can be done, it is allowed. That is the amendment that came in 2021 regarding your MTP Act. Now, we'll have a, we'll have a 2020 game here. I have brought 20 image slides. Through this 20 image slides, we'll just discuss all the important national programs. Okay, only the logos are there. You have to tell me which is the program and some basic things about the program. Okay, the first one, this is your first time. What is this? This is your new program or the new scheme. This is your Ayushman Bharat. Very important potential question. Okay, Ayushman Bharat is known as Government of India's flagship program, and the program basically has two prongs. It has a health and wellness centers, and you have insurance, PMJ. So under health and wellness centers, you have specialized centers where all the health related, your services are given to the patient free of cost. Health and wellness centers are nothing but your existing health centers, the PHCs or some sub centers. They are given, given improvement, and they are upgraded into health and wellness centers. Recently, this name has been changed to Ayushman Mandir. But you should know, one prong is health and wellness center. Who is the person sitting there? It will be a community health officer. Okay, this person usually is not a doctor. He is a nursing officer. So that is health and wellness center. The second prong is your insurance. That is PMJ, Pradhan Mantri Jan Arogya Yojana. Here, the poor people, they get an insurance coverage for health related rates. How much is the amount? You can get maximum up to 5 lakhs. Before this Ayushman Bharat came, we had something called RSPY. There the maximum cutoff was 30,000, but here it is 5 lakhs. So you should know Ayushman Bharat, two prongs, health and wellness centers and PMJ, and the amount given is 5 lakhs. Okay. Now, what is this? What is the logo showing? Which is this program? This is the logo for your NLEP, National Leprosy Eradication Program. And who's she? This is Sumna, the mascot for your NLEP. So leprosy we have already discussed. India has already eliminated leprosy. Cutoff was less than 1 by 10,000 cases. Okay, now we are aiming for eradication of leprosy. So this is the logo. They can ask you this logo. Okay, see a rising sun and a lotus. So this is the logo for National Leprosy, NLEP, National Leprosy Eradication Program. Now, these are all images. So coming to the third slide, this is TB. You have TB and TEP, National TB Elimination Program. And you have something new, that is the TB Mukt Bharat, just like your Anemia Mukt Bharat. What is this? This is your online portal. This is what? NEET-PG. Here, all the details of the patient, all the detected TB patients' details have to be uploaded in this portal. And you get all the details, okay? This is the online portal for TB, NEET-PG. Kshay means TB. NEET-PG means no TB, okay? Then you have something called NEET-PG Poshan Yojana. What is this? See, under NEET-PG Poshan Yojana, Poshan is what? Nutrition, right? You're providing patients money so that they can improve their nutrition. They get 500 rupees per month to improve their nutrition, because TB, it's a disease of undernourished people, and for the better improvement or the better, they need good nutrition. Okay, so giving a 500 rupees per month. So if it's for 6 months, the patient gets a 3,000 rupees at the end of 6 months or in installments. So that is Nikshay Poshan Yojana. So this is coming to the next slide. What is this? See a mosquito here. Your family is protected from this, vector mosquito. This is the logo for your National Vector-Borne Disease Control Program. How many diseases? 6 diseases. We have already discussed which are the 6 diseases, right? So that was NVBDCP, and there is something called integrated vector management under this program. So read about this integrated vector management also. Now this is your NP-NCD. So initially you had NP-CD-CS, National Program for Prevention of Cardiovascular Disease, Diabetes, Stroke and CVDs. Okay, now this name has been changed to NP-NCD. Here you have National Program for Prevention and Control of Non-Communicable Diseases. See the logo here, health in your hands. Your health is in your own hands. So this is the logo. You should know this logo. They can ask questions from this. And something, an important question that can come from NP-NCD is what is PBS? It is population-based screening. Or the question can be PBS comes under which of the national programs, or which of the national program includes this population-based screening. It is NP-NCD. It is nothing but the health workers, the ASHA and the ANM. They are supposed to go to the population, to each and every person in the population above 30 years of age, and then they are supposed to screen for your major NCDs, hypertension, diabetes, and major cancers like breast cancer, CA cervix, and your oral cancer. So that is happening now, that is going on. So that is this population-based screening. It's part of your NP-NCD or NP-CDCS. Now what is this? You see a mother and child. So it's something related to maternal and child health, right? So it is Pradhan Mantri Matru Vandana Yojana or PMMVY. Here, this program is basically the aim was to increase the healthcare seeking behavior of your ANC mothers. What do you give? Under this program, that is under the Pradhan Mantri Matru Vandana Yojana, you give money, you give rupees 5,000 is given to the mother in 3 installments, okay? In 3 installments, she gets this money. The installments are, one is when the first antenatal visit is made, for the early registration of pregnancy, then when the antenatal visits are made, and then last one is when after the child is born, the child is given the first dose of immunization. Then she gets an amount of 5,000 rupees. I forgot to tell you there, what are the minimum number of antenatal visits? It's not related to this program, just asking you a general question. Minimum ANC visits advised, minimum is 4, okay? And when all are the 4 visits given, you should know. So that was PMMVY, to increase the health seeking behavior of ANC mothers. Government is providing 5,000 rupees. Okay. Now what is this? Pradhan Mantri Surakshit Matritva Abhiyan, PMSMA. Here what happens is the 9th of every month, they conduct, the government organizes camps, for patients, outreach camps. Outreach camps are conducted so that they can get the required antenatal visits, and specialist is also there. You'll have gynecologists also coming to outreach areas or heart reach areas. They go and they conduct free medical checkups for the pregnant women on the 9th of every month. That is your Pradhan Mantri Surakshit Matritva Abhiyan or PMSMA. Now what is Suman? Suman is Surakshit Matritva Ashwasan. Suman is again dignified pregnancy or motherhood. So Suman is also related to your This is the logo, okay? So, Surakshita Matritva Ashwasan, again for the maternal and child health, another program. Then you have your Lakshya, LAQ. This is the logo for Lakshya. Lakshya is a quality. Q is for quality improvement initiative. Okay, Lakshya is basically aiming to improve the quality of care where at labor rooms, your OT. So to ensure that the mother and child gets very good quality of care, that is your Lakshya. Now you have your JSY and JSSK. Usually ask question where people go wrong. JSY is different, JSSK is different, okay? JSY has Janani Suraksha Yojana. There is no Shishu in this, there is no child, it is just for the mother. This one, JSY, is to promote institutional deliveries. Okay, JSY is for institutional deliveries. That is when the pregnant mother, to prevent your home deliveries. When the pregnant lady comes and delivers in an institute, in a government institute, the women, they are given a money, as well as the ASHA worker, whoever is accompanying her, the ASHA who motivated her to come to this institution for delivery. She is also given a incentive, a money, so that you promote more of institutional deliveries. That is your JSY. JSSK has Shishu also. This is your Janani Shishu Suraksha Karyakram. So JSSK has Janani as well as Shishu. That is for the mother as well as for the child. JSY is only for the mother, Janani. Okay. So under JSSK, the mother and the child, they are eligible for free services at the hospital, whether it is delivery also, everything should be free. Once the patient comes for the delivery in the hospital, it should be free. Even if she's going for a cesarean session, that is also done absolutely free. And for the first 48 hours, that is, or till the time the patient is discharged, at least 48 hours, even the diet, the food, everything is given free. And then she is also the transportation, from the home to the hospital and then back. Once the baby and the mother after delivery is discharged, she should be given free ambulance services that she reaches home back. Then also for the child up to 1 year of age, initially it was not 1 year, it was 1 month or something, but now up to 1 year of age, the child also can avail, treatment. So this is the Janani Sishu Suraksha Karyakram. Now there is something called MA. MA stands for Mother's Absolute Affection. What is this? MA is basically, awareness program, awareness campaign kind of program, which is to improve or which is to promote breastfeeding. Okay, what are they saying? Breastfeeding should be given within 1 hour of birth. Yes. Then breast milk alone up to 6 months, it should be exclusive breastfeeding, not even water. So if I ask you a question, whether a child is sick, so you're giving some antibiotics or some paracetamol syrup to a child who is 4 months, does it come under exclusive breastfeeding or not? Actually, it comes under exclusive breastfeeding. You can give breast milk, not water. Once you give water, it is not exclusive breastfeeding, but medicines are allowed. Okay, for any syrups or any medicines, if you give, that is also coming under your exclusive breastfeeding. That is not exception here. And usually you advise the mother to feed up to 2 years of age. Okay, she can feed more than that also, but at least a minimum of 2 years the child should be given breastfeeding. So 6 months exclusive breastfeeding. After 6 months, complementary feeding comes in, but along with that, continue the breastfeeding at least till 2 years of age. Now, what is this? There's a baby here. You have the Indradhanush, different colors are there. And you have a syringe there. This is your mission Indradhanush. Indradhanush is for preventing 7 vaccine preventable diseases. These are the 7 Indradhanush. Like rainbow has 7 colors: measles, polio, pertussis, tetanus, TB, diphtheria, hepatitis. These are the 7 vaccine preventable diseases under the mission Indradhanush. Again, this is to improve your vaccination coverage in the kids. But the latest one is the mission Indradhanush 5.0. We had mission MI 1.0, mission Indradhanush 2.0. Like that, now it is 5. Here it is not 7 diseases. Actually, they are tackling 12 vaccine preventable diseases. Okay, it is not 7 now. That is a change there. So under regarding vaccination, we told about something else. What was this? Keep up, catch up, keep up and follow up campaign. Just a revision. This was for your measles, right? A mop-up strategy is for OPV. Now, this one, you see this logo also can be asked. Okay, what is this? This is the logo of your ICDS, Integrated Child Development Scheme, where you have all your Anganwadis. And ICDS does not come under the Ministry of Health and Family Welfare. It comes under the Ministry of Women and Child Development. Under ICDS, so this is the logo. ICDS, who are the beneficiaries? You should know. You have children, you have pregnant mothers, you have adolescent females. So that you should know what are the beneficiaries. Correctly, you should know. Then what are the services provided at Anganwadis? You have nutrition given, right? Then you have growth monitoring. See, only weight is measured in Anganwadis as of now. Height measurement is not started, but again, discussions are going on that height should also be measured. You have growth monitoring, then you have what? Informal or non-formal education for students, for children. So those who are less than, small children, they are given non-formal education at Anganwadis. Then you have clinics, basic treatment illnesses, they can, along with the PHC, they can organize clinics and all. Then immunization services are provided at Anganwadis. You should know the function of Anganwadis, okay? What is this? This is your midday meal scheme. This is a logo for a midday meal. See this? Students are sitting with their, looks like a, your plate, food plate. So this is a midday meal scheme. Now actually they have changed the name. Now the latest name is PM Poshan Shakti. It is not midday meal anymore. It is PM Poshan Shakti, okay? Now here you have NPHC. This is the, see here, so somebody is being assisted, right? This is an elderly person assisted by another person. So it is National Program for Healthcare of Elderly. This is also a not a much recent, but still a newer program. So under this program, you have many improvements, and one thing is Department of Geriatrics or Geriatric Medicine was started in AIMS. Okay. Then this is your Poshan Abhiyan. Okay. So you have different schemes for nutrition, right? You have your ICDS, you have your midday meal scheme. So everything, NEET Bharat, many things are there related to nutrition. So this is a Poshan Abhiyan, is it's an overarching scheme. It covers all these. So Poshan stands for PM's, Pradhan Mantri's or Prime Minister's overarching scheme for holistic nourishment. That is your Poshan Abhiyan. And this is the logo, okay? This is the logo for Poshan Abhiyan. Then you have something called Poshan Ma. That is, you celebrate 1 month for the September celebrated as, month for creating awareness on nutrition. Then this is your National Health Mission, NHM. Under NHM, you have NRHM, National Rural Health Mission, NUHM, which is your National Urban Health Mission. Then ASHA. Right? ASHA came with this NHM mission, National Health Mission, okay? Now you have two things in this slide. You have RKSK and RBSK. RKSK is Rashtriya Kishore Swasthya Karyakram. Who is Kishore? Kishore is adolescent, right? This is the program in India for adolescent health, Rashtriya Kishore Swasthya Karyakram. RBSK is BAL, Rashtriya Bal Swasthya Karyakram. BAL is a pediatrics, right? The children. So you have RKSK and RBSK. So under RKSK, you have many, things to improve the health of adolescent population. One among this is AFHCS, or the Adolescent Friendly Health Clinics. Okay, these came with this, RKSK. These are designated clinics exclusively for the adolescent population, where you deal with the adolescent area issues. So AFHCS or the adolescent friendly health clinics came under this RKSK or Rashtriya Kishore Swasthya Karyakram. This is the logo you see here. Now we have Rashtriya Bal Swasthya Karyakram or RBSK is mainly to detect any defects, deformities, disability, etc. in kids. And you have something called DEIC. This is the District Early Intervention Center. Now, if some child with a congenital deformity or defect, anything is detected, the child is referred to where DEICs. There are many DEICs established in the district. There is district early intervention so that you can give some early intervention for the child. So DEICs come under your RPSK. Now you have your Anemia Book Bharat. I told you six beneficiaries, 6 institutional mechanisms, and 6 interventions. We'll just see the 6 interventions in this slide, okay? What are the interventions? We are giving prophylactic IFA tablets, prophylactic iron and folic acid supplementation. Yes. Then what? Intensified year-round behavioral changed communication. So you have something called behavioral change communication, which ensures delayed cord clamping. Okay. So early in labor rooms, we were usually, once the baby is out, there was a rush to cut the cord. Now it has changed. It's not like that. You have to wait. There is no hurry and no cord clamping. You can go for delayed cord clamping. Okay, that is what is advised now. But there are situations where you have to go for immediate cord clamping, like RH negative pregnancy or RH immunization. Cases like that, you have to go for immediate cord clamping. But otherwise, in general, Anemia Book Bharat advises delayed cord clamping. Okay. Then what? Provision of iron and folic acid, fortified food. You have iron fortified rice and all coming up. This is also one intervention. Then you have deworming. Deworming is very important. What are the causes of iron deficiency anemia? The most common cause is nutritional. Second cause is worms. Okay, so deworming is very important. Deworming of children, adolescents, women, reproductive age group, pregnant women, everyone is dewormed. Then you have point of care testing of anemia and treatment. That is point of care. We have certain smaller devices like HemoQs and all are there. That is, you don't have to take the 5 ml blood and then send it for lab and nothing like that. Just give a prick and you will get your HP values. That is the point of care testing. So you're going to interventions to improve more point of care testing for anemia. And last one is you address the non-nutritional causes of anemia in endemic areas, especially areas with malaria and fluorosis. Okay, these are 2 of the non-nutritional causes of anemia. So these areas also you're giving specific interventions. So these are the 6 interventions under Anemia Book Bharat. Now, next program, what is this? Rashtriya Mansik Swasthya Karyakram. It is National Mental Health Program. Just you should know. See, this is the logo of your mental health program. Okay. Okay. Now, this slide, you have 3 confusing terms or programs. You have your Ujjwala, Ujjwala, and what? Ujjavala. This is also frequently asked question because you go wrong in this. This is actually confusing, right? Ujjala, Ujjwala, and Ujjavala. What is Ujjala? Ujjala is light. Ujjala is providing LED bulbs. That is, government is providing a free LED bulbs to everyone so that you can save energy. LED consumes lesser energy, right? So Ujjala is giving bulb, LED bulb. Ujjwala Yojana is actually you're supplying gas cylinders or you're giving the gas cylinders to women, BPL women mainly. This is one way to prevent which one? Your indoor air pollution can also be controlled, right? You're giving a better or clean fuel. That is the Ujjwala Yojana. Pradhan Mantri Ujjwala Yojana or Ujjwala. That is this one providing of this LPG cylinders comes under Ujjwala. Now, this was actually a previous year question. What is this Ujjavala? Ujjavala is a scheme to prevent trafficking, immoral trafficking of women and girls or rescue them from sex rackets and rehabilitate them, reintegrate them. All these comes under Ujjavala. So it's an effort to prevent trafficking of women and girls from commercial sex exploitation, as well as to rescue, rehabilitate, and reintegrate them. Rescue is there, rehabilitate is there, reintegrate is there. Okay. So once a question came, Ujjala has all of the following except the options were rescue, you rescue, rehabilitate, you rehabilitate, reintegrate, yes, Fourth option was remuneration. No, there is no money. There is no remuneration given to them. So that was the wrong answer in that case. So I hope Ujjwala, Ujjaval and Ujjwala are clear to you. Now, so that was about the National Health Program. Now, last few words about, SDG. You have the MDGs and the SDGs. What is the MDG and what is the SDG? See, MDGs are what? Your Millennium Development Goals. The MDGs are the Millennium Development Goals. These are a set of 8 goals. We had a set of 8 goals which we were supposed to achieve. The whole world was supposed to achieve these 8 goals before 2015. So it was time period was 2000 to 2015. So at 2000, in the year 2000, that is the year 2000 is called the millennium year, right? 2000 we had a set of 8 goals which we were supposed to achieve by 2015. So those were called the Millennium Development Goals, and you had goals like hunger, education, health and all those things. But we failed to achieve the MDGs. Then now we have what is called the SDGs. That is 2015 to 2030. This came in 2015. That is SDGs came in 2015. They are aiming. We have what 17 goals. It is not 8. You have 17 goals in SDG. The SDG goals, we'll see what are the SDG goals after a short break.
Okay, they do not have any
So welcome back. This is the last part of today's live session. So we have already discussed, we have revised the major topics, and you have to go back and learn these topics. Now we're going to end the class with the Sustainable Development Goals, okay? So I told you we had MDGs first from 2000 to 2015, and after that we couldn't achieve the most of the goals which I told in the MDGs. So after that we have this SDG or Sustainable Development Goals. That is from 2015 to 2030. We are aiming to achieve all these goals by 2030, and there are a total of 17 goals. And one question is, which is the goal related to health? Your health related goal is 3. Okay, so when I say 3.1, that means goal 3 and target 1. Okay, so under health related goal 3, you have certain targets. Okay, you have 9 plus 4. 13 targets are there under this health goal. So we are going to study all the 13 targets and major important points coming under this with the help of KGF. Okay, so we are going to the movie. So the KGF or any story as such start with the mother, right? The mother is given the primary importance. Only after mother comes the child, right? So your goal 3.1, that is first thing. Your goal we are discussing is health related goal in SDG, which is your goal 3. Okay, the target 3.1 or the first target is regarding maternal mortality rate. So remember the mother and KGFs. So our aim is to reduce the maternal mortality ratio. Okay. We are aiming to reduce the maternal mortality ratio to less than 70 per 1 lakh population by 2030. So that is your 3.1. Reduce maternal mortality ratio to less than 70 per 1 lakh by the year 2030. What is the current maternal mortality ratio of India? It is 97. So we have not reached there. So we have to bring it to less than 70. So first is the maternal mortality. So first comes the mother. So after the mother, she gives birth to the child. So for that, you remember the neonatal and child mortality. So mothers is over. Now we are coming to the neonatal and child mortality. Okay. So under this 3.2, we are aiming to reduce the neonatal mortality rate to less than 12 per 1,000 and the under 5 mortality to less than 25. Remember 12 and 25. So neonatal to less than 12 and under 5 to less than 25 per 1,000 live births. That is your goal in 3.2. That is to reduce the neonatal and child mortality rate. Again by 2030. So now coming to goal 3.3. 3.3 is dealing with infectious diseases. Okay. So there's a mother, then there's a child. So once the child is beginning to grow, the first thing, what is the first diseases the child gets, what the mother is concerned about? The child usually comes with pneumonia, diarrhea, all kind of infectious diseases, right? So our Rocky boy is having infectious diseases here. So that's how you remember the 3.3. In 3.3, we are aiming to end the epidemics of AIDS, TB, malaria and neglected tropical diseases by 2030. Okay, so that is 3.3. So after the infectious diseases, then comes your non-communicable diseases and your mental health. Okay, so 3.4 is the 3.4 target is regarding your non-communicable diseases and mental health. So we are aiming to decrease the premature mortality due to non-communicable diseases by 1/3. We're not half or we're not ending it. We can only reduce it. So the aim is to reduce premature mortality due to NCDs by 1/3 in 3.4. That is target 4 of goal 3. Okay. So 1, 2, 3, 4. First one, mother, maternal mortality. Second one, baby, neonatal and child mortality. Third one, once a child is born, first thing he gets is infectious diseases, right? Then comes the non-communicable diseases. So 3.3 and 3.4. Now coming to 3.5. So now your occupier is all grown up. So once he's grown up, because of peer pressure and all that, he starts all kind of abuse, alcohol, smoking, everything. So your 3.5 is to aiming at reducing the substance abuse. Okay, so 3.5, that is goal 3. Target 5 is to reduce the substance abuse. So after substance abuse comes your road traffic accidents. Obviously, if you go for substance abuse, the next thing you get is you go for all the road traffic accidents, you suffer from things like that. So 3.6 is road traffic accidents. Here you are aiming to reduce the death due to road traffic accidents by half the present number. That is by 2030 you have to reduce the number of deaths due to road traffic accidents by half compared to the data in 2015. Okay. Road traffic accidents, your timeline is not 2030, it is 2020. We couldn't achieve it. So all other things it is 2030, but for this thing it is 2020. Okay. So after that, so smoking is over, road traffic accident over. Now comes your heroine in the story. So here you are concerned with sexual and reproductive health. That is, you should have universal access to all the facilities for reproductive health services. Okay, that is your 3.7. Now you have 3.8. So Occupier is having all sort of injuries and all that. So you need health coverage. So 3.8 is mainly concerning with the universal health coverage. Every person should be able to access health coverage irrespective of the cost, or there should not be any catastrophic cost expenditure to them. So that is a universal health coverage is the 3.8. The last one, see, always smoking and creating issues. So he's causing such a lot of pollution and issues in the environment. So remember it like that. So 3.9 is regarding environmental health. That is, you're tackling the issues related to chemicals, air pollution, etc. in 3.9. So these are the main 9 targets under goal 3. Once again, 3.1, you start your story with the mother, maternal mortality. What is the number? Less than 70 per 1 lakh. 3.2, neonatal and child mortality, 12 and 25. Remember the numbers. 3.3 infectious diseases, AIDS, TB, malaria, NTDs. 3.4 non-communicable diseases, decreasing the premature mortality by 1/3. 3.5 substance abuse. 3.6 after substance abuse comes the road traffic accidents. 3.7 is sexual and reproductive health. 8 health coverage. 9 is environmental health. Okay, I hope now STGs are clear to you. With this, we are concluding today's live session. Thank you for listening. Bye, and all the best for your exams.